Mm. Harshad, can you hear me?
Hi, John.
Hey, Harshad, how you doing?
I'm fine. How are you?
So you got it. You got in there, obviously.
Yes, I'm getting in.
Harshad, can you hear me?
Yeah.
Okay, let me turn. I gotta turn off this other computer.
How long it is going to take to start?
It's going to start in 15 minutes.
15 minutes. Okay.
Yeah.
How are you, Dr. Arshad?
I'm fine. How are you?
I'm fine. How are you?
I just
Thank
saw
you very
you
much
earlier also. Yeah.
See to meet you today. Very fine.
Yes. The program seems to be very good. Very learning.
Sam did it.
Sam did it. Yeah. Sam always does it.
Yeah, he did good job.
Good job. Very
yeah.
hardworking. Very hardworking.
Yes. It takes. I don't know if you've ever put a conference together, Harshad.
Yeah.
Yeah, it's a lot of emails, follow-up emails.
Yes, absolutely.
Changing schedules.
Yeah. And contacting the people, putting on a WhatsApp chats and everywhere.
Yeah, contacting them. Although it's getting easier now to contact people with improvements in knowledge and digital literacy.
Yes.
And being around conferences, people kind of get into.
Yeah.
So, and I've just told a student from Pakistan, she runs a Walter Dandy group.
The Dr. Noor, if I'm not mistaken, Dr. Noor.
Yeah, I don't know who's going to speak there tonight, but I can't televise. I'm doing this one, but they have hundreds. They have 200 or 300 students in that group.
Oh, wow.
So I told her, I said, you can get anybody you want because it's a name like Walter Dandy. It's a brand name. It's not Sean Bennett or Harshad Parekh. It's Walter Dandy.
Correct.
So just pick your speaker and they'll probably say yes.
Yes. And very good speakers nowadays. Very good speakers.
Yes.
They all are very educative and they teach us very well. And everyone learns from their experiences and our own thoughts.
Sure. From the whole world. From the whole world we can learn from. And you know, Harshad, I think because I interviewed some people at a live conference from Bogota, the big neurosurgery conference there.
Okay.
Yeah, and Victor was there, and so
Victor was there.
I had a phone call with him, a video chat with him live, and he was interviewing people. I just get the feeling that I think people, when they go back to the conferences, sure, they like meeting everyone and stuff like that. But I think they're going to say, you know what? All these problems I went through to get here, the flight, the hotel.
Yes, it's all.
I don't think they're going to be as popular.
No, it's not going to be popular. You see, it's a bit better to be virtual rather than physical.
I think it's going to erode the attendance. I think having Zoom is going to bring it down, the attendance at live conferences. And they're going to have to have some kind of online option for conferences.
Yes. And even if they want physical, they should have both media, virtual and physical, both. Because, you know, there are many people like me who cannot manage to go out and attend every conference and listen to everybody. And in a shorter period of time, this is the best way to do it, according to me.
Yes.
And you are doing wonderful, John. You are doing wonderful.
Yes.
And by giving,
the demand is there. I'm just satisfying the demand. But I think that you're going to see the demographics of attendance change. And it was well attended, Bogota. Not full, pretty well attended. I was kind of surprised. But I think I really think that people will come back and they'll weigh it and be more objective about it. You know, to travel to see, you know, a long way to see your friends.
Yes, yes,
You can see them online.
yes.
Not as good, but what the heck. So I'll be back.
And it does that. So that we are missing. Otherwise, wonderful, wonderful. You are doing a great job. And I always admire you. When do you sleep? I don't know when do you sleep. I see always you are.
During the day. Okay, I'll be back, Harshad. I gotta do some stuff.
Shall
Okay?
see you, John.
Okay. Welcome, Igor. Oop. Hello, Igor.
How are you, Dr. Igor?
Hi, Igor. Where are you from? Okay, let me change this background because. Hello, everybody. How you doing? We're not on the. Well, we're actually on YouTube. So be careful what you say. Hello, that sounds like Rose, right? Oh, that's Zanab. How you doing?
Thank you, sir. How are you?
Good, good. It's the connection is not too good, so it's hard to hear what you're saying. Igor, can you hear me okay?
Yes, okay.
Okay, okay. Okay, Sam, you there?
Yes, I am here.
Okay, good, good. Are you ready for action?
How are you, Dr. سامح؟
How are you, Dr.
كيف
Amar?
مصر؟ الله يخليك يحفظك. تسلم الله يخليك.
Alhamdulillah.
Harshad is here too.
Hi, Sam. How are you?
Hi, Hashim. How are you?
Everyone's waiting for Sam.
We were waiting for you. Your hard work is going to be seen today. I must compliment you for your hard work.
It's going to be worth it. It's going to be worth it, Sam.
Yeah.
Thank you.
Great, great. Looking forward.
Okay, who's the first speaker, Sam?
Abida.
Oh, okay. Good, good.
Hi,
He's
John.
here.
Hey, how you
Hi,
doing,
Abby.
Vida?
Hi, Same.
Abida, how are you,
Hi,
Dr.
hi,
Abida?
I'm fine. How are you?
Thank you. I'm fine. Thank you very much for you.
And Harshad's here too.
Hi,
already.
Dr. Arshad. How are you?
Hi, Abida. How are you?
Fine, sir.
Looking fresh, huh? As ever. Ready to demolish, like Atul says.
Yeah.
Great, great. Looking forward.
Yes, sir. Thank you.
I removed my pen there. I'm hogging the screen, Abby. I like it. Say hello to Zainab from Guinea in Africa. Abby, her connection's not that good.
Hi, Zanab.
Yeah, I don't think you can hear. Zainab, are you there? Oh, okay. Yeah, she can hardly speak. We can't hear you, Zainab, but thanks for coming. Okay, Sam, I gotta make you co-host, right? Okay. You know how to admit people, right, Sam? Sam, you know how to admit people, right?
What?
You know how to bring people in to make a panelist. You know how to do that, right?
I will. We will start now.
Okay, we got 3 minutes, Sam. Okay.
I will talk for just 2 minutes.
Oh, okay. You want to start then? Okay, that's fine.
Okay.
Okay.
Hang on, John. I'm just getting my presentation ready. Just hang on a minute.
Yeah. Okay. Yeah. Just hang on, Sam.
Okay, we can start now.
Okay. Abby's still getting her presentation straightened away, Sam. Okay. Okay. We'll start, Sam, and Abby can fix it while you're talking. Okay.
Yeah, it's
Okay.
just not opening. Just give me a minute.
Yeah. Okay. That's okay, Abby. There's only 100,000 people waiting. No, not really. 12 guys in the barber shop.
Hello,
Hi, Dr.
John.
Ben.
Hello.
Oh, Ben, how you doing?
Hi,
Welcome.
Hassan.
Welcome.
Hi.
I'm fine. Thank you.
Hello, Shine.
Ben, what's going on in China with Omicron?
Yeah. It's we control it very strictly,
Oh, okay.
but
Good.
everything is good, I think.
Good.
Yeah.
Very good. Very good. They have a good record.
Yeah.
So,
How are you, Dr. Ben? Dr. Omar, with you. Syria.
Omar from Syria, Dr. Ben.
Okay, John, I'm done. I'm ready.
Hi, nice to meet
Okay.
you. Hi.
Okay, you ready? Here you go, Sam.
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have another great conference arranged by Sam El-Morsi of Cairo, and I'll immediately turn it over to Sam. Good day, Sam.
Good day, John. Dear friends and brothers, welcome all to EWNC Academy 6th annual meeting. This session aims to orient all of us about recent advances in surgical management of brain lesions. In March 2016, we have started these activities of this academy. So far, we have reached the best numbers in every activity that we have done. Best teaching innovative methods. For every minute in past 6 years, we have reached the top and further more than the top. Our voice is reaching every neurosurgeon and spine surgeon in the world. We have changed the minds about how to deal with different lesions and diseases which are facing us every day. Also, we have deal with rare cases that we just hear about it. Our road is still in the beginning. Also, we have reached a lot of our colleagues in real world, and we will reach more by our in-person activities, which will be our target in the future. From that point, we have announced about choosing ambassadors in every part of the world to start these in-person activities. Mission of every ambassador is to revise the applications of joining EWNC groups from his country and to make at least 2 in-person activities in this country under auspices of EWNC. So far, we have 15 proposals, and we will still receiving more. We will announce about them once we get suitable number to start by. Now we will start our session by lecture of my dear friend Abida Shah. Dear Professor, it's over to you. Thank you.
Thank you, Sam. And as usual, I'm opening your conference with this presentation. Can you see my screen?
Yes.
Okay.
Okay. So today I'm going to talk on origin, development, and spread of gliomas and its surgical implications. It is an alternative concept based on our ideas of white fibers of the brain. So for everyone, all of us, we are performing glioma surgery. And to do glioma surgery, we all know that both the cortical and subcortical anatomy is most important. You have to understand both. As far as the recent times, everyone is aware with the cortical anatomy. It is the subcortical anatomy that perplexes everyone. So we published this paper where we defined the architecture of the white fibers of the brain. And we gave this classification to these white fibers by understanding the direction and depth of the fibers. And this architectural organization of the fibers helps you to understand how it is arranged in the brain. So imagine the white fibers of the brain as 5 layers. There are 4 horizontal layers and 1 vertical layer. So this is from the medial aspect of the brain. This is from the lateral aspect of the brain. The first horizontal layer is the superficial group or that of the short association fibers. So you can see this yellow circle here, and here you can see these fibers that my arrow is pointing. These are the U fibers or the short association fibers or the superficial group. The middle group consists of the SLF, the arcuate fasciculus, the middle longitudinal fasciculus, the uncinate, the IFOF, and components of the sagittal stratum. So on the lateral hemisphere, this is how we see it. This is the SLF, this is the arcuate, this is the uncinate, this is the IFOF. Beneath that is some fibers of the anterior commissure, and more posterior to that will be the optic radiation. This fiber down here is the inferior longitudinal fasciculus, and this fiber bundle going up is the middle longitudinal fasciculus. Similarly, on the medial side, these constitute of the SLF1, that is the middle part of the SLF that comes in this layer, and also the cingulum, which you can see in this region over here. The deep group are those fibers that are arranged, that are associated with the ventricle, and most of them are C-shaped. As you can see here, the fornix, the stria terminalis, as it runs between the thalamus and the caudate, the stria medullaris thalami, as it runs on the surface of the thalamus, connecting the frontal regions, septal regions to the habenular nuclei, and the medial and longitudinal striae as they run above the corpus callosum. The middle group is the central group. So you see in this image here. Now I showed you the lateral fibers here, and I showed you the medial fibers here. Now this group in the middle is that of the commissural fibers, which consist of the corpus callosum, the posterior commissure, the habenular commissure, and the hippocampal commissure. So these remain strictly in the midline. They do not cross the vertical group, whereas the anterior commissure from beneath passes the vertical group of fibers. And the vertical group here is the projection fibers. So you see here, as you can see in this image, the projection fibers divides the white fibers of the brain into a lateral part and a medial part. And it is very important to remember that these fibers do not cross. A fiber which is running from anterior to posterior medial to the vertical group will never go lateral to it. Similarly, like the arcuate fasciculus or the SLF2, it will always be running lateral to the internal capsule. It will never go medial to it. So this is just a basic understanding of the subcortical anatomy. Now, how do we associate this with gliomas? Now, as you know, that there are 100 billion neurons in the human brain. Earlier, it was thought that there are 1 trillion glial cells. But recently, it has been noted that the ratio of glial cells to neurons is 1:1 or a little less than 1:1. And it is not that they are without function. As you can see in this table, a lot of them have functions. And if you notice another thing, it is these glial cells that have more propensity to form tumors. And it is the tumors of these glial cells that are more malignant than the neuronal tumors. Now, what about the origin of gliomas? We've heard talk so much about gliomas, how to operate, whether to operate, low-grade gliomas, high-grade gliomas, but how much do we hear about origin of gliomas? So this was Yasser Gill's initial concept, that the gliomas grow towards the ventricle. They follow the segmental vascular pathway, and they follow the embryological glial pathway that was used for migration. And he believed that all of them ultimately lead to the ventricle. And the location of his gliomas were either subcortical, subgyral, lobar. In the corpus callosum, which he found were rare, but we've got plenty of corpus callosum gliomas and otherwise gliomas of the limbic system. More recently, evidence has suggested, as you can see in this paper, that gliomas may arise from neural stem cells. Where are these neural stem cells? They are found in the subventricular zone around the walls of the lateral ventricle. They are found in the dentate gyrus or the subgranular zone in the region of the hippocampus, and they are also found subcortically. So these areas, like you can see in this, subcortical white matter has a lot of these neural progenitor cells. So you can see here, neural stem cells, which are multipotent and renewing, have been isolated from the subventricular zone, the lining of the ventricles, the dentate gyrus within the hippocampus, and the cortical white matter. How is this important to us? If you go embryologically on glial migration, so I'm not going to go into the details, but this is the ventricular zone and this is the cortical mantle. So from the subventricular zone, the glials, they either reach the cortex by the radial pathway or the tangential pathway, and then they ultimately rest in the subcortical region. And most of the time, majority of the time, they lose this connection with the ventricle. So you have a glial progenitor cell or a neural stem cell that has arisen from the subventricular zone and it has gone to the subcortical region and lost its connection with the ventricle. So you can see here the neural stem cell can give rise to a neural progenitor or a glial progenitor, and the glial progenitor with transformation or maturation arrest can give rise to either a low or a high grade glioma. Now, based on this understanding and the architecture of white fibers, we propose a new philosophy that gliomas, they arise from a named white matter tract and they displace the adjoining normal white fiber tracts. Now, how do I come to this conclusion? How do we come to this conclusion? Before that, I will just show you that we divided gliomas into two groups. This was the localized group of gliomas. These gliomas arise from the short arcuate fibers. As you can understand, short arcuate fibers are the ones that are present around the gyrus and enclose the gyrus, and the localized glioma arises from these fibers. Whereas the diffuse glioma can arise from the long association fibers or from the commissural fibers. When it arises from the long association fibers, you will see that it classically follows the trajectory of the long association fibers. So this is a tumor of the cingulum, and you can see that it follows the path of the cingulum into the parietal cortex. You can see these glioma cells, and I'm going to show you various images that will make this concept clear. Whereas in a corpus callosal glioma, most of them tend to be bilateral. They may either come from the forceps minor or the forceps major, or from the body and various parts of the corpus callosum and its connections, but they always tend to be bilateral. That is how you differentiate the commissural group of fibers or the corpus callosal gliomas from those of the cingulum. So based on this understanding, this is the paper that we published, and I will show you how we came to this conclusion. Now you see this tumor. This tumor is in the region of the superior frontal gyrus. It is arising from the short arcuate fibers in the region of the superior frontal gyrus. It displaces all the other fibers. So this is the SLF1. It is displacing it posteriorly. This is the internal capsule. It is displacing it posteriorly. And these are the other fibers that are displaced inferiorly. Similarly, this is a tumor just in the premotor cortex. This is a malignant tumor, and you can see how it has displaced the other fibers. Here, of course, because it is quite small, you don't see the displacement quite actively. Now you see this tumor. It is a tumor in the region of the post-central gyrus. So short arcuate fibers of the post-central gyrus are involved, and it is pushing the projection fibers or the vertical group of fibers anteriorly. So this is the region of your tumor, and it has pushed the fibers anteriorly. Now this is again a high-grade tumor in the region of the supramarginal gyrus. Now you understand the subcortical anatomy. So the supramarginal gyrus is here. What are the tracts that will be around it? So there will be the arcuate that will be running around it, but medial to it. Similarly, all the other fibers, the IFOF, will be inferior to this tumor. The fibers of the sagittal stratum, that is the IFOF, the anterior commissure, and the optic radiations will all be medial to the tumor. So this tumor can be safely resected without causing any injury to these fiber bundles, as you can see in this image here. So you can see this is the arcuate fasciculus, this is the uncinate, this is the IFOF. These are some fibers of the internal capsule. And in this image, this is the region of your tumor, which is superior to all the other fibers. Similarly, going ahead, now this is a tumor arising from the short arcuate fibers of the superior parietal lobule. So you can see this is the location of the tumor in this region. And all the other fibers, like fibers of the arcuate, fibers of the IFOF, they're all lateral to the tumor. So the best way to approach this tumor would be medially, because there is no fiber bundle that will come in the way medially. So this, again, subcortical anatomy is important for that. This is a tumor in the region of the inferior temporal gyrus. Now, this is a very safe tumor to resect because the only fiber that will come across your way is the inferior longitudinal fasciculus, which in this case is displaced superiorly. And all the other tracts are medial to this. So now you can understand that all these localized tumors are rising from short arcuate fibers confined to a particular gyrus. And that gives you the idea where the gyrus is and how to resect the tumor. So this is a tumor in the region of the parahippocampal gyrus. And you can see all the fibers are displaced superior to it, giving you a safe entry right in the center here, going in from the inferior or the middle temporal gyrus to resect the tumor. This is a tumor that is more eloquent in the region of the frontal operculum or in the region of the pars opercularis. But you see that the functional areas are displaced superiorly. Tractography and anatomically, you understand that the fibers are pushed medially by the tumor. So if you enter the tumor in this direction and remove it, you'll be able to perform a resection. Now, these were tumors from the short arcuate fibers. Now you see the pattern of this glioma. So you see anatomically, this is the cingulum. The cingulum has a connection to the parietal cortex. Now you look at this tumor. It is arising from superior to the corpus callosum here and following the course of the cingulum fibers to the parietal cortex. You can see that it is unilateral. It has not gone to the opposite side, as you can see even in this coronal image. You can see that it is medial to the internal capsule or the corona radiata. It will never cross to this side, and it is basically arising from the cingulum. Now look at this tumor, a low-grade tumor that is present in the frontal and the temporal pole. Now, which fiber bundle is this associated with? You see this, the uncinate fasciculus, arising from the inferior frontal and going up to the temporal pole. Classically, it is following the trajectory of this uncinate fasciculus. As you can see even in this image, fibers of the uncinate arise from the frontal orbit of frontal cortex and go towards the temporal lobe. So this is a glioma of the uncinate fasciculus. Look at this one. This is having a frontal extension and a temporal extension. Which fiber bundle do we know goes like this? The IFOF, coming from the frontal and going to the temporal. This is a tumor not purely of the insula. Of course, it's an insular tumor, but a type of insular tumor where it is arising from the IFOF. So now these are some various types of tumors that I've shown you that grow along the fiber tracks. Now, how does this apply to us surgically? So this is an image of the brain with showing you all the short arcuate connections of the hemisphere. And if you see this 7 Tesla MRI picture, you can see how innumerable they are. Now, these gliomas of the short arcuate fasciculus, they remain confined to the gyrus that they've come from. Like suppose they come from the inferior frontal gyrus. They will either remain confined here, or if they spread, they will spread along this short arcuate connection to the next gyrus. So from the inferior frontal, when it grows further, it will go against this connection to the next gyrus. That is another important, that is how the tumor that may not be remaining to one gyrus may be seen in the other gyrus. It is going through the short arcuate fasciculus. So now, keeping this localized arrangement of the glioma in consideration, Professor Goyal and myself, we have proposed this strategy. Is en masse tumor resection a safe surgical strategy for low-grade gliomas? Now, over the years, we have even applied this surgical strategy for high-grade gliomas and with very good results. Now, I'm going to show you some examples of the same. So you see this tumor. Where is this tumor? This is the supplementary motor area. So this is the central sulcus, this is the precentral gyrus, postcentral gyrus, and this region of the superior frontal gyrus that is just in front of the precentral gyrus is the supplementary motor area. And posteriorly, the fibers of the internal capsule are pushed. So this is localized to the short arcuate fibers of the gyrus, superior frontal gyrus. Now you see the tumor dissection. So initially we were using monitoring in all our cases. We used to perform awake in majority of our patients. We used to use neuronavigation. We used to use sonography. We used to do tractography in all these patients. But now the need for neuromonitoring has reduced. The need for navigation has reduced. The need for tractography has reduced. Of course, we do perform a tractography just to confirm our findings. But if you have an anatomical understanding of the tumor, you don't even need tractography. Now you see this tumor. You can clearly identify it differently from the surrounding cortex. Now, what we normally do is we use a sonography probe. So we place a probe in this region and we confirm the margins of the tumor, although we are very certain because of the anatomical extent, but just as a confirmation, we sometimes use sonography, identify the margins of the tumor, and then form an en masse resection, as you can see in this video, that is going all around the tumor, and a complete, like a meningioma, basically like a pseudocapsule plane is being formed around the tumor, as Professor Goyal likes to call it, and the tumor is being resected. So you can see that this can be done in a relatively quicker time. It can be done in a relatively avascular plane, and we are able to perform a very good radical resection of the tumor, as I will show you in the images. Now, the motor pathways were being monitored in this patient. There was no derangement of the motor signals, but as it is in the tumor in the SMA supplementary motor area, the patient did develop a supplementary motor syndrome after surgery, but immediately recovered within the next 15 days without any problem. So you see this is the surgical strategy, an en masse surgical resection. Once you get used to this style of surgery, you are able to identify the tumor from its consistency, from its visual appearance, and you are able to get a fair idea. This is a very, very consistent plane of resection that you can form. Mind you, it is not a sulcal to sulcal resection. It is a resection of the tumor that is around the margins of the tumor, and a radical resection is being achieved. So I'll just move ahead. Now you can see that the whole tumor is being removed here without the need of any coagulation. And with this technique, you can avoid using a lot of bipolar because the vessels are being pushed away and we are able to safeguard it without causing any problem, which is the main problem for deficits in glioma surgery. And here you can see the resection. This is the post-operative image showing the radical resection. And this is the MEP showing that the motor pathways are completely normal. And you can see the specimen here in this image. Again, similarly for a tumor right in the precentral gyrus. So now you understand that the fibers are pushed posteriorly and a little bit laterally. Once you understand this, you go around the tumor and you resect it completely. You keep in mind the eloquent areas of the brain. So this is the supplementary motor area. This is the hand motor activation area. And this is the dorsal premotor area. You have to know this anatomy beautifully. You have to know the subcortical anatomy beautifully. I'm not going to show this whole video because we don't have that much time. And you can see here by the visual impression, you can make out that this tumor is different from its color. And once you start resecting from its consistency, you can make out that it is different. And you can form a plane around the whole tumor and resect it completely, as you can see in this image. This makes you avoid the need for use of bipolar. It gives you a good plane of resection. And you can see this gyrus here is actually the precentral gyrus, and which is actually had been displaced and it is now preserved beautifully. And this is the cavity of the resection. And this is the patient in the immediate post-operative period. You can see the radicality of resection. You can see the specimen. You can see the patient doing well. So now just to show you how it looks on sonography. So this is again another tumor in the middle frontal gyrus, short arcuate fibers, which is close to the precentral gyrus. As we know that this is the dorsal motor activation area. And you see this image, typical low-grade glioma. This is how it looks on sonography. You can see the cellularity in this region. This is the normal cortex, and this is the region of the glioma. Once you do sonography, you'll be able to identify this more easily. And this is the cavity after resection. You can see that it has been completely resected. And you can see post-op MRI showing a radical complete excision. So just a few images, even in eloquent areas, again, another in the supplementary motor area, using this strategy, radically resected. Another tumor in an eloquent location, radically resected. This is again another tumor, and you can see how the functional area is displaced posteriorly. All the tracts are displaced around the tumor. It is a tumor arising from the short arcuate fibers. It is displacing the long association fibers. It is displacing all the other fibers, and you can go in and perform a radical resection. This is again another tumor that was going right up to the corpus callosum. Some of them do maintain this connection with the ventricle, and you can see the cavity and the whole, because in this same plane, this whole tumor was resected, going right up to the corpus callosum. Again, a tumor in another eloquent region, premotor and in the inferior frontal gyrus, which you can see has been radically resected. Okay, so this is a tumor. This is the region of the supramarginal gyrus, where you can see this tumor I had shown you earlier in the superior parietal lobule, which has been resected. So I'll just go further. These are all tumors from the short arcuate fibers, and you can see that they're resected very radically and beautifully without any problem. Now let's go further. This is again another sonography image. You can see this tumor in this image, and here this is the post-op resection cavity, and you can see in this image also the resection. So these are all the tumors of the short arcuate fibers, or the localized group of fibers, which we can perform an en masse surgical resection. Now coming to the insula. The insula harbors both kinds of fibers. So this is the image of the insula and its relation to the ventricle. Once you open the opercula or the curtains, you see the short and long gyri. Now just beneath this short and long gyri are the fibers of the extreme capsule and the claustrocortical fibers. So these are the fibers that harbor, these are the fibers which give rise to the localized group of tumors of the insula, and the fibers in proximity to the insula or in close association to the insula give rise to the diffuse type of tumors of the insula. So you have fibers from the arcuate, fibers from the IFOF, and gliomas coming from the uncinate. These are all the tumors that form the diffuse group. So this is just an image showing the arcuate fasciculus lift up. This is the sagittal stratum with the IFOF and fibers of the optic radiation. This is the uncinate. This is the arcuate. This is the SLF. This is the whole arcuate lifted, and you can see the optic radiation. And this is the entire internal capsule, the anterior limb, genu, posterior limb, the optic radiations, and the acoustic radiations. So these are high definition tractographic images showing the fibers, the arcuate, and the yellow one is the IFOF, and this is the MLF fiber as it is running from anterior to posterior. So coming to insular gliomas, this is just a perisylvian glioma, which is superficial to the insula. It is just around the sylvian fissure. All the fibers are displaced medially, and you can perform a radical resection. This is again a high-grade tumor in the perisylvian region, and you can see that a radical resection can be obtained. Now, insular tumors can be of two types: short localized fibers, localized gliomas that arise from either the operculum or the short gyri. So this is a tumor that is arising from the inferior frontal gyrus or the pars opercularis. You see the eloquent nature of this. It is exactly in this location, or as you would call the motor speech area. I'm not going to go into this, but you can see that an en masse resection has been performed here by identifying the glioma. You can see visually that it is different from the normal brain. You can clearly see the color difference here. And when you do more and more cases, you will identify it more beautifully. And in this speech area, because the patient was not even cooperative for awake surgery, we had to perform under general anesthesia. And you can see with the same strategy, we have removed the tumor completely. And you will see the patient in the post-operative period, he's able to speak. Just a little dysarthria, but he's actually able to sleep. This is on the second day, and there is no problem with the patient. So moving on, these are the tumors that are the localized group of tumors of the insula, or those from the short arcuate fibers. So this is a localized tumor that is, we have approached through a transsylvian approach, and you can see the tumor resection. Again, another localized tumor of the short arcuate fibers, where we have done a good resection. In tumors of the insula, you don't have to go for an en masse resection because of the eloquence of the region and because of the presence of multiple blood vessels. I'm not going to go in this video, but this is a small technique that I had used to remove these tumors. And here you can see again tumors of the insula from the short arcuate fibers of the insula and the post-operative cavity. So this one is a tumor of the uncinate fasciculus. As you can see, going to the frontal and temporal region, you can see the fibers that are displaced towards it superiorly and laterally. And again, a good resection has been achieved. For a diffuse group of gliomas, majority of the component can be removed en masse, but otherwise some part of it has to be removed piecemeal. And this is the post-op resection cavity. This is another tumor that is arising from the uncinate fasciculus, and you can see the post-operative cavity. Another tumor that is arising from the higher grade tumor of the insula, and this is the post-operative resection that has been performed. This is another tumor of the uncinate going frontal and temporal, and you can see the resection that has been performed. This is a tumor of the arcuate fasciculus. You see, it is not localized just to the insular gyri. It is going around it. It's actually following the course of the arcuate fasciculus. And this tumor was also resected maximally. And this is the image after the resection. Now see this diffuse group. This is from the middle part of the SLF. You see this glioma here. And you can actually see how it is spreading across the SLF in this image. And again, a radical resection was performed in this case. Coming to the limbic system, shortly, I will just show you. Sam, just give me 5-6 minutes more. So this is the cingulum. This is the actually the Pappage circuit. This is the hippocampus. This is the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of the thalamus, the anterior thalamic radiation, and the cingulum, which is coming back to the hippocampus, forming the Pappage circuit. And this is the Pappage circuit that we have dissected outside. And this is the paper we published. So Pappage, to understand the spread of gliomas of the limbic system, you have to understand that there is a supracallosal pathways and there are infracallosal pathways that connect the limbic areas. And you have to understand the spread of gliomas by understanding these pathways. So this is, as I showed you earlier, tumor of the cingulum, which has been resected by an interhemispheric approach. This is another tumor in the region of the isthmus of the cingulum. You can see this is the cingulum and the isthmus of the cingulum. Again, why cingulum, not corpus callosum? Because it is unilateral. And the approach is interhemispheric with the use of navigation, and a radical resection has been performed. This is another tumor of the parahippocampal gyrus. So this is lying medially here. All the fibers are displaced superiorly, and you can enter from here, as you can see, the inferior temporal gyrus, and it forms a safe trajectory to resect these tumors. This is just to show the trajectory. You see this IFOF, this is the temporal horn region here. You see the head of the hippocampus in this region. When you turn the specimen, you see that there is an area here in the region of the hippocampus, which is free of any optic radiations or any fibers of the IFOF. And when you enter in this region, you are able to reach the temporal horn and then form a beautiful resection. So this is our approach that we use through the middle temporal gyrus. And it was first described by Professor Goel. And we use this, you can see this is the hippocampus, and this whole thing is resected here along with the parahippocampal gyrus and the tumor in this location. And you see that the optic radiations are quite superior and safe if you enter from this trajectory. and then you remain beneath the roof of the temporal horn in this region. So this was the paper on the subject. These are just a few examples of the tumor of the parahippocampal gyrus resected using this approach. You can see a beautiful radical resection with safeguarding of the structures has been performed. And lastly, the corpus callosal fibers. As I've told you earlier, they go bilateral. So this is a recent paper on fibers of the corpus callosum. So we have divided it into dorsal radiations and ventral radiations, as you can see in this image. So this purple one here are the dorsal radiations. This and orange one here are the anterior radiation or the forceps minor. The yellow one is the forceps major or the posterior radiation. These are the ventral callosal radiation, or posteriorly they are known as the tapetum. And anteriorly, these are fibers that connect the corpus callosum to the basal ganglia. This is the anterior part of the ventral callosal radiation. And this is how closely related they are to the IFOF. And basically, the corpus callosum connects to all regions of the brain. And this is our paper. And this is based on our paper. We have performed surgery on these tumors with a radical resection. So this is not a bizarre tumor of the corpus callosum. It is involving the fibers of the forceps major, and it is also involving fibers of the tapetum. And that is why it is looking like this. This is the tractography image, but you understand the location, you understand the anatomy, and you can perform a radical resection. This is a tumor of the forceps minor that I've recently operated, and you can see radical resection has been achieved in this patient. This is again a tumor of the forceps minor going on both sides, and a radical resection has been achieved. This is a tumor of the forceps major. This I could only remove from this side. This side of the tumor is still remaining, but the patient is doing well. So I have not attempted a resection on this side yet. So to end this is just a tumor approach to the caudate head that we have described earlier. And this is our trajectory to approach lesions in the region of the caudate head. These are fibers that I will have to discuss in another lecture. It will be too much for this lecture. And this is a tumor in the caudate head by a lateral trajectory that has been operated. And we have also studied on the brainstem, but that is not a part of this lecture. So thank you very much for this opportunity.
Okay, Sam?
Ari, for this excellent presentation. Is there any question from panelists? Okay, thank you, Ari. Well, we will shift to next speaker, Professor Binzu. Please start your lecture. Thank you.
Okay, thank you, Chairman. And so my topic is cerebral revascularization in recurrent nasopharyngeal carcinoma. So the recurrent nasopharyngeal carcinoma is a very dangerous disease. You can see only the 3 years survival rate without ICA invasion, only 65.1%. But most of the ICA can be invaded by the carcinoma. If you don't treat, don't do the cerebral revascularization and the resection of the carcinoma. So there's only 16% patient can get 3 years survival rate. But if we do the cerebral revascularization combined ICA embolization and the combined resection of the carcinoma, until now we get the 100% 3 years survival rate. Most of this kind of patient can be died of the rupture of the ICA. So we have to do the revascularization for this kind of patient. So you can see this is a saphenous vein to ECA SV to M2 segment bypass. So only this one bypass, you can see we can replace the whole hemisphere, even the contralateral frontal lobe revascularization. So this is the treatment of skull-based tumor invading carotid artery. Sometimes if if the ENT doctors removing the carcinoma, they sometimes hurt the ICA and get the rupture of the ICA. So we can direct repair this kind of ICA, use covered stent. If we do the planned cerebral revascularization, so we can use the blood flow replacement bypass. The high flow bypass is ECA saphenous vein to M2 bypass. Medium flow is ECA radial artery to M2 or M3 bypass. Low flow means STA. Normally we do the double bypass to M3, M4. Then we use direct occlusion of the ICA. Sometimes we use assisted method using the progressive occlusion of ICA. This can promote the blood flow of bypass and can be combined with different bypass method. So this is a direct repairment of the ICA. This is a interrupted. This is a ruptured ICA intraoperatively. You can see this is a aneurysm raised from the ICA, and this is a pseudoaneurysm intraoperatively. It's ruptured. You can see, and we use a covered stent to repair it immediately. So this is after the repairment. So this is how we do the cerebral revascularization. Donor vessels, we can use radial artery, even bigger saphenous vein, and the smaller one, superficial temporal arteries. We should make the tailored bypass for ICA invaded by malignant tumor. At first, we should estimate the natural collateral blood flow, guarantee enough blood flow replacement. So before we did the bypass, the ICA would be use balloon occlusion test for 30 minutes. If the patient can tolerate the BOT, we will use enhanced BOT, which means the blood pressure decreased 30%. If the patient can tolerate it very well, this kind of ICA can occluded directly and without further treatment. But most of the patient couldn't tolerate the blood pressure decreasement. So we still need the STA, MCA double bypass. If the patient couldn't tolerate 30 minutes balloon occlusion test, so we have to make the blood flow replacement plan. If the patient is a male, normally the STA is quite large, larger than 1.2 millimeter. So this kind of patient double bypass can be replaced whole MCA territory. But if the patient is a female, we should still combine with the radial artery graft. If the ICA only feeded the same side hemisphere, which means MCA combined with ACA territory, so this kind of patient, we should use radial artery as a graft. If the patient's ICA invaded supplies it's a dominant side, which means not only feeded the same side hemisphere, but also the contralateral ACA territory. So this kind of patient, we should use the saphenous vein as a graft. Sometimes, if the double side ICA was all invaded, so this kind of patient, we will use saphenous vein combined double barrel STA bypass. So this is I call it a maximum flow bypass. So both ICA were invaded. You can see this is a tumor, and both ICA was invaded by the tumor. Before the surgery, we did the both side BOT. We can see the ACOM is quite good. So I use ECA saphenous vein to M2 stoma. This is a saphenous vein to ECA stoma. This is a MCA, M2 segment. I combined with the double STA to M4 segment bypass. You can see this is after the both side ICA occluded. So the blood flow, the bypass not only feeded the same side hemisphere, but also the contralateral side. So this is a right hemisphere. Also got some collateral blood flow from posterior circulation from PCAM. The second type is a high flow bypass, which means replace the blood flow of one side ACA combined with the MCA territory. So this kind of patient, we also use saphenous vein as a graft. You can see after the bypass, we directly occluded the ICA. This is the intraoperatively, we did the intraoperative DSA. You can see the blood flow replace the whole hemisphere's blood supply. Then the third type is a medium flow bypass. Normally, we use the radial artery as a graft. You can see this is a radial artery. Radial artery normally can supply the MCA by the MCA territory. If you combine with the STA, can feed it the whole hemisphere. So this is a video. This is M2 segment. Use a 9-0 pruning suture. The first knot is a surgical knot because there's some tension between the donor and the recipient artery. The first knot is at the toe of the stoma. Then here. You can see both the donor and the recipient artery. The vessel wall was quite thick. So the second knot is still surgical knot. Then to the point of 9 o'clock, then finish this side, still in interrupted suturing. Then the other side. I prefer to do the first stoma of intracranial stoma. Then remove the temporal clips. And the final knot. Now you can see the stoma was quite patent. Then do the ECA to radiatory stoma. Still, the first stage, the first knot is a surgical knot. Then the second one, that is here of the stoma. This is also the 9-0 pruning suture. It's also a surgical knot. Then the another side. So then remove the temporal clips from the distal of ECA, then the proximal, then the donor. So this is ICG. You can see the blood flow is quite patent. And we did the intraoperative DSA. You can see the blood flow was very good. So the fourth type is a low flow bypass. Normally we use STA-MCA double bypass. For the male patient, normally it can replace the whole MCA territory. So this is two stomas, one in inferior trunk, one in superior trunk. You can see this is one in superior trunk, one in inferior trunk territory. So that before the ICA, you can see the STA was quite small, but after we occlusion the ICA, the STA enlarged immediately. how to treat the ICA? Because we should give enough space for ENT doctors. They can remove the carcinoma afterward. So we use long segment occlusion, use coils combined with onyx. You can see this is the occlusion of the long segment of the ICA. So after the occlusion of ICA, you can see the MCA territory was totally replaced by the STA. And this is a vertebral artery angiogram. You can see they also get some collateral flow from PCAM. So we also use progressive occlusion of ICA in 7 days. If it can be combined with different bypass method, increasing the blood flow of donor artery and promote anterior and posterior communicating artery, and perimeter compensation. So sometimes it can make a cat grows into a tiger. So you can see this is immediately after the occlusion of the same side occlusion. You can see this is occluded by the ICA both sides. This side we use the ICA progressive occlusion on the right side. So after control side, lateral side, both side occlusion of ICA, you can see the blood flow supplied even more territory. So this is a typical traditional progressive occlusion clip. So this is quite complicated. So I redesigned this kind of progressive occlusion clip. So this is an illustrative case. Before the surgery, you can see the ACAM and the PCAM was very poor. This is a intraoperative ICG of STA to MCA. Then use the new type of temporal clip, the progressive clip, narrowing the ICA around 70% intraoperatively. Then we will get progressive occlusion of the ICA in 7 days. To the seventh day, we totally occluded the ICA. So the left ICA was gradually occluded and completely occluded 1 week later. So the double bypass were patent. And finally, you can see the ACAM and the PCAM also increased. So use this kind of assistant, we can make the blood flow replacement even more effectively. So until now, we have totally 28 cases. In 8 cases, we use a saphenous vein as a graft. In 2 cases, we use a radial artery as a graft. And in 60 cases, we use a double barrel STA to MCA bypass. 2 of them combined with the ICA progressive occlusion. All successfully replaced the blood flow of ICA invaded by tumor. Unfortunately, 1 case died 2 weeks later because of the ICA blow-up syndrome at the 7 days post-operation. Before we occluded occlusion of the ICA. So this patient is unfortunate. Then the ENT doctors completely removed the tumor soon afterward. So until now, the 3-year survival rate without ICA invasion is 65.1%. if we do the cerebral revascularization, till now it's 100%. So this is a take-home message. Cerebral revascularization combined direct occlusion or progressive occlusion of ICA. We can totally replace the ICAs invaded by malignant tumors blood flow. So preoperative cerebral revascularization combined with ICA embolization and have a much better prognosis. Thank you.
Thanks a lot, dear Professor, for this excellent informative presentation. There is one question in chat box. In cases of progressive occlusion, can we avoid doing the bypass?
Excuse me.
This is a question in chat box. In cases of progressive occlusion, can we avoid bypass?
Yes, I already introduced that if the patient can tolerate the enhanced blue occlusion test, this kind of patient can be didn't need the bypass, and the ICA can be sacrificed directly. For 30 minutes blue occlusion test combined with a 30% blood pressure decrease. If the patient can tolerate very well, this ICA can be sacrificed immediately without any bypass.
Okay, is there any question from panelists? Thanks again, Dr. Zhu, for this excellent presentation.
Okay, thank you.
Now we will shift to next speaker. Professor Zhang, please start sharing your screen. Thank you.
Hey, Dr. Zhang, are you there?
Good evening.
We're not getting your screen. I don't know why. Are you sharing your screen, Dr. Zhang? I'm sorry, we're having technical difficulties. Okay, Dr. Zhang there, okay?
I think.
Hi, Dr. Zhang, are you there? Are you there, Dr. Zhang?
Oui. Oui. Suivez.
I believe we can hear you. Is that you, Dr. Zhang?
哎，我在弄呢。
We don't seem to be connecting well. Try again, Dr. Zhang. Maybe he's with Dr. Ben.
Yeah. I already called him. He is sharing his screen, but I don't think maybe his connection was not.
Hi, Dr. Zhang, can you hear me? Can you hear me, Dr. Zhang? There you go. There you go. He's sharing the screen now. Okay.
Okay.
Hopefully the audio will kick in. Whoop, we're having problems here. Do you want to go to the next presentation, Sam, and then we'll come back to Dr. Zhang after this one? Do we have, oh, wait, Dr. Zhang, he's getting back on there.
Okay.
Okay. Yeah, I don't know if the connection is good. I think that's the problem, the connection.
Yeah.
Perhaps the bandwidth may be a problem. Dr. Zhang, can you hear me okay? Is he with you, Dr. Ben, physically, or is he in another room?
No, he in his room.
He's in another room?
Yeah.
Oh, okay. Okay, Sam, it's your decision. We could go to the next one and come back. It looks like it's not. We can come back, Dr. Zhang, okay? Go ahead, Dr. Zhang, try it again. Try it again. I don't think the bandwidth is strong enough. Dr. Zhang, can you hear me? I think Dr. Zhang needs to get to a better connection, Sam.
John, maybe he can shut off his video and just use the audio. Just see if it works.
Yeah, you can. I don't know if he understands it. Dr. Zhang, can you turn off your video? That saves bandwidth.
Okay, we will shift to next speaker, Professor Albert Sofianov.
Okay, Dr. Zhang, we can hear you. Go ahead. Go ahead, Dr. Zhang.
Professor Albert.
Okay, now let's move on to the next speaker. And
yeah, move on to the next speaker, Sam.
Professor Albert Sofianov, please start sharing your screen. Thank you.
Okay. Good day for everybody. Thank you. Thank you very much for giving me possibility to share our experience in this interesting and very perspective area of modern neurosurgery, like exoscopic brain tumor surgery. Please, I share our small experience about this kind of surgery. At first, I want to show you this slide, and you must understand that we are now living in very interesting time, because all devices like loops, microscope now maybe will develop, and now we have new device for imaging of the operative file like exoscope, and I hope and I believe that this possibility will be continue in the future, and it will be some revolution, not only in neurosurgery, because we have now, even now we have even some reality, even digital medicine will be a revolution in the future. So one of the example, now we have exoscope, and this exoscope now is possible to use in practical medicine, in clinical medicine, like neurosurgery. And now it's possible to buy and these products just to use in operation room. And one of these devices is exoscope. Some companies produce exoscope now, very useful exoscope now. But in my center, I use exoscope, the named by 3D exoscope Vitom from Storz company. And in this picture, you see the part of this device consists of the exoscope yourself. Official device for the holding this exoscope, and some device like light sources, image possibility model.
Premium is hardly anything.
No, term insurance, you don't get any returns. No money is refunded.
Oh, I'm sorry.
Only if you are getting on an endowment policy or a unit link policies,
Oh, I'm
then
sorry.
only you get return.
What again?
I'm sorry about that. Go ahead.
Continue.
Yes, please.
Possible to continue for me? Okay, and the main part of exoscope is the head of the exoscope, and you see the view of this part of this device, and you see the two eyes of exoscope. What give us possibility of 3D imaging. It's very important. It's very important. And another very interesting tool is the holder, because at first I try by official holder, as you see before, but I'm not satisfied, and so I replace, and now I use for this kind of surgery by exoscope with Mitaka pneuma holder. In my opinion, is one of the best holder for this kind of surgery by exoscope. Mitaka pneuma holder. Also, very important tools of exoscope is handheld control, image pilot. This is device. By this device, it's possible to make zoom, focus, screen, moving during the screen, macro moving, screenshots, video recording, white balance, S technology, and so on. So it's a very important part of the exoscope. And in my experience, because it is not really freehand device, so one second assistant stand on only for the pilot, because a lot of very important function for surgery just inside of this device. So exoscope, of course, now have some advantages in neurosurgery. The first one is the ergonomic comfort for the surgeon. This is very comfortable for surgeon, and it is very important just for precise dissection in very important structure like vessels or nerves or brainstem, for example. And I show you for the next cases dissection possibilities for the surgeon, because a very comfortable position of the surgeon is very big and amazing. Also, first surgical assistant also before surgery, during the surgery, have able to comfortable assist during the procedure without having to adjust position based on surgeon position on the operation microscope. High degree of the depth perception also is very important features of the exoscope. Exoscope is very small and very small device and not consume a large footprint of the operation room space compared with the operation microscope, for example. Educational and training opportunities for the operation room staff, residents, and students is unbelievable also. Also, it's very important just to very quickly and very rapid switch between micro and micro vision. Sometimes it's very important in some difficult challenge cases during the surgery. And you see very fastly full surgical files and just micro area. Sometimes it's very important. Also, all staff like scrub nurse take possible to participate more actively in process. Another very important features is the lighting, because LED-based illumination generates less heat than operation microscope with halogen lighting. Sometimes it's very important especially for the continuing surgery, many hours surgery, or if you operate in some very elongation area, like for example, brainstem. Picture also amazing because 4K high definition monitor. This is really brilliant, and it's possible to differentiate some colors. It's also very important, for example, in glioma surgery, because it's possible to differentiate the color between normal brain tissue and, for example, glioma tissue. Also very important. Interesting, the telescope distance from the operative file, because it gives us possibility to all in great visualization during the procedure. And it's very efficient for use of surgical instrument, because the distance you use, you change the distance from the telescope to the operation wound very easy, and the distance must be bigger when you use microscope. Sometimes it's very useful when you use, for example, for the pineal tumor region, because you need to use the long instrument. So it's sometimes better than microscope. Also very important. Also very interesting, for example, compared to the endoscopic surgery, lack of need for the lens fogging or cleaning. Because all surgeons know, because cleaning of the lens in endoscope is sometimes some problem, sometimes some big problem, because you remove endoscope, clean, and then put inside of the operation file. Sometimes it's very difficult and dangerous. So in this kind of surgery, by use of exoscope, is no need. Very important feature. And for my opinion, also very important is just to save eyes of the surgeons, because all surgeons know, because when you see through the microscope, your eyes is very tight, and if you make like this every hour, every month, every year, so it's very dangerous for the surgeon's eyes. So less excessive harmful light exposure to the eyes of the surgeon. It's not all adventures. It's some important adventures. Oh, sorry. Of course, not only our experience, but some authors' experience. The exoscope have a limitation, and this kind of these models of exoscope, it's not ideal. It's not ideal. So need continue improving, because one of the most important compared to the, for example, microscope, for me is not real freehand surgery, because in my department we have some device and we have microscope with real free hand moving. This device does not have real free moving. So why special assistant stay with the exoscope and just move the microscope. Learning curve also some problems sometimes in some people, because some people need develop the coordination and familiarity with this system. Also, it is personal features of the surgeons, but possible vertigo, headache, and eye strain from prolonged use of 3D glasses is possible. And another big problem, for my opinion, not only freehand, but another main problem is the light source. Because sometimes, especially in big surgery, for a skull-based surgery with a very narrow wound for neurosurgical, it needs better light. It is now the limitation challenge for surgeon and for surgery sometimes. But I think it's in the future, all these disadvantages will be improved, I believe. We have exoscope maybe 2 years. We have 2 years now, ma'am, exoscope, and at first we work a lot of time in our cadaver lab by exoscope, and only when we have some experience with the manual experience at first, we moved to the operation room. And now we mainly operate last years, and we have some experience in these surgical procedures. Near 100 procedures now we have experience. Mostly, of course, is tumor surgery. Near the 50 cases now we have experience of tumor surgery. So all kind of brain tumor or skull base, it's possible. For example, pineal region, skull base, intraventricular, and so on. Also, some malformation in pediatric cases also possible and very interesting, especially for the posterior fossa surgery. Some Chiari malformation is near the 30 cases we have now. Also, functional neurosurgery with endoscopic assistance, like a microvascular decompression of fascia or trigeminal nerve, it's possible. And we use also epilepsy surgery, awake surgery, vascular surgery like a cavernoma, clipping of aneurysm, even bypass surgery in moyamoid disease is also possible, and we have now experience like this. For this kind of surgery, like a bypass, I think is also very useful because not necessary to move the myocardium, not need real free hand, for example, just one position, big magnification, good quality of image. So it's very useful for vascular surgery, in my opinion, for example. Patient position in this slide I show, and you see our operation room with the monitor, lot of monitors, and the patient position. This is the exoscope. Another view. The most important, you see the holder. The good position of the holder is one of the key of the surgery, because from this device depends the moving of the exoscope, easy moving and enough distance. You see some short video. We prepare just for comfortable surgery. Again, you see the exoscope, and you see the position of the assistant. This is the first assistant who helped for surgeon during the surgery. You see the assistant, you see the exoscope, and just posterior of the pneumonia, you see the second assistant. And from the above, again, first assistant, exoscope, operation nurse, monitor, very comfortable to see, just direct visualization from the eyes to the monitor, and very important second assistant. You see the pilot with a lot of function, just to moving, imaging, focus, distance. You see, by hand, assistant just manage this function by this image pilot. All people in 3D glass. Now I want to show our experience about brain tumor surgery. Case one is the atypical rhabdoid tumor of the CV junction. You see the giant tumor, all neck, and go inside of the cranium, big one. And you see how good visualization just only from start, from the beginning, from the skin incision. Very good angled view. You see all files of surgery in one session. Good visualization, good color, good magnification, Now we open more because tumor growth inside of the neck. We open spinosis, laminoplasty, not remove the vertebral arch. It's laminoplastic technique. Very fast and very easy. We open lot of arch without any problem by one moving. And now open. What we need. If necessary more, we open more. Just 30 seconds. And you see the interesting the color. You see the how we use possibility of visualization because it's a digital. So you see the introduction to the S technology of the visualization, Clara, Chrome, and so on. You see the difference between Clara Chrome, and sometimes it's very useful just to visualize some vessels inside of the tumor. Chroma, Spectra 1A, Spectra B. We all mainly we use standard and Chroma. And now we see how we open the dura very fast and very easy. This is our laminoplastic technique. All tumor now open. This is extravertebral part of the tumor also. We see the visual magnification. How big is magnification? If you need some more magnification, you make close the exoscope just to the wound, and magnification will be better, bigger and bigger. Very easy. Beautiful quality of the pictures. And this moving, it's by the pilot device. You see the very easy switch microscope, microscope, moving around the all area. You see, very fast, very fast. Magnification. It's very important in this kind of surgery, especially in challenge cases. In challenge cases, very important. Faster, faster. Faster. Change, fast and change of the focus, zoom, moving, quality of the picture, and so on. And you see the magnification, even small vessel, very beautiful, possible, we have possibility to see. Very beautiful, very precise dissections possible, even around the brainstem. And you see the quality of the color, because color is very important in brain tumor surgery. Differentiation between the tumor, between the brainstem, between the cerebellum, for example, and so on. Remove tumor piece by piece after dissection. Now I remove extravertebral part also. Now total removing of the tumor, total. and close, start to close the wound. And again, all this manipulation we use by 3D depth perception. It's very important. This is after operation, total removal of the tumor. This is histology, atypical thyroid tumor of the craniovertebral junction. Another case, the medulloblastoma, also posterior fossa tumors. You see big one in the fourth ventricle. Not so easy for the surgery. And you see some anatomical features about this area. And now we start the surgery. Also, very open view, very open angle of the surgical file. Very interesting, very easy to surgeon when you open, because you must see the sinus all around the wound, and you see all in one session. Again, very easy to manipulate by magnification. Very easy, from micro to from micro to micro, and again. Again, you see the beautiful color. You see beautiful color between tumors and the brainstem and the vessels and so on. Now we open the fourth ventricle. Very good anatomy. And you see very well tenia choroidea. And now we try to open it, just to open the root to the aspiration file. Open more and more. Even with big tumor, it's very useful because it's possible to change the angle of visualization of the exoscope very easy, not like microscope. Microscope has a limit in posterior fossa tumor, for example. And for example, not possible to see the vermis from inside to outside. It's difficult. If you want to see, we must cut to vermis, for example. But in this kind of surgery, you see, because we change the visualization, it's very easy. So it's very easy to us to see the all cavity of the fourth ventricle from inside. It's very main important feature for this kind for this device, especially for the posterior fossa tumor surgery, which is the aqueduct. We completely dissect around and remove one block. You see the quality of the picture. It's excellent. Excellent. Total removing. Again, this kind of tumor, it's very difficult to see with microscope. You must split vermis. But exoscope, you're possible to see like from this one, from this approach. Just from inside to outside. Not from outside to inside, like microscope. From inside to outside. This is histology. Typical medulloblastoma. Another case, also big case, very difficult to for surgeons from thalamic tumors, right thalamic tumors. This is MRI tractography around the tumor, so it's It's we hope to good results for the surgery, because tracks not disrupt, just go around the tumor. So good indication for surgery, for thalamic surgery. Again, our equipment, just for this kind of surgery, you see a lot of monitors. It's very important. This is 4K monitor. This is a kit for exoscope, ultrasound with possibility to fusion with the navigation, brain lab navigation. It's very important. It's very important, again, position of the surgeon, very comfortable position just for dissection. It's very important. Not like for microscope. Patient position. Exoscope. This is the planning before operation. Main vessels, trajectory, and so on. And before surgery, ultrasound. Just to estimate situation. You see the direction of the probe of the ultrasound. And fusion.
Fusion is performed, allowing less skin retraction and facilitate the occipital cervical musculature is de-inserted.
Okay, we just create the approach. At first, sternostomy. Okay.
The door is then open in the right side, exposing the tentorial face of the cerebellum. Arachnoid adhesions and small vessels are coagulated and cut.
Very important. You see the green point is navigation. For exoscope, it's possible to navigate. You see the navigation point of the exoscope. In every step, we know where are we. This is the navigating point.
A small incision is performed in the tentorium, allowing us to identify the pulvinar of the thalamus. Tumor location is confirmed with the use of neuronavigation.
This is a probe of navigation. Yeah.
A small corticectomy is performed and tumoral tissue is identified. Sample of the tissue is collected for pathology. And tumor removal is carried with microsurgical techniques, suction, and bipolar. After satisfactory removal, the endoscope is employed to check for tumor remnants in the corners. Intraoperative ultrasound helps us identify the tumoral cavity. Further resection is performed. Hemostasia is achieved and the dura is closed in an ordinary fashion. The first day post-operative, we can notice an improvement of the child's eye movement. Post-operative imaging shows complete tumoral resection.
MRI after surgery. Another case about also pinal tumor region. You see the tumor before the surgery, big one in pinal region. In this case, we use combine the endo and exo and endoscopic surgery. First stage of surgical intervention, endoscopic ETV of the bottom of the ventricle and restoration of the CSF circulation and the brain lab navigation and ICG control. We will plan and the biopsy and partial laser ablation of the tumor we plan to do. At first, the pre-surgical planning, and we try to choose the trajectory for the endoscope. And you see the three type of trajectory for endoscope we have before. The first one is the ideal for the access to the tumor, just on the center of the tumor. The third one is the ideal for the ETV, but it's not easy to access to the tumor. But this is second is arithmetic mean, because possible to access to the tumor and to make the ETV also. And one of the important of this kind of surgery is the equipment for this kind of surgery, because it's a very high technology possibility. You see the navigation. You see the screen for the disposable video scope with possibility of the laser ablation, special monitor. You see the special endoscopic device for the 3D. You see the special device for the exoscope with the endoscopic possibility for the ICG. And you see the standard endoscopic kit. So we see the set for this kind of surgery. Again, planning, we choose trajectory. Because we choose the flexible video scope. So why we choose this trajectory just directly to the tumor? And you see the ETV and surgery by 3D endoscope from vision sense. You see the good quality of the picture and the large view angle picture. It's very useful for surgeon. Not like standard endoscope, 2D. This is 3D endoscope picture. You see the anatomy of the third ventricle, for example, the mammillary body, tumors, the bottom of the third ventricle. This is a basilar artery through the bottom. When we estimate the all anatomical landmarks, now we try to do ATV. This is a forceps like that. And between vertebral artery, basilar artery, sorry, and cerebral, we create the fenestration. And then we put inside the Fogarty catheter just to enlarge. And now we create the good ETV, big one. This is the first step, restoration CSF flow, because we don't know what's possible for us to remove tumor, not possible. So our first step is economic variant of the surgery. That's restoration of the CSF flow. And second one, we just estimated the situation with the tumor. Possibility of the biopsy, partial removal, not possible. So big volume inside of the third ventricle. So we decide to take biopsy and partially remove by laser ablation. And you see, at first we use just to create avascularization area. We use the laser tube by the laser on the tip of the tube, laser tube, just to create the avascularization area just for biopsy and tumor removing. This is a laser on the tip, and now we use another tube of the laser, just side lasers. You see, not on the tip, on the side of the probe, laser probe. And by rotation, very easy. We remove the tumor. Only by rotation. Very easy moving. Very safe moving. And after surgery, we check our work by ICG, endoscopy. Okay. This is after surgery, partial removing. ETV worked very well. And then we go to the surgical removing by the exoscope. Again, you see how it's possible to move exoscope. Very easy, just to, not like microscope. Position, marking, visualization, and this is surgery. Open. Open the dura. This is anatomy, landmarks. Very important is the vein in this kind of surgery. And when we check the tumor and location and the vessels around and inside by the ultrasound, when we start to dissect, very good elimination again, magnification, color, and very easy to dissect, very precise and very safely. Very safely, because magnification, focus, zoom, color, very good. We save the main vein. It's very important. But we need sometimes use some special, very long instrument. You see, the scissors, special scissors, just for keyhole surgeries. Scissor. When dissect around and when remove by one piece. This is after total removing. And then we check by endoscope about the remnants and about the veins, vessels. We totally saved all the vessels, veins. It's very important. And then close by ordinary fashion. This is after surgery, before, after, histology. And using a combination of the 3D endoscope assistance is very useful because very important neurovascular structure of the brain are located in this posterior cranial fossa. And neuroscopic assistance during surgical intervention will give us at some advantages. Hemostasis control of the totality of the removal by ICG possibility and reducing the risk of postoperative complication. This is conclusion, but the learning curve of surgeons is very important. So we have some lab, cadaver lab for this kind of surgery. All our neurosurgeons in the world know about our lab. So we have some cadaver dissection course about the scope. So last was in October, not in October, just in February. In February again. So we have now two courses, workshop about the endoscopic surgery, headed by Professor Borba and Professor Albert Sufyanov. And we invite all participants to our place to study exoscope surgery. Thank you very much.
Thanks a lot, Professor Sufyanov, for this excellent presentation that oriented all of us about this recent facility. Professor Borba have invited me to visit Ironman and your center. And I appreciate this invitation. I think also you have more facilities that we all want to be oriented by. There are a lot of questions here, but I think the main question about cost is, in your opinion, is it valuable to use exoscope instead of other instruments that we have?
Oh no. Again, exoscope is very beautiful tool, but need improving. So now it's good, but especially for posterior fossa surgery, but still need improving and still need learning curve. But it is future. It is future, near future. You see one of my slide. This is a view of the operation room, but in the corner of the operation room you have the microscope. But exoscope is future.
Okay, thanks again for this excellent presentation.
Okay.
And now we will shift to next speaker, Professor Zhang. Are you ready?
Okay.
Yeah, I'm ready.
Professor Zhang, please start sharing your screen.
另外一个人，另外一个，不跟朋友，搞朋友。 别人这个人啊，
You're on your way. Oop, fell off.
另外一个
Try again.
也听不清。
Dr. Zhang, the first step is to share screen. Click on that link at the bottom of your screen. Okay, Dr. Zhang?
OK，
Yeah, go to the bottom of the screen. It says share screen. Click on that.
是不是？
正在共享屏幕，
这边有吗？
你能看到吗？那边？
Okay, you're on your way. You're not connecting to the right screen. Okay, click on the share screen. Okay, click on the share screen. Then you need to go to your PowerPoint. Click on share screen.
OK，
Yeah, okay, there's your PowerPoint. Okay, great.
OK，
Yes, it's okay.
is
We'll take it. Well, okay, Sam, I guess we have to make a decision. What should we do here?
Okay, I think we will shift to next speaker as we have much trouble with this.
Yeah, I'm sorry, Dr. Zhang. We tried. Okay, Sam, it's up to you. What do you think, Ben?
Both of those. I think we.
Yeah, I think his connection was not good enough. Yeah, when he shared the screen, the sound was the voice was
right, was garbled.
Yeah.
So we apologize, but we may have to move to the next speaker. Sam, what do you think?
Okay, Professor Sanford. Professor Sanford, are you ready?
Yes.
Okay, so please start sharing your screen.
So
Maybe we can get Dr. Zhang later if he gets to a good connection.
Okay.
Okay, who's next, Sam?
Professor Sanford, he will start sharing his screen now.
okay, could I start it now?
It's okay. Go ahead, sir.
Okay, thanks, Sam, for inviting me to this great meeting. And today I would like to talk about the surgical techniques in insular tumor. And actually, I learned all the techniques and concepts from my mentor, Professor Yasuko. And this slide shows is his first visit to Taipei. And I put every sentence in his slides. And During my fellowship in Little Rock, since 2007 to 2009, I learned a lot from him. So this is the concise concepts of professor when he put everything in this slides. But one of the most important is what is the microsurgical techniques? He always using the cisternal anatomy allows to explore the lesion in each side of CNS through the subretinal space. And we call it the cisternal navigation. It also, excuse me. And also, based on the embryology, we have to recognize the each compartments within the brain, especially where the lesion is located. And we attack the lesion in the specific compartment and avoid damaging the other innocent compartments. So later I would show how we identify, and we have some classifications of different compartments of the brain. And of course, the goal of the surgery is to complete elimination of the lesion. And at that time, professor usually using the retractor, but he told us, actually, we have to try to avoid the rigid retraction. So today, most of surgeries we are done without the retraction system. So simply to say, Professor Michael Neurosurgery is actually the real minimal invasive techniques. He using the cisternal navigation and retraction techniques. And most of the cases, maybe you use the turned osseous. You have to drill the bone to get a wider space and a good surgical field. And the goal, of course, is totally remove the tumor based on the compartment concept and important basic coagulation techniques or suction techniques. And the anatomy basis of Professor Michael Neurosurgery, I have mentioned several times, is the compartment concept. Actually, is based on the embryology. And another important is he has the knowledge of the wide matter tracts, which he had learned from the Klingler fiber dissection technique. So maybe most of the people have known during the brain development, actually the cortical anatomy is classified into the allocortex, the most primitive cortex. The allocortex, including the paleocortex, actually is the most of the olfactory system. And the arcuate actually is the hippocampus. And the transitional area between the allocortex and neocortex is the mesocortex. Is actually is made of maybe the parahippocampus or cingulate system or the insula. And actually, he got most of the influence from Professor Maslin. In his book, he described details about the each system, like I mentioned the limbic and paralimbic system, which in the allocortex or corticoid or allocortex system, including the septum and substantia innominator, amygdala, piriform cortex, and hippocampus. And the paralimbic areas, including the temporal pole, cortex orbitofrontal area, and anterior insula, cingulate system, and parahippocampus. So actually, even in the mammalians, like the monkey, the brain development has a similar patterns. And in monkeys, like you have this slide showing, we have two bands of paralimbic areas. Which one is the olfactocentric, and one is the hippocampal-centric paralimbic areas. So like you have seen, the insular and orbitofrontal and temporal pole is one band, and the subcallosal area and cingulate and parahippocampus is another system, all belong to the paralimbic system. And all these compartments actually in embryology, if you have known, the allocortex is constitutes of 3 layers of the neurons, and mesocortex is between 3 to 6 layers, and neocortex is 6 layers of lamina. So why do we have to learn the glioma surgery based on the embryology knowledge? Because we have to form the compartment concept developed from the embryology basis. And if you have the compartment concept, then you will realize that the tumor growth pattern in the specific compartment actually differs from others. And then we choose the right surgical approach. Actually is the minimally invasive approach to the lesion in the specific compartment and avoiding disturbing or destroying the innocent ones. For example, today I would like to talk about the insular surgery. So I know some of the people, they remove part of the frontal operculum, then they get access to the insular fossa. But if you know that the frontal operculum is actually belong to the neocortex system, neocortex compartments, and the insula is actually the paralimbic system, is different compartments. So it's not necessary. You have to try to avoid the destroy of the neocortex to get into the insula. You just try to split to open the septum fissure without any damage to the innocent area. So it will make sense that why the real microneurosurgery for insular surgery is just open the septum fissure. Later I will show, not to using, maybe some people using the functional mapping, then they remove the frontal operculum, then to get access to insula, it is not necessary. So like I said, different compartments, the tumor growth pattern in different compartment has some specific behavior. In neocortex, the glioma may involve 1 to 2 or more gyrus, but they all grow pointed to the ventricle system because during the embryology stage, and the brain developed from the paraventricular area. So you can find all the tumors which is pointed to the ventricular wall. So in the clinical practice, if you read carefully in Professor's book, then you find such kind of the neocortex tumor. Then if you look carefully in the post-op pictures, then the tumor is removed and actually the shape or the post-op change, the all pointed to the ventricular system. These slides show what happens during the surgery in Professor's mind. He follows the tumor's growth pattern. He removed the 1 or 2 gyra, and then he taper the tumor towards the ventricular wall. So this is another case. And this is my case. I removed the tumor in the F1 region, but I spared the cingulum because the cingulum is not belong to the neocortex. The cingulum is the paralimbic system. So I removed the tumor and taper down to the ventricular wall. So the anatomies of sulci and gyrate are very important. You have to know the morphology of the gyrus, then applies the anatomy to the MRI so that you can realize the tumor is within which compartments. Then when you do this surgery, it's actually simply to say the glioma surgery is actually an anatomical resection following the compartment concept. So in Professor textbook, he classified the limbic and paralimbic tumors into several subtypes, like a pure insular or the insula combined with other compartments, or the mesiotemporal like a hippocampal tumor or cingulum tumor, or the frontal orbital tumor, or the septal region tumor. So all these lesions, all these systems are belonging to the limbic and paralimbic system and have a complex connections. So different from the tumor growth pattern in neocortex, in the limbic and paralimbic system, the tumor has a different growth pattern because the tumors, especially low grade or even the high, most of the high grade, the tumor growth is within this system. They rarely jumps out the system to another different system. For example, if you look at the tumor in the insula, then they can expand. Sorry. Sorry. So you can expect that the tumor involving the frontal orbital region, or they can involve the substantia innominata, because all these region is belong to the limbic and paralimbic system. So as you can see, this is the pure insula. Then it can involve the frontal orbital region and some of the temporal pole. And also, as you can see, the tumor can involve the amygdala, the insula, the frontal orbital, and the temporal pole. And also you can see the pure mesotemporal, the hippocampal tumor. And also you can see this is a cingulate tumor. And also the cingulate tumor with the subcallosal or even the septal region invasion. Or also the cingulate with the multiple compartments involving the frontal orbital and some of the amygdala. So if you look carefully in your clinical practice, you can identify the tumors in the limbic and paralimbic system, which is quite different from the neocortex tumor. So if you have such a compartment concept, then you can predict the tumor behavior. So this slide shows, I done this case in 2018, and the patient had the anaplastic astrocytoma. The tumor is actually within the insula. And so I removed the tumor in the insula. So as you can see, 2 years later, the tumor recurred. But if you look at the insular region, it's clear, but it recurred in the temporal pole and amygdala. So even the tumor recurrence is within the same compartment. So if you follow these concepts, then you remove the lesion purely within the same system. Don't disturb the system different from the lesion. So this is the real concept of the minimal invasive of marginal neurosurgery. And even for the large tumor, if you cannot, sometimes it's hardly recognized the lesion in which compartment, but if you remove the tumor precisely within the border of the tumor, then in the post-op MRI, then you can see the tumor is actually is origin from the hippocampus. Then you can preserve the most of the innocent area. Another important concept is the fiber tracks, which Professor learned from the Klingler during the 18th. And actually, people will ask that during the surgery, we don't see the fibers. The fibers is invisible. But if you can apply the fibers, the knowledge of the fibers, along with the real anatomy, then you can choose the best approach to the lesion. For example, in this paper done by the Nick Cranbell, is one of the fellows from Professor. He had done the beautiful article to analyze the different approach to the mesotemporal region. Then he got a conclusion that when you use the supracerebellar tentorium to the mesotemporal, there will be minimal fibers which will be destroyed during the surgical approach. So if you don't see, even you don't see the fibers, but based on the knowledge of the fibers in the real anatomy, then you will choose the best approach to lesion because you know which fibers will be destroyed during the surgical approach that you choose. Then you will choose the best one. So we have several approaches to different kind of lesion, especially in the limbic and paralimbic system. And as you can see, most of the approach is using the, for example, using the transsulcus, using the interhemispheric, using the transfusion. All these approaches based on the cisternal navigation, and actually is the minimal invasive. We don't using the transcortical approach to deep septal lesion, like some of the people like to use the trocar, or it is very rude to do the brain surgery because it's against the principle of the microneurosurgery. So I summarize some different approaches to different compartments of the brain, but today I would like to focus on the insular tumors. So we're using the transfusion approach to insular region, but actually the transfusion approach is versatile. You can use in this approach to deal with very a lot of kinds of pathology or vasculations. But how I can do it for the insular tumors? For these slides, as you can see, I totally removed the lesion. And even this complex one, as you can see the post-op pictures, I almost nearly totally removed the tumor. I dare not to say I totally removed the lesion because it's glioma. But how I do it? Of course, I'm using the transfusion fissure and to expose the insular fossa. But as you can, if you have known that the insula, the anatomy insula is pyramid shape, and actually is bounded by the anterior limiting sulcus, superior limiting sulcus, inferior limiting sulcus, and also the three important corners. The anterior upper anterior corner actually is pointed to the caudate. The inferior anterior inferior corner actually is at the limiting insula. Actually, the most important one is the lenticular striates from the M1 segment. And the posterior corner actually is corresponding to the cortical spinal tracts. So during the insular surgery, what I was the most free of? As I mentioned, if you know that is pyramidal shape, and in each corner, that there's some important landmark that you have to see. So as I mentioned, the anterior inferior corner, you have to localize the lenticular striate artery, and the anterior upper corner, which corresponds to the caudate, that you have to find some important landmark that direct you to the caudate. So later I will show which one is the most important landmark that you can identify that you are close to the caudate. And the posterior corner is corresponding to the posterior limb of the internal capsule. So in this corner, when I do the surgery in this corner, for beginners, I always using the intra-op monitoring, using the subcortical mapping to using stimulus to identify the cortical spinal tract. But the most important, now you have to widely expose the insular fossa. So this picture shows that most of the blood supply is from the maybe N1, A1, but actually the insular surface, the cortical surface of the insula is not supplied by these important perforators. So this is why when you open the insula, you can coagulate the small branch from the N2 and 3 overlying the insular surface, because the blood supply system is different from different area. So like this show, now you can coagulate the small branch, then you can do the tumor removal, but you have to preserve the major trunk of the M2 and M3. And also this venogram shows all the veins that drain into the ventricle wall. So like I mentioned, when I do the anterior upper corner, then I try to localize this vein is called the medullary vein. If you follow the medullary vein, then it will guide you to the ventricle wall. So you can also guide you to the direction to the caudate. Later, I will show in the surgical photos. And another important corner is posterior corner, how you can delineate the posterior limbal internal capsule. So I always using the intraop monitoring using the subcortical stimulation. And in my surgery, I always using I put the epidural catheter for monitoring because I will collect the D wave signals because the D wave is better and more reliable than the traditional NEP. So when I do the posterior corner, then when I remove the tumor, I will use in the monopolar and give some stimulus to evoke the response of the motor. So usually the amplitude of stimulus is correlated to the depth of the distance to the lesion. So when I using the 5 milliamperes to get the response of the motor, then I will stop because the 5 millimeter, because it means the 5 milliampere is related to 5 millimeter to the cortical, to the posterior limb of the internal capsule. And usually I will stop because 5 millimeter is very close to the internal capsule. So in this case, I'm using the techniques and totally remove the tumor, and actually the patient is doing very well. And also in this case, I'm using the transcipient approach, and usually I'm using the beaver knife. As you can see in the illustration in Professor's textbook, I using the blade sliding over the sylvian vein. And actually, during the surgery, the instruments and the anatomy is actually some kind of the communication, because different patient has different texture of the anatomy, so you have to using the instrument to feel the texture of the anatomy. And usually I choose the system, the sylvian system below the pars triangularis, because the system below the pars triangularis is prominent and more easier to get into the insular fossa. So I'm using the inside out techniques. I go into the insular fossa, then I open the sylvian fissure from inside to outside, and it will be easier to widely open the insula. And the most important that you have to widely open the sylvian fissure. The most difficult one is the Herschel-Jarrett, because it's most of the cases is most attached together. So when you open the anterior part of the insula, then you move backwards from inside to outside. Then you carefully to open the Herschel-Jarrett. And sometimes it's easier to split the artery because the artery is rarely cross the sylvian fissure, but you have to recognize the direction, which side that the veins belong. Then you keep the plane, then you can open the Herschel-Jarrett. And also you can identify the color is different from the brain, the brain parenchyma. Then you can coagulate the small branch from the N2 or N3 branch. Then you can do the tumor bulking. Then you can identify the color change at the depth of the tumor between the putamen and the tumor. Because as you can see some red spots from the bottom of the tumor bed, because the blood supply in the deep city region from the basal ganglion is from below. So when you remove the tumor, then you can see these red spots, then you realize, oh, you're close to the putamen. Then you will remind you not to go too deep. So this is the putamen. Then when you do the anterior superior corner, like I said, I try to localize the vein. This is so-called medullary vein. And it will guide you to the caudate. So this is a superior limiting sulcus. This is anterior limiting sulcus. In this corner, I try to localize. As you can see, this is material vein. It directs you to the caudate. If you go some deeper, then you will see the different color within the caudate is actually different from the tumor. So you can see some grayish color and some spotted pattern in the caudate. So don't go too deep if you see this picture. Then if you do the posterior corner, like I said, I was using the monopolar to give stimulus to get the distance to the corticospinal tract. Then when I usually are using the clockwise or counterclockwise to remove the tumor. Then if the last step is too close to the lemon insula, then you have to carefully to check the maybe the N1 segment to look for maybe there's a take off the lenticular striate artery. But sometimes you have to leave some. Don't try to chase the lenticular striates into the basal ganglion, because even you preserve this artery, you may cause the vasospasm, and patient even can get some deficits from the vasospasm. So in this case, after the surgery, and the patient sent me his video playing the violin. So using the correct concepts of the microsurgery and the techniques which you learn from your masters, and the most important one is from the lab, you can do your patients very good job for your patients. Like a professor says, the assertion that complete elimination of the lesion will carry the risk of significant morbidity and mortality actually neglects to consider the fact that the surgeon's competency. So how to improve the surgeon's competency? So you have to go to the lab to learn the anatomy, and also you have to watch a lot of the surgical surgeries from your mentors, and you have to apply all the knowledge in the clinical practice. So this is the only way now you can improve the patient's outcome. And this is the real spirits of the modern microneurosurgery. Like this old man that he tried to take the last piece of the tumor in a deep corner. So you have to kneel down to take the last piece of the tumor. So this picture always, I have paired this picture always on my mind when I do my surgery, and I try to follow my professor's steps and to get a patient a very good outcome. And today I just briefly introduce some important concepts and basic techniques for the insular tumor. But of course, it's not only the insular tumor, you can apply the same concept and techniques to any other compartments of the brain if you have the right concept of microneurosurgery. And thank you very much.
Thanks a lot, Professor Jesus, for this excellent presentation. Is there any question from panelists? There are a lot of questions for you, sir, on chat box. Unfortunately, for sake of time, we can answer it live. Please go for the chat box to answer it. And now we will shift to the next speaker, Professor Mustafa Baskaya. Please start sharing your screen. Thank you.
Yeah.
What is it saying? How it works?
Okay, Sam, it's up to you. What do you want to do?
I'm trying to share.
Yeah, I think we're
Okay.
confused here. Sam, is Dr. Zhang going to present or Mustafa?
No,
Yes.
also Mustafa will start.
Yeah. Hold on a second. I'm doing it.
Okay.
Hold on, Dr. Zhang. Dr. Mustafa is presenting, okay?
Okay. Good morning, good afternoon, or good evening, wherever you are. Thank you. Thank you, Professor Al-Morsi, for having me. And thank you, John, for organizing all these, and rest of the organizers and the panel, distinguished panelists, speakers, and all the participants. So this is about the brain surgery update. And unfortunately, I don't have any updates for you. I'm just gonna introduce this concept of ultramicrosurgery. So the question is microsurgery is dying, right? That's the question we have been asking ourselves. And I'm following a wonderful lecture by Sanford. He showed you guys the beautiful concepts of insular surgery. But we have threats. Everybody does insular tumor surgery differently. This mapping and going through the cortex. So these ideas of being minimally invasive as actually, to me, is abuse. People using like, oh, I have a keyhole, pinhole surgery. I do go through the orbit. I mean, these are the real threats. Threats we have: endovascular surgery, radiosurgery. Only if we use, it shouldn't be a threat actually, it should be a collaborative adjunctive treatments, but we feel like we are threatened, right? Same with the radiosurgery. Sometimes we have this strange, ultra-conservative defensive approach. If the things we think we cannot do it, we say this is inoperable. This cannot be done. And we refer patient to the radiosurgery. And fear of making mistakes. A level of neurosurgical training is getting worse and worse, especially in the United States, and lack of surgical skills. Like Sanford said, people, neurosurgeons, trainees don't spend time in the lab, and shortcuts, overuse of unnecessary technology, and unfortunately you'll see some of them today, and then you'll see every day. So what is ultramicrosurgery? Ultramicrosurgery is a concept, ideology based on microsurgical principles set by our pioneers, Yashagil, Drake, Sugita, Spessler, Dolench, De Oliveira, Fukushima, Hernesniemi. Concept, ideology based on neuroanatomical principles as beautifully demonstrated by Professor Su, and concept that doesn't get stuck with terminology. The size of the target or the size of the craniotomy or size of the instruments, they are not microsurgery. They are not ultramicrosurgery. This is the case, right? This is a gigantic case. Oh, I did beautiful surgery. It is not that difficult if you follow the principles of microneurosurgery or ultramicrosurgery. What are the principles? Correct surgical strategy, choosing the correct approach, correct size of anatomy. Craniotomy is not just huge, not just small, just to be safe. Enough craniotomy, enough size craniotomy, early devascularization of the tumor with extradural dissection and clinidectomy. And I call this surgical embolization. If you do that, you don't need to do any embolization preoperatively. Tumor becomes a dead necrotic tissue. And early decompression of the ipsilateral optic nerve, and having the proximal control with the anterior clinidectomy in case of vascular trouble, and microvascular dissection to preserve the normal structures. And this is the results of microsurgery. Good results, good outcome, and we have no problem. But what about this? This tumor is, compared to the previous tumor, is much smaller, but it's more complex because contrary to the other tumor, this is involving, encasing all the vasculature, A1, ICA, and ICA bifurcation. And patient is very limited, almost no vision, just light perception. So how are we going to operate this? Same principles, but we're going to use ultramicrosurgical techniques. After doing the craniotomy, enough size, extradural clinidectomy, and optic unroofing, you see the optic canal here. And this will allow us to have a proximal control in the clinoidal segment of the ICU. Okay? And then will come like the principles of the aneurysm surgery, right? Get the proximal control, get the distal control, then debulk, and piece by piece remove the tumor. So we're gonna go find the MCA, and that's difficult, yes, because there's a mass effect. And then we're gonna go debulk the tumor until we get to the distal control. So I start seeing some MCA branches, and that's gonna let me go dissect the tumor more, decompressing the optic nerve. And we know that optic patient is almost blind, only light perception, but we'll still preserve the normal anatomy. And we'll give her a chance to maybe she can recover. Then we're going to the distal, finding the MCA. And then following MCA towards the internal carotid artery bifurcation. And this microsurgical dissection will allow us to see this is a A1 branches now. And if I have a trouble here, now I have distal control and proximal control. And I can repair if I cause a problem. You just got the glimpse of the oculomotor nerve here. And now we are applying the strategy of divide and conquer, right? You divide the tumor, remove pieces, and now I'm coming towards the A1. So just got the glimpse of A1. Tumor is all 360 degree around the A1. What important thing is here, preserving the A1 perforators, these perforators here. You don't rush, you just keep doing it, sharp dissection, not too much traction, applying the traction. We just got the PCOM and the anterior choroidal. Now we have a better control, and now I'm gonna get everything. Now I think I am winning the game here. So dividing an ipsilateral optic nerve, and another important structure here, superior hypophyseal arteries going to the optic chiasm. So you need to spend time to preserve these very small arteries, okay? And we are dividing and preserving these very tiny small arteries. Now you see that that is another branch, and you don't know they are supplying chiasm or tumor. So if you don't know, you preserve them until you prove otherwise. A1 perforators going around. Tumor luckily is not very hard, moderate consistency. Now we are getting to the point that I'm very close to win this game. And then now we can cut and remove all this disease dura of the lesser sphenoid wing and anterior clinoid, and the optic roof is already drilled, and we can establish a Simpson grade 1 resection. And believe or not, in 3 months, 2 to 3 months, she starts seeing some in this eye she wasn't able to before surgery. And this is concepts of ultra microsurgery, okay? Does ultra microsurgery mean minimal invasive? No. Does ultra microsurgery mean, yes, minimally invasive, but same time maximally safe? We don't get stuck with this keyhole, minimal invasive, this minimally small pinhole. I remove the brainstem tumor from the thoracic region. This is all nonsense. And also, on the contrary, doing like horrendous approaches unnecessarily, combine this, combine that, extreme, these are also wrong. Doesn't make sense. And this is what happens if you do it. This is an unfortunate case. This is radiation-induced meningioma. This patient had a childhood cancer, and they did the radiation at that time, high dose, and he developed these. And after one piterional craniotomy, he had 5 more surgeries just to get 10-20% of the surgery through transciliary approach. because they were minimally invasive. That's not being minimally invasive and safe. You let the tumor grow. See how extensive orbit, cavernous sinus. They did like 1 million surgeries here, and at least 2-3 radiosurgery. And patient became blind, completely ophthalmologic. Now he's having visual problem on the left side. So you don't need to be minimally invasive or use the minimal term of minimally invasive. You need to exenterate the cavernous sinus. You need to remove as much as possible. It was extremely difficult to find the MCA branches in these cases after scarring many surgeries. So I did the bypass, M2 radial artery, external carotid to M2, and I debulked some tumor and came back as a second stage and removed the rest of the tumor. And this is the result, okay? This is pre-op. These are abdominal fat grafts we put here because he had nothing here. And I had to leave this tumor because these were extremely attached to the basilar perforators. But remove the rest of it. And here in this location, the tumor was again encasing the superior cerebral perforators, so I had to leave some. But good outcome and definitive approach. It is not nonsense, minimally invasive transciliary. So I am not against endoscopic surgery, okay? I am against using the terminology claiming that these surgeries are minimally invasive. Nothing we do, either go through the nose or go through the tiny hole, is minimally invasive. Everything we do in brain is maximally invasive. But that's not the point. You should be maximally safe, minimally disruptive, like Sanford said. Okay, endoscopic resection. Look at this subependymoma. Look at this gliosis after endoscopic, right? This is minimally invasive? To me, not. This is the maximally invasive, okay? This is the surgery I did. Huge tumor, interhemispheric transcallosal. Look at the size of the callosum we removed, 1 centimeter callosotomy, no T2 flare changes, and they call this maximally invasive. It is not. Maximally safe, it's minimally invasive in reality. Interesting brain tumors, insular gliomas, okay? That's the top surgery, and Sanford performed very well following Professor Yaşargı's principles. I do the same. This is the example for typical insular grade 4 astrocytoma. You see the contrast enhancing part and non-contrast enhancing part. I don't want to spend too much time with these things, but the same principles, okay? Opening the fissure wide, using the fissure, using the systems, not just going mapping all around and then disrupt the temporal and frontal opercula, okay? And principles set by the pioneers. Wide arachnoid dissection, wide dissection of the veins so you can preserve all these veins, okay? And then applying the tenon suture, slight retraction, wide dissection from M1 all the way to the parietal operculum, okay? Once you got to the tumor, that's done, okay? Then following the circular sulcus on all sides, posterior, that triangle, and then removing the entire tumor. Good outcome, immediate post-op, and she has been with us. This is a glioblastoma 4 years, more than 4 years, without any recurrence. This is ultra microsurgery. This is not same as the previous insular glioma. This is going towards the anterior perforated substance, okay? More subinsular than the pure insular. So what we're gonna do, first we're gonna preserve, and we know that lenticular striates are involved, okay? Wide arachnoid dissection, moving the veins away, but preserving the major veins, and then getting to the tumor. You see these, unfortunately, GBMs, different from the other gliomas, they don't respect these borders, okay? They will go encase and cross the borders of that embryological borders. Problem here is the encasement of the lenticular striates. Okay, I don't suggest you do this kind of dissection after you gain enough experience. See, I am dissecting the lenticular. Ah, God. I'm dissecting the ventricular striate arteries, okay? I don't suggest you do this until you spend enough time in the lab or in the operating room. Look at these. These are all M1 lenticular striates. And then you can use ultrasonic aspirator at the very low intensity, 5 or 10 on these arteries, okay? That's what I mean when I say the ultra microsurgery. I am using technology, but I am operating. Technology is not operating. And you guys can do better, okay? I learn slow. Does ultra microsurgery mean maximally invasive? No. In certain cases, you do enough approach. This is a case example. Patient presented with the sixth nerve palsy, and my presumptive diagnosis, this is going to be a trigeminal schwannoma. Okay, it's cystic appearance, typical appearance, T2 hyperintense, and heterogeneous appearance, and also I kept the atypical meningioma in my mind. She's a 60-year-old, not very healthy person. I said we do enough approach. Okay, not combine approach, but enough approach. Initial retrosigmoid craniotomy. We couldn't tell even at surgery what this might be. Pathology came back as a grade 2 meningioma. So now I left this tumor. It was very hard tumor, and I couldn't reach through the Meckel's cave suprameatal drilling. And I tried to pull it, it's not coming. So I don't want to give damage, right? Wait for the pathology, see what the pathology will come back. Pathology came back grade 2 atypical meningioma. I don't want to leave this tumor now. I have to do gross total resection. That's the best care for this patient. We did the transcavernous approach, came back, and drilling clinoid principles again set by our pioneers, Dolench, Hakuba, and Dr. Krish. So it's hard tumor, removing tumor between the trigeminal nerve roots, going all the way back to the Meckel's cave and pulling the tumor. And once you get the CSF, that means you are doing well. You got to the trigeminal cistern and you remove the rest of the tumor, okay? So we did the enough approach. We need to come back and do more. And this is the fat graft, and she did very well. But sometimes enough approach, any approach you do is not enough for certain pathologies. And chordoma is one of them, okay? GBM is one of them. You have to do everything. Give your best to the patients, and so they can survive this terrible, horrible diseases. This is a young man with the completely dysfunctional lower cranial nerves, lost weight, aspiration pneumonia. So first, what you need to do? Admit the patient to the hospital, have elective tracheostomy and gastric tube feeding tube placement. Then start entertaining about what approach is best for this patient. So in this case, anything you do it should be like Dr. Al-Mefti suggested. Do anything for these tumors, okay? We come, and then after discussing, first I decide to go infralabyrinthine, do the test occlusion of the sigmoid sinus so I can transect and I can reach high. And we entertain coming from the front, back. Eventually we did everything and come back and infralabyrinthine approach, then far lateral transcondylar, extreme, whatever you call it, and complete skeletonization of the vertebral artery. And we know that vertebral artery is encased by the tumor. So now what I did, I have a proximal control. I am going to obtain the distal control, the principles of the aneurysm surgery. Remember that, right? So this is the distal word and proximal word, extradural word. So I need to dissect. Now I can wean this because I have control, okay? And I have to do very, very radical resection. This patient deserves that. So skeletonize that and eventually going into the hypoglossal canal, skeletonizing the hypoglossal nerve intradurally and extradurally, and giving chance to recover. These nerves are paralyzed, but you want to preserve them. They're peripheral nerves. Okay, so establishing this one, fusing him, and coming back, doing the endoscopic anterior approach, getting the rest, and this is the outcome. Okay, perfect. Gastrostomy tube is removed, tracheostomy is closed. He's doing very well. This is the taking the risk, doing the maximum for this patient. And sometimes microsurgery and ultra microsurgery is against this strange defensive ultra conservative approach. Okay, this is a 69-year-old woman, slowly growing meningioma, has been followed 2 years for nothing. Tumor gets more, bigger, slowly. They say it's okay, it's nothing, it's not causing any problem, little headache, little gait imbalance, it's okay, you can tolerate, if necessary we can radiate. This is nonsense. Okay, you need to remove, and you need to do the right approach. Okay, and that is combined transpetrosal approach, and you can get these results and you move on. Look at this. Gross total resection. Even if you cannot do gross total in some of these cases, do near total, radical subtotal. So give the patient the best chance. And now we are moving to the other territory, right? Vascular neurosurgery. This is typical microsurgery. You'll hear from the, I think Dr. Zhu here, wonderful microneurosurgeon, ultra microneurosurgeon. He did like that. I don't know. Last time I checked him, 16,000, I don't know, 2 million. He does perfectly well. This is a typical case for double barrel bypass. Okay, you do this. This is, everybody can do this after enough training. Okay, microsurgery, whatever you call it. Beautiful, patient does well. But sometimes we have cases like this. It's a mycotic aneurysm. You don't have any STA. It's emergency surgery. Patient is grade 4, subarachnoid hemorrhage, intratemporal hemorrhage. So what you're going to do? This is what you need to do. These submillimetric branches, you isolate them, cut them, okay, inside to bypass first. And these branches we measure like a 0.6 to 0.7 millimeter. This is the highest magnification you see. Do the inside to bypass. And then after that, I'm moving fast. So after the inside to end to side bypass, you come for other branch. So this mycotic aneurysm was at the branching point. Do the end to end anastomosis after excising the thing. Okay. This is a small, yes, this really applies to the size. Sometimes size matters. Okay. And you see it's everything is patent, not even she had a stroke, and she made an excellent recovery after content has grade 4 subarachnoid hemorrhage. And this is another example of standard microsurgery, okay? Giant thrombose aneurysm. You just go there with the plan. If you can, clip reconstruct and excise the aneurysm. If you cannot, entertain these bypass options, but go there and be prepared for all these bypass options. Don't go there just I'm going to clip, or don't go that I'm going to bypass. If you can reconstruct, you should reconstruct this. This is a microsurgery. That's what you do. And excellent results, has been aneurysm free for almost like 7 years. But not every case you can reconstruct. Okay, this is a fusiform giant aneurysm in a 10-year-old boy. And this case, you need to do everything, and it's very hard to guess. This case, can you do A3 bypass? Is it enough distance between? See you see here, and this branch is very small, and there's no posterior collaterals from the posterior callosal arteries. You cannot just simply trap, so you have to do some kind of excision and bypass. And A3 is not possible, or is possible, we'll find out. But you cannot go there just unprepared. I'm going to do A3 side to side, and we couldn't. Okay, we get to the proximal control, and then we need to harvest the radial artery, do the interposition graft between the frontal branch of the STA to the A3. And during the harvest, we injure the radial artery and we repair that. So this is the artery, and go there, do the bypass. And now there's a size mismatch. How are we going to overcome that? That's okay. Ultra microsurgery, okay? The experience and the time you spend in the lab will pay back. So narrow this artery and then do this way. And you see the bypass working nicely, immediately, post-op, and post-op 6 months, post-op 2 years. He's back to school, he's doing great. Arteriovenous malformations, okay? There is no microneurosurgery for arteriovenous malformations. Arteriovenous malformations is always ultra microsurgery. And this is the cream of cream, okay? Short dissection, identifying the normal anatomy, identifying the pathological anatomy. Don't just go start doing the coagulation and trying to resect and like a lobectomy. Don't do that. You're gonna run into trouble one day. So identify all feeders one by one, skeletonize them, identify the draining arteries, draining veins, identify the normal structures passing by, not directly supplying. Put the temporary clip if you are not sure. And then you go start taking all these feeders once you are sure where they are going, okay? And take them one by one. See the AVM start turning blue. That means we are doing fine. Okay, now you can do dirty coagulation. Yuha calls it dirty coagulation. Anything you need to do, okay? And keeping these AVM loops inside the dissection plane and leaving, as you know, the draining veins lost. And paying attention which artery directly supplying, which artery is en passant artery. And if you do that, you are fine. AVM becomes a simple pathology, but if you don't follow the principles, you're going to be in the trouble. Okay? And then removing the rest. Good results. This is a typical micro or ultra microsurgery, whatever you call for AVMs. And this is another example, okay? How much time I have? Huh? And then this is the last case. Samir, I'll be done soon. Dominant AVM is huge, and these people recommended embolization, after embolization, radiation. Why? It is not. It's in the sylvian fissure. It's like doing a glioma surgery, insular glioma surgery. Operculum is not involved at all. Why you embolize? Embolization only if necessary. Why you take the risk of two procedures, right? You skeletonize these. It's just to open the sylvian fissure, like you are removing the insular glioma. And identify the normal, identify the pathologic anatomy, then take the feeders, and you are done. Why you subject the patient to the million procedures? So you left the dura here, it was to attach, and same principles like we are doing. You're doing bypass, you are doing glioma surgery, meningioma surgery, or whatever. And result is good. So, is microneurosurgery dying? Yes, microneurosurgery is dying because of us. We complicate the issues. But ultramicrosurgery is born, okay? Go to the lab, spend time in the lab, read, listen, watch, dissect. That's the only way of achieving microneurosurgery or ultramicroneurosurgery. Otherwise, you'll be wasting time. And this is the Dr. Krish soccer game. This is us. Good. This is microsurgery. Okay. Now I'm going to see the ultra microsurgery. After this is my knee surgery, I am very small. Okay. I am done. Thank you very much. Thank you for your time and having me. Hope I cause controversial discussion, and I'm happy to discuss anything, any questions. Thank you very much. Thank you again for having me.
Thanks a lot, Professor Baskaya, for this excellent presentation, and to always emphasize that you have to be a safe surgeon. Is there any question from panelists? I think it was clear enough to not have many questions. There are some questions in chat box. Please, for sake of time, check it. And now we will shift to next speaker, Professor Zhang. Are you ready?
行，跟谁讲？听得到吧？
Try it again.
Oh.
Professor Zhang, can you start sharing your
问了，
screen?
还要跟他交流了，跟他交流了。
Third time's a charm, hopefully. You just share the screen first. At the bottom, share screen.
Chairman. Chairman.
Not yet.
Can I start?
We're not sharing the screen, Dr. Zhang. Okay, share the screen. At the very bottom, there's a share screen option. Okay. It says share screen. That's the first step. There you go. Okay, make it larger. Make it presentation mode. Well, that's good enough. You can start. You can start. Perfect. Perfect. You got it. Oh boy. We're not getting sound at all. Sam, it's up to you. It's up to you as moderator. What you want to do. Sam, this is not going to work. This is a bad internet connection. It's just not going to work, unfortunately.
I think so.
Yeah.
So,
what do you think, Sam? We have to make a corporate decision.
Okay, we will shift to our next speaker, Professor Jose Lisma.
Yeah,
Please start sharing your screen.
It's just not working. Okay, let me just get rid of Dr. Zhang. Okay, Dr. Zhang, we'll have to try later. We'll try later, okay? Try later. Okay, go ahead, Sam.
Professor Jose, please start sharing your screen.
Okay, Sam, who's next?
Professor Jose Lisma. Professor Ibrahim, are you ready?
I am ready, yes.
Okay, please start sharing your screen. Thank you.
Okay, can you see my screen?
Yes.
Right. So, how nice to see you all. My thanks goes to John Bennett and Sam Al-Morsi, and I say hello to all the speakers, participants, and I'm really glad to be with you here today, and thank you for your invitation.
Sorry.
My topic is on the sphenoorbital meningiomas, which I consider as a unique tumor. I will discuss my personal experience with you on those tumors. This is the Farah Medical Campus where I work, a very modern neurosurgical unit. And this is the black iris symbol of Jordan. So what about the sphenoorbital meningiomas? They are really unique. They are distinct category of tumors that originate from the dura of the sphenoid, i.e. here or here. And then they involve the sphenoid wing, they involve the orbit, they involve the cavernous sinus, anterior fossa, middle fossa, and usually they are associated with a carpet-like, this soft tissue component. So this is the unique thing about these meningiomas. This is like a sort of a post-mortem view of this meningioma involving the orbit, sphenoorbital meningioma. And there's something else unique in these sphenoorbital meningiomas, that there are a few published microsurgical series, few published endoscopic series on this. In fact, much more rare papers on endoscopic use for sphenoorbital meningiomas. And the other thing about these tumors that they have high recurrence rates. So if you look into literature, and you will find a few published microsurgical series and a fewer on endoscopy series. Although endoscopy, I believe it is the future of neurosurgery, it will give you better visualization. And in this case, they claim that they have concomitant air sinus involvement therapy and concomitant middle fossa involvement therapy. So this is endoscopic transorbital approach for these tumors. And if you look into literature, as I said, few literature are there. And this is a unique paper, actually. It's combining microsurgical surgeons, Joseph Marron and Miranda, with endoscopic surgeons, Gardner and Schneiderman, talking about round-the-clock orbital approaches. From Italy, also from Locatelli, again, the sphenoorbital meningiomas as a target for these endoscopists. Another paper from USA, again by Schwartz, again attacking the lateral wall of the orbit by an endoscope. From Italy also, this paper about 14 cases. But the thing about these approaches of endoscopy, that they are all subtotal resection. So this is pre-op, this is post-op, there's still a tumor there, and so on. But again, I stress the fact that it's endoscopy is the future of neurosurgery. So this is the incision, and this is the flap that they raise, and this is going into the greater wing of sphenoid. Again, from Italy, Paolo Cavabianca and Cavallo, Luigi Cavallo, published this paper about endoscopic approach to the orbit in general. So sphenoorbital fissure, then you go for the greater wing of a sphenoid, and you can see the middle fossa dura there. Not even the sphenoorbital meningiomas are amenable for this technique, but also the temporal lobe pathologies like tumors and so on. Again, from Paolo Cabianca, where they have used this endoscopic approach for specifically sphenoorbital meningiomas. So it's really a very good view, and I think the future is there. Another paper from South Korea, 2019, about the use of endoscope for this sphenoorbital meningiomas. This is pre and post-operative, and this is the approach. And another paper from South Korea, 2021, about the optimal indication for these sphenoorbital meningiomas. They classify them into ABC approaches for these tumors. So the other point about these sphenoorbital meningiomas is that they have high recurrence rates. And in literature, it's 35% at 5 years and 55% at 10 years. So these are notorious tumors to deal with. And that's why they are unique. This paper from my friend William Caldwell in Salt Lake City, 2017, speaking about this preoperative, where there is total resection here, postoperative, but there is recurrence after 5 years. So even when you do radical excision, there is high rate of recurrence. And this is the uniqueness of these tumors. Another paper from Japan to 2019 showing this recurrence of the sphenoorbital meningiomas after 10 years. They excised it and then it recurred again after 19 years. Now I'm going to tell you about my series, my personal experience with these cases. I had the opportunity of dealing with 55 cases. As you would expect, females were more. Average age is 38 years. Whether they are on the right side, on the left side, for no good reason that I can explain, they are more on the left side in my series. And I had 2 cases where they had bilateral sphenoorbital meningioma. This is one case, and this is the other case. In my series, I found 4 cases were on hormonal therapy, trying to find the relation between development of these meningiomas and hormonal therapy. And I had 2 cases with meningiomatosis. Presentation, as you would expect, mainly proptosis or optic nerve involvement, blindness, and so on. But other presentations are there, like cranial nerve seizures and so on. And this is the frequency of these presentations in my series. As for proptosis, if you look to the patient when he's face-to-face, if there's not a large proptosis, then you would miss it. So the best thing to do if you want to diagnose proptosis by clinical examination is to look from above the head of the patient. So in this patient, you can spot it immediately. In this patient, you may have some difficulty seeing it. So the best way is to look from above so you can appreciate immediately the proptosis. Of course, you can go always to the Frankfurt plane where you can see and measure the proptosis, and you can compare the proptosis preoperative and postoperative. In my series, in my practice, I do full ophthalmological examination, visual acuity, fields, fundoscopy, OCT, evoked potential, and exophthalmos measurement. So these are the visual fields that we do for all patients, pre and post-op. And I use the visual score, which was invented by the German Ophthalmology Society. They combine the visual acuity and the visual field. It's a very good thing to compare preoperative and postoperative visual score, pre and post. Fundoscopy is important, optic OCT, evoked potentials, and in every case in my series, brain surgery, I do Karnofsky performance scale. Not only for metastasis, as people would think, I do it for almost every case. Images that I'm going to show you are from my personal series, and I will show you the use of these images for diagnosis. So CT can show you the amount of involvement of the greater lingual node and the middle fossa. You can use the 3D CT to show, like this case of mine. And we concentrate on the anterior clinoid process. We'd like to see whether it is aerated or not, because if you want to drill the anterior clinoid, which is almost in every case almost, then you need to know what type of aeration there is. And this very beautiful paper about the types of aeration of a clinoid process. So the anterior clinoid process gets aerated through the orbit. So the air goes through this here into the anterior clinoid process. So this is type 2, and this is type 3, where you have full aeration of the anterior clinoid process. So if you want to drill it, you have to be aware of this. You can see the amount of bony involvement of the anterior clinoid process and the optic canal. And you can compare your results pre-operative and post-operative. So here, the anterior clinoid was totally involved. This is the optic canal, which was opened, and the anterior clinoid drilled. And this is seen here where the severe orbital fissure was also opened. So you can compare pre-operative and post-operative. MRI is very useful. You can see the amount of involvement of the orbit. You can see a dural tail of the tumor. You can use the Fiesta sequence to see the tumor well. MR angiography. In this case, it was very useful. You can see here the ophthalmic artery jumping over the optic nerve to the lateral side and then jumping over it to go to the medial side. You can see it here clearly on this normal left side, but on the right side, you don't see it. You can do proper angiography and see the ophthalmic artery because it's important in these cases. And venography is also important to see the superior and inferior ophthalmic veins and the drainage to the cavernous sinus. I sometimes use the isotope to give me a clue if I have any doubt on the diagnosis. In this case, we had doubt on the diagnosis that this could be another pathology, so we did this isotope. So what are the structures involved in my series? You can see that the orbital roof could be involved, as in this case. The lateral wall, as in this case. The apex of the orbit. The superior orbital fissure. The optic canal. The fat, the orbital fat. The sea of fat, the yellow sea of fat. All of the orbits could be involved, as in this case of mine. Cavernous sinus could be involved. Frontal bone. Temporal bone. Temporalis muscle, totally involved. Subcutaneous tissue even can be involved, as in this case. Floor of the middle fossa. Going into the infratemporal fossa. Pterygopalatine origin, pterygopalatine plates. And the air sinuses. Here, frontal air sinus is involved. Remote sinus is blocked here. Sphenoid sinus is invaded. Even maxillary sinus can be invaded. So this is a really aggressive tumor, and this is the uniqueness of this tumor. Brain invasion can happen in these tumors. Invasion everywhere can happen. So the surgical approaches that are used in this kind of pathology, frontotemporal, fronto-orbitozygomatic, transpalpebral, people use, I did not use that, transmalar and transcranial. These are the general approaches. In my series, I use the pterional approach in most of the cases, fronto-orbital or transbasal. I use the image guidance as part of the equipment that I use because you need to see through the image guidance the amount of bone involved. You need to know how much drilling you want to do, and you want to be aggressive in doing the drilling because this is the success of surgery depending on this. So to take you through the surgery, I have to take you first through some of the surgical anatomy that one needs to know. We need to know the sphenoid bone anatomy very well in the AP view and the lateral view. And then if you add to the sphenoid bone, the ethmoid bone, and if you add the palatine bone, and then you add the frontal bone, and you add the maxilla and the zygomatic arch, the zygomatic bone, so you get to the orbit, and here's the greater wing of sphenoid. So we are speaking about spheno-orbital tumors. So you got to know the anatomy of the orbit very well. You are going there. You should not go there unless you master the anatomy. And as Dr. Baskaya said, you have to master the anatomy. And there's nothing called minimally invasive surgery. Every surgery in the brain is maximally invasive. It is what you do for your patient and save him from any harm. So rule of 7 bones, 7 muscles, 7 arteries, 7 veins, and so on. And the anatomy also through the annulus of Zinn, what is inside, what is outside, should be mastered completely. The extraocular muscles and their relationship, the optic nerve and the central retinal artery, the tarsus, superior tarsus, and the muscles that are inserted there, superior orbital, superior rectus is involving the eyeball, but we have levator palpebris superioris, and we have the molar muscles that are supplying the eyelid, and these can be a problem for you. So this is the superior rectus, as you can see it in the AP view, and above it is the levator palpebris superioris. And also we have, as I said, molar muscle that is going to the eyelid. So here we are, the superior rectus muscle going to the globe, and the levator palpebris superioris going to the superior tarsus, and with it is the molar muscle. Remembering that levator palpebris superioris is supplied by the oculomotor nerve, and molar muscle is supplied by the sympathetic. If you look at the orbit from above, this is the orbital roof. If you remove the orbital roof, you come to the periorbita. Through the periorbita, you will see the frontal branch and the fourth nerve. If you take that out, you can have medial compartment and lateral compartment of the orbit, and you have to have full anatomical mastership on these structures if you want to operate on these tumors. Also, you have to know the anatomy of the anterior clinoid, its relationship with the carotid, and the distal and the proximal rings of the carotid, because you will come across these structures, the carotid cave, the ophthalmic artery, going into the optic canal, remembering that ophthalmic artery comes from different origin. It's not only coming from the back of the carotid into the optic canal, it can come from so many other structures, and sometimes change the gear and change the courses. They can come from even the middle meningeal artery. The relationship of the cavernous sinus triangles to the anatomy of these pathologies. If you go through the orbit from the lateral aspect, this is what you see. And if you take them structure by structure, so you remove the bone, you will get to the lateral wall of the orbit. You can see the lacrimal gland here, and you see the orbital fat. As I said, it's called the yellow sea of fat. If you take that fat away in this cadaver, you can see the lacrimal gland, you can see the lateral rectus, and you can see the inferior oblique. And here you can see the apex of the orbit and the structures as they pass. Again, you have to master the anatomy there extremely well. The anatomy of the meningio-orbital band is extremely important because these tumors invade the floor of the middle fossa. So you have to go to the foramen spinosum, ovale, rotundum, and you have to go to the lateral wall of the cavernous sinus. So how to cut the meningio-orbital band is only mastered by doing cadaveric courses, as in this view. So once you unlock the cavernous sinus, and I think one of my colleagues is going to speak about unlocking of the cavernous sinus. So it's just suffice to say that you have to unlock the cavernous sinus to go after these tumors. So the 10 triangles of the cavernous sinus should be mastered. So the principles I adopted in my surgery in these cases is first to go through extradural approach, then intradural approach, and then reconstruction. These are the 3 steps: extradural, intradural, and reconstruction. And remember that you can do the anterior clinoidectomy either extradural or intradural, so you have to have the dexterity to do both. So the extradural means that you have to drill the anterior clinoid process, you have to open the severe orbital fissure, you have to drill open the optic canal, you have to go to the foramen rotundum or valley, you may need to remove the periorbita if it is involved, and you remove any pathology which is within the orbit. I'm going to show you now steps of the surgery taken by still pictures from my series. So this is the craniotomy. I keep the hair, elevating the bone flap. Most of the time you'll find this bone is involved, so you have to drill it. Now you have the frontal and temporal lobes there. Frontal lobe, temporal lobe, greater wing of sphenoid. You have to drill the greater wing of sphenoid, going medially, and then you will cut the meningio-orbital band. And then middle meningeal artery is cut here, and then going to foramen spinosum, of course, here, and then going to rotundum and ovale and rotundum. So from the foramen spinosum, you go to foramen ovale, and then foramen rotundum. And then you'll come to the lateral wall of the cavernous sinus. When I reach the cavernous sinus, I use the Doppler to make sure that I'm listening and hearing to the pulsations of the petrous carotid and the cavernous carotid. So here we have opened the roof of the orbit. We're looking at the periorbita. We have drilled the greater wing of a sphenoid, and we have cut the meningio-orbital band. We have opened the supraorbital fissure, which is, for me, is the crucial step in the surgery. The proptosis will not disappear unless you open the supraorbital fissure. and you can drill the anterior clinoid process extradurally. So here we are drilling the greater minimum sphenoid, opening the superior orbital fissure. This is periorbita, this is the anterior clinoid. Again, another view to show that we have to open the superior orbital fissure to accomplish any good result here. Now dealing with the periorbita and the pathology within the orbit, sometimes what I do is to have a stitch in the lateral rectus so that if pulling on that would show intracranially what we are doing and what are the structures that we are dealing with. So this is the periorbital fat, and the meningioma that was inside the orbit has been removed. This is one of my cases. Then we come to the next step, that is to go intradurally. And then, as I said here, the frontal dura, the temporal dura, open it, and then take the tumor, the soft tumor that we described. And then you'll find sometimes the middle cerebral branches are attached to the tumor. You have to go through these branches and remove the tumor from the optic chiasm and the optic nerve, remove it from A1 and A2. Here is the optic nerve, A1, M1, internal carotid artery. So this is the area that you are working intradurally. Again, remembering that you can do the clinoidectomy either intradurally or extradurally. Here we'll do the anterior clinoid process drilling intradurally. So you cut the dura over the ACP, you drill the ACP, you remove the apex or the tip of the anterior clinoid, and then you'll come to the roof of the cavernous sinus, and you can see the clinoidal segment of the internal carotid, the distal ring and the proximal ring. And then you will open the optic canal, you cut the falciform ligament. So here is joining both the optic nerve within the canal and the intracranial one. If the tumor is going through the optic canal, you follow it. Here is carotid and ophthalmic, so some tumor was going through the canal here. We have to remove it. You drill and remove all the involved dura, which is associated with these tumors. So this is the view, the optic nerve, the carotid artery, the oculomotor is there. Internal carotid, you can see the PCOM, you can see the A1, and you can see the optic nerve there. So this is the approach. And here you can see the sphenoparietal sinus. So this is the final view. The nerve is free. Internal carotid, PCOM, the superficial middle cerebral vein, and the sphenoparietal sinus, and the lateral wall of the cavernous sinus. So then we come to closure of the dura using dural patch, dermis patch, fasciolata, whatever you have, and then put a fatty graft there to fill the dead space, and then come to the third step, which is reconstruction. You have to construct the orbits, and you do duroplasty and cranioplasty. In regard to the orbit reconstruction, if there is no periorbital resection, then you don't need to do reconstruction. If there is a periorbital resection, then you have to do rigid reconstruction. However, having said that, if you look into literature, and I'm here citing these famous orbital surgeons like Maroon and De Monti and Talashi, in 200 cases, Maroon, he did not use any reconstruction. The same thing with De Monti in 56 cases, and Talashi again in 47 cases did not use any orbital reconstruction. And if you need to use, then these are the materials that you use: titanium plate, biometric materials, and the bioactive glass, calveolar grafts, midpore titan, and porous polyethylene. This is one example of the reconstruction that I do for my cases using the titanium mesh. And here again, the titanium mesh used for the reconstruction of the flap. Having shown you the still pictures, I show you the video to demonstrate what we have said. I'm going to go through that quickly. This is the orbital, this is the flap that we removed, and you can see that it was really involved with the tumor, so we drill it. And then we drill the greater wing of a sphenoid, removal of the orbital roof. Now concentrating on the severe orbital fissure. So here we are trying to open the orbital fissure here. Still, it's not opening well. So this is the critical step of the surgery. Full wide opening of the superior orbital fissure. Otherwise, the proptosis will remain because you have not freed the superior and inferior ophthalmic veins going to the cavernous sinus. So here we have good wide relief of the superior orbital fissure. We have drilled the anterior clinoid. We continue drilling here the greater wing of sphenoid. Anterior clinoid is being drilled intradurally, opening the dura, finding the tumor, and then detach it from the middle cerebral artery and vein. Here we are doing this, trying to separate this tumor in the same technique that we use with the vestibular schwannomas. So this is the last piece of the tumor attached to the middle cerebral vein, superficial middle cerebral vein. This is another short view of these surgeries. Again, drilling of, just showing you the steps running in a video rather than still pictures. Drilling of the greater wing of the sphenoid, and drilling the roof and the lateral wall of the orbit, going into the intradural step, and then drilling, opening of the optic canal, drilling of the anterior clinoid. The last piece on the tip of the anterior clinoid is the most difficult to separate, and if you find any bleeding, then you can control it with any other drugs that you have. In theater, this is the clinoidal segment of the, and here we are cutting the distal ring. And here we are opening the arachnoid around the oculomotor nerve. So, when we looked at the histology of these cases, grade 1 was the majority, 32, but we had 3 cases of a grade 3. And we looked into the histology. You can see the tumor involving the bone. So this is real involvement and invasion of the tumor. Brain invasion, not only bone invasion, but the brain invasion. This is a grade 3. And this is unique, the temporalis muscle being involved and seen in this cuts. We published this in the American Academy for Pathology, myself and my colleague, Dr. Bufarsakh, and we found that the hierarchy, this is about the last consecutive, I have more than 1,000 meningiomas, but this was the last consecutive 250 meningiomas, and we found that the higher Ki, the worse, of course, the higher P53, the worse, and the lower progesterone is the worst. These are our criteria that we published. And you all know that meningiomas are common in females. Grade 1 and 2 were commoner in females, but grade 3 was commoner in males. What about the visual improvement? 30 out of 55 improved. 21 did not improve, and 3 got worse. And those they did not improve because there was severe pressure on the optic nerve and chiasm, that there was some ischemia of the nerve, so they would not improve. And this is the improvement of the proptosis in 72% of cases. You can see the pre-op and the post-op. And I'm glad to say that I had no mortality in these cases. We achieved the gross total resection in 34 cases and subtotal resection in 21 cases. As Dr. Baskaya said, this is micro neurosurgery. Either you master it or you don't. If you don't approach these cases. And in spite of the aggressiveness of the treatment, I had recurrence in 15 cases. In the gross total group, I had 3 recurrences out of 34. In the subtotal group, the recurrence was more, 12 out of 21. So 15 cases, 3 and 12, 15 cases of recurrence. And this recurrence occurs 3 to 10 years after surgery. So what did we do with these recurrences? 15 cases of recurrence. We observed. We found that there was no progression in 3 cases. We found progression in 12 cases. What did we do? We used the gamma knife in 2, conformal radiotherapy in 3. We redo surgery and radiotherapy in 3. 4 cases refused surgery. Just to remind you that we have the gamma knife in Jordan one of the first countries in the world to acquire the gamma knife back in '96. This is me, 25 years younger. What about complications in my series? Oculomotor nerve was involved. 3 cases temporary, 1 case was permanent. Levator palpebral superiosis, 3 were temporary and none was permanent. Look at this case here, pre-operative. This is post-operative, and this is about 4 months after complete recovery. Same in this case, proptosis, ptosis, and then recovery. So most of these cases of the oculomotor nerve, they recover if you have actually maintained the anatomy of the oculomotor nerve. Other complications, yes, of course, 3 DVT, subgaleal collection, wound infection, CSF fistula, ischemia or infarction in 2, seizures in 4. This is some of my complications, extradural abscess in this case, venous infarction, which did not lead to any neurological deficit at all, CSF leak, which we corrected later on. The types of radiation that we use, the external beam radiotherapy, we don't have the proton beam, but we have the gamma knife. I'll show you some of the cases, and then we'll finish. This is the one of the cases which I told you, I said have 2 cases with bilateral sphenoorbital meningiomas. This is one of them. Of course, we attack this side because it is the culprit of her symptoms. We did not attack this side. So you can see the preoperative views and the proptosis. This is the CT scan showing the amount of bone involvement, the anterior clinode involvement, the narrowing of the optic canal, the narrowing of the severe orbital fissure, which you have to open if you want to have good results. And this is after surgery, and you can see that we have done a good job. And we followed her for 9 years. We were aggressive. So this is the result. 9 years follow-up, and there is no recurrence. And there is no change on the other side of the left side of the sphenoorbital meningiomas. Another case is this case from Kurdistan, from Iraq, 51-year-old female with this tumor. And you can see the amount of involvement and the proptosis. And this is the post-operative follow-up for 7 years without radiation. You can see the reconstruction, and this is the follow-up. Another case is this case from Yemen with this huge tumor, sphenoorbital tumor, and the proptosis there, and the result that we have achieved. We followed her up for 5 years. Another case from Iraq with this sphenoorbital meningioma, which was really a very difficult case, but we managed to do a very good job on her. Another case from Jordan, this tumor here, and you can see preoperative destruction. And we did a good total radical excision, and we continued the treatment because there was much bone involvement. We gave a Novalis radiosurgery, and this is the pre and post. And this is 7 years follow-up after surgery and Novalis. Just one case, the last case of this recurrent case of sphenoorbital meningioma. This case came to me from the West Bank of Jordan, from the Palestinian Authority, with this tumor. And we excised the tumor completely. And then 3 years later, she came back with some recurrence. What did I do? Just follow her up. And for 8 years, I followed her up, and there was no change. So you don't jump on these recurrences, you just wait on them. If they show progression, then you can treat. I'm reaching to the end of my presentation, and I've come to the conclusions. I believe strongly that aggressive removal of sphenoorbital meningioma is critical for a favorable outcome and tumor control, as I've shown you. But sometimes you are defeated because there is a residual tumor in the orbital apex or the cavernous sinus that you cannot remove. Then you can use radiotherapy or radiosurgery. I finish here. I thank you for listening, and I'm ready to have your questions and comments.
Thanks a lot, Professor Ibrahim, for this excellent presentation. Is there any question from panelists? The question here in chat box is about reconstruction of orbital floor.
Sorry, I did not hear that, Sami.
Reconstruction of orbital floor.
You don't need, most of the time you don't need, as I said, if there is major reconstruction, major involvement of the floor, then you do it. But most of these cases, rarely they involve the floor of the orbit. They involve mainly the roof, medial wall, and the lateral wall, rarely the floor. But if it is involved, then you have to reconstruct it. Otherwise, you'll have inophthalmos rather than exophthalmos.
Okay, thank you, Chair. And now we will shift to next speaker, Professor Jos. Please start sharing your screen. Thank you.
Okay, can everybody see that?
It's okay.
Yes, we can, Nick.
Perfect. Thank you very much. Professor Zbeir, that was an impressive talk. Thank you, John and Dr. El Morsi for having me to the Egyptian Academy. Salam alaikum wa shukran katir. My name's Nick. I'm the endovascular neurosurgery fellow at Mayo in Rochester. And I was talking to John this week about what we could talk about, and I've just returned from the WFNS meeting in Colombia, which was really great to see people in person again after a couple of years. And one of the things that struck me there was how really the organization of healthcare in different countries affects how we all treat the same condition in a slightly different way. And so that's what we're going to talk about today, is global healthcare models and their impact on neurosurgical services. I'm going to make it brief because I too am very excited to listen to Professor Dufault talking next. So we'll briefly cover general healthcare models. I'll speak a little bit about my personal journey and some of the lessons I've learned along the way. And then afterwards, I'll invite any feedback or comments. So if you really want to understand the delivery of healthcare, the key is, of course, to follow the money. And if you understand how healthcare is funded, then you get a little bit of understanding of the context of how it is delivered and what it does well and what it doesn't do so well. And the first of the four models that we're going to discuss is called the Beveridge model. William Beveridge was a British economist and a liberal politician in the 1940s. He was part of the Labour Party and really had a key role in establishing the British welfare state. And this model essentially is centered around the National Health Service that provides centralized care. So both the delivery of care is led by the government, and the government funds it. So there's a single payer with no competition. Healthcare is funded through taxes, but it is free at the point of care. And it is universal, so everybody is covered. It's equitable. It doesn't matter whether you're unemployed or a billionaire, you get essentially the same level of care. And because it is free at the point of care, there do have to be some safeguards against overuse. And unfortunately, funding is at the mercy of political agendas. So depending on whether you have a more socialist or a more conservative party in government, that has a very real impact on the budget that is allocated to healthcare. And of course, it does mean that you have to deal with the bureaucracy of government departments. But this is the predominant model that is used in the United Kingdom, Spain, New Zealand, Cuba, Malta, where I'm from, and even in the United States. So the Department of Veterans Affairs, healthcare is delivered in hospitals that are funded by the government, and it is paid for by the government. So a lot of countries will use a mixture of different models. The second model is known as the Bismarck model. So Otto von Bismarck was a conservative German statesman who was actually Chancellor of Germany from 1871 to 1890. And his vision, I guess, being a little more conservative, was for a more decentralized model of healthcare where employers and employees pay into these sickness funds that are essentially non-profit insurance plans. So through your job, you get an insurance plan, and then healthcare is delivered by private institutions. So the fact that you have a number of different private institutions means that there is competition between different institutions, and competition, of course, is a good thing to drive innovation and to support quality. But the downside to this model is that it does require employment for cover. So there's some immediately obvious issues with people who are unemployed or retired, who may struggle to fund their healthcare. And this is the predominant model used in countries like Germany, Belgium, Japan, France, and even in the United States. So there are some essentially disparities in healthcare that relate to firstly whether or not you're employed, and secondly the quality of your insurance. So if you get good insurance, then the moment you sneeze you can get a whole body MRI, but if your insurance is less good, then there are some clear limitations, and you're essentially at the mercy of the insurance companies. The third model is the National Health Insurance model, and this one blends a little bit from both the Beveridge and the Bismarck models. And here the government is a single payer, so the government acts as an insurance program, but the providers are private. So it's really a mix between the two. It does provide universal insurance. It's not for profit and therefore doesn't deny any claims. And it is generally seen to be cheaper and simpler than the Bismarck model. But because it is funded through the government, there are some limitations in place over what medical services are covered in order to control the costs. And generally, the main frustrations with this system are that it can lead to some long waiting lists and delays to treatment. And this is the model that is seen in countries like Canada, Taiwan, South Korea, and even in the United States, Medicare essentially is modeled on the National Health Insurance model. So you can see how the United States, for instance, really takes bits and pieces from all of these different models. And finally, we have the old-fashioned out-of-pocket model, which is mostly prevalent in rural areas, particularly in less developed countries, where essentially, if you're wealthy enough to pay for your own healthcare, you pay for it and you choose your own provider. It does, of course, mean that wealthier patients get better access to care. And this is generally because of insufficient funds or infrastructure to have an organized healthcare system. So it does unfortunately mean that many never see a doctor. And this is the model that we tend to see in rural parts of Africa, South America, India, China, and even in the United States. There are a good proportion of people who fall between the other models who, let's say, are not employed but not eligible for Medicare for whatever reason. So a little bit about my personal journey. I'm originally from Malta, which is a tiny island in the Mediterranean. It is part of the European Union, but culturally it is very much a melting pot between Southern Europe and the north of Africa. So the language, for instance, is based on Arabic, but it's an ex-British colony, and the healthcare system is modeled on the British National Health Service. Malta is part of the European Union, so when I graduated, Britain at the time was part of the EU, and so it was very easy for me to transition to postgraduate training in the NHS, and that's what I did. So I did my residency in the United Kingdom, and then when I finished, and I wanted to be an endovascular neurosurgeon, there isn't really endovascular neurosurgery training in the United Kingdom as things stand, and so I moved to the United States, which is where I currently work as a fellow at the Mayo Clinic. And I've accepted a faculty position at the University of Nebraska, so I'll be settling in the United States for the foreseeable future. But in terms of where I trained, this is the south coast of England. And in England, because there is a National Health Service, there are very clear territories that belong to each neuroscience center. So all of the area that you see here essentially covers 13 different hospitals that all feed into a single neurosciences center. And so what that means is that throughout the entire United Kingdom, there are only 24 centers that deliver neurosurgery. And so inherently, they all have large catchment populations. So for instance, where I trained, we covered a population of just over 3 million people, which meant, for instance, that you had a guaranteed, 180 ruptured aneurysms a year. And that's without essentially making any effort to advertise and market your services. There's roughly one neurosurgeon for every 200,000 people in the country, compared to one for 80,000 in the United States. And that has some bearing on what conditions are covered by neurosurgery versus covered by other specialties, because there are essentially very few per capita neurosurgeons in the United Kingdom. And so they're clinically very busy, which is good in a way. They have a guaranteed case volume, and they can also divide labor because they're salaried and there's no financial incentive for taking on extra stuff that you don't need to take. So for instance, where I trained, of the 15 consultants, 2 of them did vascular only, 2 of them did tumor only, 2 of them did skull base only, etc., etc. And there's also centralization of care for rare conditions. So for instance, the pediatric ependymiomas only go to 2 or 3 centers around the entire United Kingdom. And we know that for complex and rare conditions, that case volume is very, very closely related to outcome. So that's a good thing. So, services are streamlined, but the pathways are often rigid, which can sometimes lead to frustration. It's good that there are clear boundaries. There's no competition, so it's kind of easy. You just, the work comes to you. But because people are very busy clinically, it does mean that the peripheral parts of the specialty get sent elsewhere. So, for instance, peripheral nerve surgery in the UK is done by orthopedics and plastics. Carotid endarterectomy is done by vascular surgeons, and endovascular neurosurgery is done by radiologists. So the good things with this model are that clinical decisions are made free of any financial pressures. The service does have to rationalize resource utilization, although we very rarely denied patients treatment on the basis of cost. There's significant purchasing power from when the whole country is essentially one service. So, if the NHS wants to go to Medtronic to buy a catheter, they will buy it for roughly half the price what it costs a hospital in the United States for exactly the same catheter. And that's because of the economy of scale from a single buyer. And to some extent, there are efforts for a unified medical record, although there are some issues with that as well. But the downsides are, as I mentioned earlier, you're at the mercy of politicians, and over the last 10 years, waiting lists have got progressively longer. And because everybody is so busy with their clinical workload, there is sometimes limited appetite for innovation, research, and networking. In contrast that to the United States, where healthcare is delivered by a mixture of academic and private institutions with variable practice sizes and volumes, there's a lot of competition because healthcare is lucrative, and that competition drives a very dynamic and motivating environment. Hospitals have a strong incentive to innovate and to be efficient, and generally surgeons are treated quite well by the institution because they're valuable to the institution. And because it is lucrative, of course, there's also this incentive to take on all of these peripheral procedures. So, neurosurgeons in the United States will do peripheral nerve surgery, they will do endovascular surgery, and some of them will do carotid endarterectomies as well. There is a culture of second opinions in this country, which is a good thing. So it's a very patient-centric model. So, if a patient goes to see a provider and they're not entirely sure they like what they've heard, they often do go and seek a second opinion. That comes with its own disadvantages, because if you go and see enough people, eventually you're going to find someone who's going to do what you want them to do. And so, unfortunately, to some extent, that leads to some providers essentially pandering to their patients and doing what the patient wants rather than what is right for them. And the downsides to the organization of healthcare in this country is that sometimes it is a little bit fragmented. There isn't a unified medical record across different centers, and it is very expensive. So it represents pretty poor value for money, because there's a third party involved, which is the private insurance companies. So what have I learned from training in different countries and from meeting people at particularly at meetings and on platforms like this is that actually, despite all the differences in our countries, we're more similar than we think. We often share the same frustrations, and we all have the same desires for our patients. And it's through platforms like this and through the efforts of the Egyptian, the EWNC and John's platform that the world is really getting smaller. I would say that there's pros and cons to every system. It's easy to get frustrated, and pretty much everywhere I've worked, people have their own frustrations with their hospitals. But the grass isn't always greener on the other side. There are problems elsewhere. I think it's also fair to say that the standard of care for the same treatment isn't necessarily the same in different countries, because it is strongly influenced by the resources and the organization of services in different countries. If you are in training, I would encourage people to mix things up as much as possible. You need to leave the cave to figure out what you don't know. And wherever you can, take the opportunity to travel. I used to feel quite self-conscious about approaching people for a visit, but actually, I think most of the time when you ask someone for a visit, you're essentially complimenting them, and most people are very receptive, and you never know where that might lead. So if you're thinking about organizing a visit somewhere, particularly now that things are dying down with the pandemic, I would say stop thinking about it and just do it. People will be receptive to you. That's all I've got to say. I put my contact details on there. If there's anyone in training who wants to discuss my experience of training in different countries and the transition, I'm happy to talk. Please do reach out. And with that, I'll stop sharing.
Thanks a lot, Dr. Bob, for this excellent presentation. Is there any question from panelists? Thank you. Okay, Professor Lizina, please start sharing your screen.
You can see the screen?
Yes, it's okay. Just to make it full screen.
Okay.
Play.
Okay, it's nice. I can begin.
We can hear you. Can you make it presentation mode, please?
Yeah, and you can see the screen, pineal tumor?
Yes.
Okay, I have to, okay. Well, thank you. I hope you are watching my presentation. Thank you, Professor Elmore. Thank you, John. The supracerebral infratentorial approach for the pineal lesion. Okay. Oh. Okay, if you have some difficulties, let me know, because I don't have any ability skill for this kind of presentation.
Well, you know, Jose, you could put it on presentation mode. Tell them where to do that, Sam.
Okay, I need to put, but I don't know where.
Presentation mode. Where is the presentation mode, Sam? Could you help them?
Yeah, wait, please.
That's an Apple. I'm not used to working with Apple.
Okay.
Can someone tell them where the presentation mode is, please?
Yeah, I need to put soon.
Press F5. Press F5 on the computer. Press F5.
F5.
Okay.
On the computer. F5.
Can you see a triangle that it is written reproducer?
Yeah, but I don't know.
Next to that, reproducer.
Yeah,
Reproducer, arriba, reproducer.
Yeah, just click on that.
Reproducer, see, arriba, reproducer.
Yeah, but I don't know what is reproducer.
Está arriba. Sí,
Yeah.
reproducir, agregar dispositivo y reproducir. Eso es, perfecto.
Okay. Sorry.
Okay. Está bien, okay, go ahead, you can go. Oh, okay.
Okay.
Yes.
It's good?
Yes.
Okay, but the problem for the approach to the pineal region usually is because for the low incidence of the lesion in this region, we have only 0.4% of all of intracranial tumors. If in the pediatric population, this increase at 2.8. But I think it's not it's so difficult access approach to the pineal region. The problem for me is the low incidence in this pathology. Because the neurosurgeon training the resident, for example, in all the resident 5 or 6 years, probably get to look 1 or 2 or 3, and it's enough to approach without help this kind of tumor. Okay, we encountered in the pineal region several kinds of tumor. This tumor is propensity for mixed tumor, pathology, and heterogeneity. For this reason, we need obtain important samples, not only eye biopsy, because in a simple biopsy, maybe is one kind of tumor, but we miss the other tumor, probably more aggressive in the other part of the same tumor. The pathological confirmation is mandatory. Obviously, the anatomy is the more important for each pathology or for any pathology in intracranial. This is the most important than the old technology. And we see the tumor is located in this region above the splenion of corpus callosum, below the vermis, and in front of them, the most important is the colliculus. The colliculus superior is very important to know the match in the approach of this, in this region for the supracerebral infratemporal approach. Because this is very important, both colliculus and the vermis. And usually we had some fight to the vascular structures in this region, venous structure, but usually this structure are above the lesion. For this reason, this approach is so safe for the match these venous and arteries. We can see the vascular veins, both occipital internal vein, both Rosenthal basal veins, the precentral cerebral veins, and the great vein of Galen. Usually is not frequently we can see the internal cerebral vein in this approach. When you can see in the picture of the left, the vascular structure are just always above the lesion. The lesion is near of colliculus is the most important structure we have to save. We can see with the pineal region lesion, there are a lot of options. Watch, shunt, third ventriculostomia, endoscopic, stereotactic biopsy, radiation therapy, chemotherapy, surgery, endoscopic, or microsurgery. In the case of vein tumor, complete resection usually provides a cure. For malignant tumor, the removal of as much of the tumor as possible is so improve outcome and response to adjuvant therapy. In addition, the surgical removal of the tumor will provide tissue samples and resolve hydrocephalus. A lot of time is not necessary to resolve the hydrocephalus previous to the surgery, because we have a good surgery and we get to remove all the tumor. Will be the circulation of the cephalic is possible, and we don't need the other kind of recirculation or ETB or shunt. Approach of the region. We have several options. We use infratemporal supracerebellar, and the other options are a good too, and they're not one way in this, like the majority of the pathologies intracranial. What advantage has the supracerebellar approach? The center of the tumor below the major veins, gravity aids the cerebral retracting and decrease bleeding. The disadvantage is tumor extending laterally and inferiorly, surgeon fatigue, risk of air embolism, and post-operative pneumocephalus. What to avoid the air is compression and elevation of lower limb, oxycapnography, transesophageal Doppler, and irrigation and waxing. The position we use, the sitting position, table should be able to go low, head flex to keep tentorium parallel to floor, patient tilted forward, and is possibly 2 concurrent 3-quart prone. This is the sitting position or semi-sitting position we use in all patients and always. And this is important to flex the head. And it's important to the surgeon are comfortable because it's surgery to the arms. This is the correct, is very, very important. Long instruments are necessary. This is the way, it's a classic midline incision for the posterior fossa. Is we expose the sinus, and I personally coagulate and sectionate all the bridge points because I need to the cerebellum go down as possible. And this way we have a tunnel, and in this look, we look the both basal veins and the culmen, and in the end, we can see the quadrigeminal cistern. It's a long tunnel, but we don't need to diminish any brain structure. This is the quadrigeminal cistern, usually is whitening and soaked, and the culmen we have to decline. And this way, we are able to remove this tumor without ETV, without shunt. The circulation of LCRF is continuous, and this patient, several years later, and this is our patient. This is a 10 years old girl with an astrocytoma. You can see what we coagulate the bridging vein, and we go down the culmen, and in a little time we get to the quadrigeminal system, and we can see the both basal veins. This is the tumor. Basal veins, vein of Galen is up. And it's not so hard to remove the tumor, to get the third ventricle, and we can see the pulvinar, we can see the both fornix and the choroidal. It's at the end of the surgery, and we control by endoscopy if our resection is good. Sorry for the music. And we see the vein of Galen, corpus callosum, vein occipital interna, basal vein. ACP. third ventricle, chordoitil, both Monroe, foramen, pulvinar, fornix, this is the post-op. This is an astrocytoma.
Mira para abajo. Mira
Astrocytoma.
Eso, mira para el frente.
Astrocytoma grow from the parenchyma, and we can see a little damage of the superior colliculus. And this is the control
Mira para la pared.
several weeks after.
Mira para abajo. Mira para arriba. Mira a tu mamá de vuelta. Mira para arriba. La doctora del hospital se enteró.
And we see
Para acá.
several months after the patient recovered the gaze totally.
Para abajo.
The other case, this is a pineocytoma that was irradiated with gamma knife without biopsy, and the tumor grew on time 1 year later. And this is the third patient. We have we did the control with endoscope several years before, and we can see the total removal, thalamus, the great vein of Galen, basal veins, both pulvinar and total removal on this tumor. And this is a patient a lot of years after surgery. We can see the cavernoma in the inferior colliculus, and we got our plain strategy. We know we have to go above the fourth cranial nerve, and in this case we use a lateral approach, and this is the remove of cavernoma. At the end, we control the adequate resection of the cavernoma with endoscopy. It's a 4-part. And this is the post-op. This is the other case, a dermoid cyst. It's a pathology easily removal. In this case, the tumor is not the pineal gland. It's before the pineal gland, and in this case, we don't need to coagulate the precentral cerebellar vein. This is post-op.
No, pero con los ojos, sin eso. Mira para el otro lado con los ojos.
And the patient
Mira
have
para abajo.
difficulty
Mira para arriba.
to upgaze.
Eso, bueno, ahora mira la
But
cámara.
on time, we can see
Para
the
el
patient
otro,
recover
para
totally.
arriba. Eso. Mira para el frente.
And this is the several years after control. The other case, this is a arachnoid cyst in patient with some symptomatic. And for this reason, we decide to approach and with lateral approach, but in this case, we use the exoscope. This is a pathology with no need we are communicating the visceral and the parietal arachnoid to fenestrate with exoscope is possible too, and the post-op. And then we have the last case. This is a falcotentorial meningioma.
Presentamos un caso de una paciente.
And we can see can we use the endoscope.
Las mismas maniobras que con la técnica microquirúrgica.
It's very important to use a handling device. Then we put the microscope. We go dissecting the tumor with the microsurgical technique.
Acá estamos en la disección de la.
ها؟ چی؟
میگم باباشون خیلی عجله. مامان نیستن.
کجاست؟ ما برم بیاریمش.
همون بابا این.
And finally, we pre and post operate. Okay, a total of 127 cases of pineal tumor between 1990 and 2022. In my personal experience, 105 supracerebral infratemporal approach. Before surgery, we did 17 endoscopic ventriculostomy and 9 shunts. After surgery, 9 patient impairment of eye movement, 4 temporary. We have 3 intraventricular bleeding and 2 drowsinesses. This is the pathology. Okay, thank you, Professor El Morsi, and thank you, John.
Thanks a lot, Professor Ledesma, for this excellent presentation. Is there any question from panelists? Okay, thank you, sir. Professor Dufour, can you start sharing your screen?
Dr. Zhang, are you there? Dr. Zhang, he's the next speaker, right, Sam? Oh, I'm sorry.
Professor Dufour.
Okay, okay, fine.
Okay, I don't know if you can hear me.
Yes. Okay, can you go with Dr. Zhang, please? Please, Sam, can we try Dr. Zhang? Let's try Dr. Zhang, okay?
Okay, okay.
Okay, okay, go ahead, Dr. Zhang, go ahead.
Okay.
Yes, go ahead. Please introduce yourself and off you go.
Are you see my PPT?
Yes. Yes, we can see you. Yeah.
Oh. Would you? Okay. My lecture is about endoscopic ventricular surgery. We do many operations use endoscopic. Today, my lecture is about the tumor of the ventricle. The ventricle is classified of the lateral ventricle, third ventricle, and fourth ventricle. First, I use the endoscopic and port cortical approach. The case is a 6-year boy with a large tumor in the ventricle. is a large tumor. We use the endport to resect the tumor. After the tumor be removed, the armor shows the tumor disappeared. This is the boy. The second case is a cavernous sign is a hemiangioma. This is of the thalamus. After the tumor be removed, you can see this is the video. And no port. The tumor is of a thalamus tumor. Tumor being removed. We coagulate. We use suture.
Professor, can you please press 5? Then it will go into presentation mode. Nikoita F. Wu.
Yeah. Next, we introduce the trans-Callosum approach. This is a cavernous angioma in the septus placidium. This is the operative view of the tumor being removed. You can see the video. First, we expose the corpus callosum, and we resect, cut the corpus callosum. This is etiology. Is a tumor. Is tumor. The anterior septal vein. We cut the septal pellucidum. We dissect the tumor. Kind of. The tumor be removed. This is the foramen. We also use in the hemisphere trans-brachial approach to resect the tumor in the ventricle. This is a central neurocytoma. In the past, we use a microscope to resect the tumor, have tumor be removed. But now we use endoscope to resect the tumor. You can see this is another case of tumor be removed. You can see the video. This tumor. This we open the sinus system of the Galen system. This is preculus lobe. We call it the lobe. Into the ventricle. Dissect the tumor complex. We use suction to resect the tumor. After the tumor be removed, then we open the septal paleocytium, prevent the hydrocephalus. The post CT. The tumor in the atrium of the lateral ventricle is we have many approaches, such as cerebral, peritum lobar approaches, and perimedial theta approaches, and contralateral in hemisphere transspiritual approaches. We use parietal lobe, we use end port. This is not tumor, mini tumor. Of the tumor being removed. This is another tumor. We use end port. We use a Vitam extroscope to expose the tumor and remove the tumor. As you know, there are many part of the surround the atrium. You have optical radiation, but the superior and lateral is wall of the ventricle is blended by the optical fiber. So we can use hemisphere approaches and theta approaches. We use perimedial theta approaches to resect the tumor. We cut the tentorial and expose the tumor. The plex, cut the plex. tumor removed. We also use contralateral preculous approach to resect the tumor. This case is a large tumor. If you use the islip, the lateral, to expose the tumor, but we can't expose the lateral part of the tumor. So we use contralateral approach to expose the tumor. This is the tumor. We can flex and expose the tumor. Of the tumor being removed, the patient is recovery. You can see the video. This is a tumor. We use the right side to into the ventricle. This tumor is very hard. When we use CUSA and scissors to resect the tumor, we dissect the tumor. We cut the bleeding line. We suture the focus. Is our paper. Last is a temporal hole. This is a mini tumor. We use the endport to dissect the tumor. Next is the pseudoventricle. We classified the pseudoventricle is anterior part and the posterior part. To the anterior of the pseudoventricle, there are many approaches, such as laminar terminus approaches and transforaminal approaches, and extended transforaminal, transvenous, transchoroidal approaches, and transcallosal into follics approaches. Translaminar terminus approaches have and lesser approaches and LSO approaches. This is translateral approaches. Translateral approaches can resect the craniopharyngeal tumor. This is craniopharyngeal tumor. Is our paper. But it also can use LSO approaches. This is a tumor of cordoid glioma. The tumor is very hard. Of the tumor being removed. You can see the video. We expose the tumor. Laminar terminus. We cut the terminus membrane and dissect the tumor. It's very hard. We use the CUSA. The tumor be removed. We use surgical fluid. Tumor be removed. We also use transforaminal approaches. Also transcallosal approach or transcortical approach to enter the lateral ventricle. Then transforaminal approach to the pseudoventricle. In the past, we use a microscope to use transcallosal transforaminal approaches. This is a craniopharyngioma. We use this approaches. You can see the tumor be removed. But no, we use endoport cortical transforming approaches. This is the case with an endoport. Is a mini tumor. Dissect the tumor. Supply, blood supply. We cut the remove the tumor. The next case. Tumor be cut and removed. Tumor being removed. You can check this pseudoventricle. This is aqueduct. You see the post operative MR and CT. We also use expanded foraminal transversal coronal approaches. We also use a transcallosal approach and the transcortical approaches. This is anterior septal vein. This is a view. We can cut the vein and extend the transcorticoid. If the vein in this part, we don't cut the vein. We can use extra port or endoport. This is a craniopharyngioma. Dissect tumor. The tumor be removed. You can see the aqueduct. We also use transcortical approaches. We use endoport. This is a juminoma. This is many tumor in the wall of the ventricle. We dissect the fossa. We cut the vein. We use suction to remove the tumor. This part is unclear. This is residual tumor. We use radiotherapy. In the past, we also use transcallosal interfolix approaches. Use microscope. In the past, this is a craniopharyngioma. We also use this tumor. This is risk system. This. Next is the posterior part of the pseudoventricle. We also use many approaches, such as the trans-callosum in the follicles approaches, trans-corridor approaches, as extended transformal, transvenes, transcorridor approaches, and midline theta approaches, perimedial theta approaches. In the past, we use a microscope, but use trans-callosum in the follicles approaches. This is a cavernous angioma. Is of the middle brain of the tumor being removed. This is a teratoma. But no, we use trans-corridor approaches. In the past, we use trans-callosum approaches, but now we use endport trans-cortical approaches. In the past, this is cavernous angioma. We use a microscope to use the trans-callosum approaches. But now we use the endport to trans-cortical approaches. This is a video. Is from right side. This is the left side. ICV, we must use, we protect the ICV. Sucking the blood. Tumor be removed. Next, we also use a expanded transformer, transvenous, transcolloid approaches. This is the papilloma of the corridor plaques. We use these approaches to expose the tumor and remove the tumor. You can see the tumor disappeared. Another case is boy is a night tumor as a joint side tumor. Other tumor be removed. You can see aqueduct, post-common, and a pioneer recess. Tumor be removed. Left, we can also use the theta approaches, the midline and the perimedial theta approaches. This is midline. This is perimedial. Is our operative position. It is received and uncomfortable. This patient have do twice VP shunting in another hospital and gamma knife, but the hydrocephalus are also have. We use the midline, but we only open the right system of to expose the tumor. Only use right side. This is a complex and dissect from the brainstem. Like that. This is a VP shunting. But no, most operations we use perimedial theta approaches. You can see it's a mixture germ-cell tumor. We from left side, and we open the system. We dissect the arachnoid. The tumor. We use a mini resector to help the expose. This is a draining vein to the ICV. This supply, butt supply. The draining vein, we call it draining vein. It's draining vein. This artery. Detector vein, dissect from the brainstem. There's a small artery. The tumor have 5 type of pathology. Next, we use the left side. We call the brain vein. We open the system, and it is a pineal gland. We push the pineal gland up and open the pseudoventricle and expose the thalamus, the enormous thalamus, and cut the thalamus. Dissect the tumor. The tumor be removed. We use surgical the hem state. Surgery. Tumor be removed. This is our paper. Next is pseudoventricle. We use midline sub-occipital approaches to do many operation. This is a large tumor. A poor tumor. From lateral resist a tumor removed, conduct, and the pseudoventricle. The other hospital use the tube. This is we use the far lateral suboccipital approaches. This is a pabulum of choroid plexus. We expose the tumor and remove the tumor. Is post-operation CT. Conclusion. Neuroendoscope can complex the major right of the operations and can achieve better invasive effect. 5 years ago, our department can do almost all of the operation use endoscope. But in the future, we can use a robot, endoscopic, and endovascular surgery. Thank you very much. Thank you.
Thanks a lot, Professor Zhang, for this excellent presentation. Is there any question from panelists?
Yes, I have a question. I see that he is mostly using freehand endoscope. Is he also using sometimes a holder?
Okay.
Could you repeat it?
Yes, I see that he's using mostly freehand endoscope as it's very dynamic, but I'm asking him, is he also using sometimes a holder to steady things?
Yeah.
Did you get the question, Dr. Zhang?
Pardon?
Did you get the question?
Dr. Zhang, are you using a scope holder?
Professor James New?
Yes, the question is, do you use a scope holder during
Oh,
surgery?
yes, your holder. Pneumatic holder.
Pneumatic holder, like
Pneumatic
a Mitaka.
Mitaka.
Okay, thank you, sir. And now we will shift to next speaker, Professor Deveau.
Thank you.
Please start sharing your screen.
Can you see my slides?
Not yet. Oh, yes, now.
Yes,
Perfect.
it's
Perfect.
okay.
Thank you. Thank you for giving me this opportunity again to show my experience, 25 years of experience in the field of low-grade glioma, with now more than 1,000 awake procedures, and to introduce the concept of meta-networking theory. It's more or less the talk I delivered during the plenary session in the World Federation of Neurosurgical Society in Bogota a few days ago. Most important for me is not the technology into the operating theater, but just to help the patient living longer and better. And it's exactly what we achieved, because now with 25 years of follow-up in a large series of patients, we were able to increase the median survival around 17 years and the quality of life in 99% of patients. And to achieve this goal, first of all, what we have understood is that, of course, a tumor named glioma is diffuse, so invading the brain. So if you would like to remove it like a tumor mass, you will remove just the core. So that means that you will achieve a very good resection, a beautiful surgery, but finally, you will not change the natural history of the disease. And the proof is definitely obtained 5, 10, 15, 20 years later, when you are sure that your patient will live longer and once again enjoying a perfect normal life. So what we did is, first of all, to operate earlier. No wait and see attitude. And nonetheless, I continue to receive, despite the COVID, patients coming from 5 continents and a regular wait and see attitude. I cannot understand that because, of course, the tumor will become malignant and then we will kill the patient by doing nothing. Second, to achieve a real maximal resection, not to remove the core, but to remove the brain itself according, of course, to the functional boundaries. So that means that if you can achieve a supratotal resection, namely to go beyond what is visible on the preoperative MRI, you will see that really your patients can live longer. And third, to preserve the quality of life and to achieve this goal, we have to understand definitely how the brain is processing. Namely, not localizationism, but networks. When I started, once again, 25 years ago, the median survival in this kind of benign tumor at that time was 6 to 7 years. Then we started to publish in the French Glioma Consortium this first paper almost 9 to 8 years ago with more than 15 years of median survival by doing early resection. More recently, we published paper with my friend Luc Layandé in Nancy, with a young oncologist, and you can see by yourself that, first of all, the median survival are beyond 16 years, but that the vast majority of cases of patients enjoy a perfect normal life over 12 years. So that means that to live longer is not antagonist with a better quality of life. This is what we have learned about brain plasticity. But we have to be objective. And first of all, to understand that because the tumor is migrating along the white matter tract and not pushing the brain, because this is a diffuse glioma, then the vast majority of patients, at least over 50% of them, will experience some degrees of cognitive and emotional deficit before any treatment, just at diagnosis. So you have to do a neuropsychological examination before any treatment, which is never or almost never done. I do not understand why. And definitely, this is the absolute proof that there is no tumor mass. There is no delineation around the tumor, but a diffusion within the white matter tracts, because the connectivity is the limitation of neuroplasticity. So that means that there is already an invasion by the tumor itself at diagnosis of the superior longitudinal fasciculus, for instance. The patient will have already some decline of executive functions. This is a fact. Of course, you cannot be aware about it if you do not perform preoperative cognitive assessment. You will say the patient is not hemiplegic, is well. This is totally wrong. And this is the reason why we have to perform functional mapping, not only at the level of the cortex, but also the white matter tracts, the limitation of neuroplasticity. And to achieve this goal, because these tumors are located within so-called eloquent areas according to the traditional localizationist view, in Broca's area, Wernicke's area, central area, blah, blah. But in fact, it does not exist. It's a networking brain. And now you will see the interactions not only within networks, but also between networks. This is the concept of the meta-networking brain. And this is helpful not only for low-grade glioma surgery, but also high-grade for epilepsy surgery, for a deep access to a cavernoma, for BCI. Why not? To restore the brain. How do you want to operate and to restore the brain if we do not know the brain? So please use fMRI, DTI if you want. This is a very good tool for learning, for research. But at the individual level, there is no value. And I know it because I am the director of a team of research in this field. So I have the regret to tell you what you know already, that DTI is not a function, but just the structure, a reflect of the structure. And recently, there was a paper published by Engineering in this field today, I mean 1 year ago, telling, as you can see, that there is a very big variability in the size, shape, densities, and connection of white matter tracts for the same set of data, but analyzed in different teams. In other words, you cannot rely on fMRI and DTI, and you know that. But the vast majority of neurosurgeons would like to think that they can compensate their lack of knowledge based on the technology. And this is, of course, totally untrue. So please await the patient. Why? Because you will be directly connected to the connectome of the patient in real time. And of course, we will do electrical mapping. But most of all, we will achieve anatomofunctional correlation thanks to cognitive monitoring, both at cortical and subcortical level. So please select the good tasks to administrate, of course, to preserve the quality of life for the patient. They do not want to be hemiplegic aphasic, we have understood. But it's not enough in order to enjoy normal life, especially if you have more or less one generation in front of you. This is what we achieved now. So it's totally different to preserve the quality of life according to the occupation, hobbies, habits, leisures, lifestyle, and so on, but also according to the environment. But of course, we have to take into account this limitation of neuroplasticity. I will re-insist, namely the white matter tract, projection fibers, association fibers into the operating theater. The cortex is just the tip of the iceberg, not because not important, but because very plastic. So for more than 20 years, and probably until the end of my career, I will not use technology into the operating theater because I want to achieve good results. No neuronavigation shift, no DTI. We have seen it's not the function. No fMRI. You have seen it's impossible to make the distinction between critical areas you have to preserve versus compensable areas you have to remove if you want to achieve a more complete resolution and not just the core of the tumor. No intraoperative MRI, no microscope, no ECOG except for research purposes, and so on. So that means that everywhere in your world, you can achieve these results. To say we need technology is a false excuse. But we have also to understand that the brain is not just left dominant language and right non-dominant. Otherwise, your patient will have problems regarding the cognition, especially the spatial cognition, but also for accurate movement. It's totally different to be hemiplegic versus to play piano. For semantics, it's critical for human being to understand the concepts. Executive functions, to be able to do simultaneously many things, but also for the emotional processing, for the personality. Indeed, we tried to be very objective by doing extensive neuropsychological assessment after my surgeries. And you can see that 20% of my patients continue to experience, unfortunately, some degrees of cognitive deficits, especially regarding the executive functions. They are not hemiplegic, they are not aphasic, they enjoy my life perfect. No, they are not perfect. So we had to increase the level into the operating theater, and this is the reason why we propose to the patient to do many things simultaneously, just in 4 seconds, to move, to understand, to speak, to self-evaluate, and so on and so on. Every 4 seconds without any rest for 1 to 2 hours, the time to remove the tumor, according to the functional boundaries. So monitoring also the executive functions, multitasking, the sustained attention. So critical functions in order to enjoy a perfect normal life. And what we have learned, first of all, that Broca's area does not exist per se. This is not the area of speech. And we published that in Brain already 8 years ago, and we reproduced the same results between Montpellier, San Francisco, and Shanghai. So whatever the kind of language. So even neurologists started to understand that localizationism does not exist. Second, we introduced new tasks, and I cannot, of course, just in 30 minutes explain everything. But if you are dancer, for instance, the line by ascension task to avoid hemi neglect, while the tumor could be located within the so-called non-dominant hemisphere. What means I need my brain in order to be myself. And most of all, the emotional processing. We had beautiful discussions in Bogota about modification of the mood, of the personality, of the affect, of the mentalizing in this kind of patient. And finally, people who induced so many worsening in patients for many decades started to say, maybe we have to be careful about the quality of life of patients. Oh, really? What a scoop. It was time. So please map the functions by using, if you want, the DTI, the fMRI, the beautiful technology, but outside the operating theater. First of all, learn the anatomy. So please do dissection, and not just to see the white matter tract, but that cortical termination, in order to understand the cortico-subcortical networks, and then once again, their interactions. So weigh the patient, use neurophysiology and cognitive monitoring. And what will happen? You will preserve really the movement. Movement is not just to avoid hemiplegia. Of course, if you cut the pyramidal pathway, the patient will be hemiplegic, we have understood. Do not cut the pyramidal pathway. But there is another network interacting with the classical corticospinal network and involved in the control of movement. Once again, if you play golf or piano, it's not enough to avoid to be hemiplegic. This is another level. And you will say it's not mandatory for the patient, but you have not to decide for the patient. She have to decide before surgery. And then if they say, I want absolutely to continue to have a perfect mind-manual coordination, you have to weigh the patient, including in so-called right non-median hemisphere, and to task this bimanual phase, anti-phase, complex coordination of movement in order to preserve the frontostriatal tract, for instance. What means you can avoid to induce the supplementary motor area syndrome. You will tell me the patient recovered. No, they do not perfectly recover. They are not hemiplegic anymore. In fact, akinetic, as you know. But it does not mean that they can do very complex things. So you will tell me if you stop according to the FST and not the pyramidal pathway, you will leave tumor. Yes, but I will come back. I will come back a second time, 5 to 6 years later. I will come back a third time, 10 years later. And in the meantime, the patient will enjoy a perfect normal life and the tumor will not become malignant because I reduce the volume. So do not think just about one surgery. The brain is dynamics. This is the same thing regarding the somatosensory feedback. How do you want to operate in the right non-dominant parietal lobe? By telling my patient is okay because not hemiplegic, but he will have somatosensory disorders, including regarding the self-awareness of his own, her own body. We spoke about in the previous talk the preservation of the optic tract. You know the sole solution to preserve the visual field by avoiding anopia in 99% cases to weigh the patient and to stimulate and to say, and use phosphines or shadow, because with hemianopia, you cannot drive. You know how to avoid hemi-neglect? Otherwise, you cannot drive anymore. It's the line bisection. But now, at the level of the subcortical white matter tract, the superior longitudinal fasciculus layer 2 in the so-called right non-dominant hemisphere. And recently, we published this new paper in Nature Communications in order to better understand the neural basis underpinning the visuospatial awareness, which is absolutely critical and not against the median survival. Because even once again, if I left tumor, I will come back because in the meantime, mechanisms of neuroplasticity induced by postoperative cognitive rehabilitation, preservation of the connectivity, and return to work, at least to an active life. So interactions between networks. There is no one network in movement. There is no one network in language. But there are interactions also between these complex networks. Just speaking about language, dorsal pathway. Everyone knows the Arcuate fasciculus and phonological processing. Okay. We published now in Brain this week a paper just about the anatomy of the Arcuate fasciculus in brain by telling we do not know the anatomy because the vast majority of cortical termination at the temporal lobe are not running to the Wernicke's area, but at the posterior part of T2 and T3. How do you want to operate the brain by telling my patient will continue to enjoy normal life if we do not know the functional anatomy of the brain? many sublayers at the level of the ventral semantic pathway, so constituting the so-called inferior frontooccipital fasciculus, and of course involved in semantic processing. Basally speaking, the inferior longitudinal fasciculus. If you cut it, you will induce increase of reaction time, at least regarding the lexical axis. Maximally, you can induce aphasic anomia. So we have to understand also that the posterior part of the inferior longitudinal fasciculus is involved in reading. I mean, of course, today, especially thanks to iPad and so on, many patients can say, it's not absolutely critical for me to have a perfect reading, so please remove more tumor. Okay, if you decided before, but we have, as neurosurgeons, to explain that to the patient, where to stop à la carte, or to push the resection. We have to understand that metacognition, namely knowing of knowing, is underpinned by a bilateral circuits, and especially thanks to the inferior frontooccipital fasciculus, not only in the left hemisphere, but in the so-called right non-dominant hemisphere. When you stimulate it, that means that the patient will have understanding disorders, not only regarding language, but also non-verbal semantics. But the world is telling me so many things every day. I suppose this is the same thing for you, and it's not talking to me in my language, so I have to understand it. Regarding the personality, once again, we're trying to be objective. So we published recently a paper by analyzing my patients regarding their mood, their behavior, and what happened. Of course, many of them changed, at least modulated a little bit by becoming more irritable or more disinterested and so on. So is it possible to preserve these kind of functions into the operating theater? Because this is critical to be a human being. Yes, it is. So please introduce a task, namely to recognize the emotion expressed by faces in front of you. And what will happen, you will see that not only some cortical hubs can be critical for this patient at a time, but also white matter tracts, and I will not insist, but the right IFOF, but also the right cingulate. It does not mean that you cannot cut the pathways in all patients. That means that it depends on the reorganization occurring before surgery, but also before second surgery, if you would like to reoperate, before third surgery. So thinking about your own dynamic planning 10 years in advance. Yes, it's possible to think like this. This is the reason why my patients are living 17 years in the prospective collection of data. They have understood also that they are sublayer in the right non-dominant IFOF with different subfunctions. And finally, we introduced more recently the task of self-evaluation, namely, are you sure that the answer you provided during these tasks is good or not? And so patients can give a wrong answer and to say, I am sure. So that means that they are anosognotic. How do you want to return to a normal life for the next 20 years if you have these kind of problems, if you're not hemiplegic? So what means non-dominant hemisphere? If you have understood, perfect. For me, it's very clear. This is not right non-dominant. And to prove it, I will publish next month in Neurosurgery my own series, before and after awakening the patient in the right insula for right insular low-grade glioma. You can see my first series under general anesthesia to severe hemiparesis. Now, no hemiparesis anymore, because I stop according to the IFOF, which is lateral to the anterior perforating substance. But you can see also that the return to work in my first experience was 82, now 95, which is not enough, but we tend toward almost 100%. And the extemporization, the same. No, it's not possible. Of course it is. It's because now we have understood how to deal with this connectome. Not completely, but we tend toward. So what about the reasons? Otherwise, I can say what I want, but I demonstrated nothing. So the first almost 900 patients I operated on with low-grade glioma located in so-called eloquent areas, Broca's area, the Vernicus area behind the labia vein, the central area, the corpus callosum, blah, blah. Okay. Mortality 0, because I have a good team. It's not forbidden. It's not expensive. It's not like to have a brain suite. 0.5% of severe permanent deficit. We have to be humble. The risk zero does not exist. But in 99% cases, we return to an active life. And you can see that not only we preserve the cognition in the vast majority of people, but also 10% of them improved in comparison with before surgery, because remember, 55% of them were not perfect. 94% of return to work. I will now really to tend toward 99%, plus 80% of positive impact on epilepsy. So improvement of the quality of life. You will tell me once again, you administrated too much task into the OR. So it's again the median survival. Really? More than 17 years. No, because I reoperated on so many patients by playing with these dynamics. And this is the reason why we have to understand what means neuroplasticity and meta-networking brain, because the compensation is thanks to the contralateral hemisphere. And we understood that when we induced transitory supplementary motor area syndrome, there is a decrease of the interhemispheric right-left connectivity. And when a patient recovers, a re-increase. So we have to take care about this connectivity, not only within hemisphere, but between hemispheres. And then suddenly the brain will tell you if the tumor is growing again, which is the vast majority in more than 90% tumors, because they are diffuse, they will come back. So the core of the tumor means nothing. Then the brain will tell you, okay, please reoperate me because I changed in the meantime. It's exactly what we did in so many patients now in the so-called primary motor cortex, in the so-called left dominant hemisphere, or also doing bilateral lobectomy, preserving the quality of life. And you can see that the median survival in this sole paper published in the literature by our team past year, 18 years. Why preserving the quality of life, the cognition, the return to work? Why doing more and more supratatorization? So resection according to functional boundaries. Why reproducing these beautiful results by doing a multi-center study recently between Montpellier, once again, San Francisco, Calgary, Udine, and so on. You can see by doing earlier resection, the 10-year survival is over 93%. This is really the proof that we can change radically natural history of the disease, while 97% of return to work in incidental diffuse low-grade glioma. You can achieve these results if you know the limitation of neuroplasticity. So please try to have this kind of atlas in your mental imagery. Please try to elaborate new model of cognition. We are first of all neuroscientists. We are not just technicians. And of course, in order to help younger people, we published this 2000 stimulation sites in the Soul Anatomo-Functional Atlas in the literature, taking into account the fact that these cortical and subcortical networks are critical. And of course, more and more, we have seen the interactions between networks because this is the principle of behavior adapted to the environment. This is the principle of meta-networking brain. And I like to insist on the fact that we published in physiological reviews, so beyond surgery, in oncology, but in the Bible of human physiology. In other words, it is now officially accepted that localizationism does not exist. And what means into the OR to conclude? You ask a patient to move, to speak, he will continue to move alone, to speak in isolation. But when you will stimulate, he's not able to do both simultaneously. Of course, you can continue. The patient will not be hemiplegic aphasic, but it will not return to normal life. And the next step will be to learn the concept of metaplasticity, to change the mechanisms underlying the compensations during and after surgery. So to conclude, for younger people, and I like to insist on that, if you believe too much on technology, you will become addicted and never you will achieve this kind of results, because never the robot will tell you oh, maybe you can remove more because the interactions between the three networks could be compensated after surgery. You have now the choice, or to be just a surgeon, to be involved in technology, to be happy by your surgical act, and that's it, or to see if you can change radically the life, the quality of life, the survival of your patients as human beings. I made, I hope, the good decision this past 25 years. You have just now to ask to you and to your patients what you would like to achieve. If I did it, you can do it. So good luck. Thank you so much.
Thanks a lot, Dave, also for this excellent elaborative lecture. Is there any questions from panelists?
Yes, there's a question by Uday Gupta, Sam.
Okay, go ahead, John.
Okay, Uday Gupta of India says, great presentation, sir. What investigations should I advise to patients while evaluating a glioma? Please recommend some good text on connections and neurosurgery. Thank you.
Kind of investigation, it's too extensive. Before surgery, you need a 3 hours cognitive assessment. After that, you have to do nonetheless the DTI in order to better understand and to make the anatomofunctional correlation, not into the operating theater, but for your planning, especially if your surgeons are younger, in order to implement their mental imagery. Third, you have to select the tasks according to what we like to preserve the patient. It's totally different if who is a mathematician, for instance, compared with a taxi driver. Fourth, into the operating theater, we have to make this correlation between the stimulation of the white matter tract, so the connectivity, with the knowledge we have about our own atlases, but also adapted to the DTI of this patient, and his willingness to preserve these kind of functions. I mean, for instance, to be able to do 5 things simultaneously, or to speak 3 languages, and so on and so on. And of course, you will adapt this cognitive monitoring by telling, I can push a little bit more according to the natural story of the disease, because if the tumor is growing very fast before surgery, then maybe you can accept to induce small but objective deficit, but not for a long time, because you know that the patient will have post-operative radiotherapy. If it's a slow-growing tumor, then you can push more to induce a transitory deficit, because the patient will have time in front of him or without any adjuvant treatment. Or the reverse. If you know also that you will not achieve a complete resolution in this case because invasion of an input or output, then you know that you will come back. So it's better to leave a little bit more tumor by explaining before surgery to the patient, can you accept to be reoperated in 5 years? And the answer in the vast majority of cases will be, yes, of course, if I enjoy a normal life. So post-operatively, you will have again to do an extensive neuropsychological examination and to elaborate rehabilitation planning according to this full equation, and to meet again the patient regularly in order to adapt her quality of life, including to work half time initially, for instance, to push a little bit more the plasticity and so on and so on. And you see that you will do approximately every 1 year neuropsychological assessment. So this is a full equation. And that means that we will make finally the next strategy altogether with the patients who, in the vast majority of cases, in my experience, know the natural story of the disease and the brain dynamics much more than 90% of the oncologists I know.
Thank you. Any good text? Any good text you can recommend on connect?
Of course, the Dufault you have in front of you.
Oh, okay. Self-referral. Okay,
Thank you,
Sam, back to you. Back to you, Sam.
Thank you, sir, for this explanation. And now we will shift to next speaker, Professor James Leo. Please start sharing your screen.
Can you see my screen?
Yes,
Okay. Can you hear me loud and clear?
yes.
Okay. Great. Thank you, Sameh. Congratulations on a wonderful symposium. Thank you for organizing this, and following Professor Dufault is a hard act to follow. That was an amazing body of work, a career lifelong experience. Today I wanted to share with you some techniques on accessing difficult, complex skull base and vascular lesions, particularly for the paraclinoid region, and to unlock the cavernous sinus. So Professor Dwight Parkinson, taught us many years ago of the cavernous sinus, and that this is the lateral sellar compartment, and that this is an extradural anatomical jewel box that houses many critical structures, including the carotid artery and the cranial nerves. And Professor Dolence taught us many wonderful techniques on accessing the cavernous sinus. And we also have to give credit to Professor Roten, who really emphasized using X-ray vision to visualize some of these deep targets behind the layers of the dura. So the technique and the approach that I typically use to get to the anterior cavernous sinus for most of these lesions is the one-piece modified orbizygomatic, or otherwise known as the orbitopterional approach. And this really is the workhorse for anterolateral skull base lesions to get to the paraclinoid region for many vascular and neoplastic lesions. And this shows a typical frontotemporal skin incision, where we like to harvest an extended vascularized pericranial flap for reconstruction, and then using a one-piece technique which allows us to incorporate the orbital rim with our frontotemporal bone flap. And to do this, you really have to use the McCarty burr hole to really allow us to do this one-piece technique to disarticulate the orbital rim from the orbital roof. So when we get our extradural exposure, we can decompress the orbit along the superior and lateral orbital roofs, and we want to identify and decompress the superior orbital fissure and identify the meningoorbital band, because this band, otherwise known as the orbitopterional fold, is really the gateway to unlock the cavernous sinus. And so there's many ways to do this, but we typically cut this meningoorbital band, and we cut it along the temporal surface of the enteroclinoid process. And you start peeling the dura propria off of the inner layer of the cavernous sinus. And it should peel like an orange, so that you can expose this cavernous sinus from front to back. And it allows you to expose V1, V2, V3, and then expose the optic canal as well as the anterior clinoid process in preparation for clinoidectomy. And when we perform the clinoidectomy, there's different indications, which we'll go through later. But when you're doing this peeling, it should peel off of the lateral wall, much like an orange. And if you're feeling any resistance, you have to reconsider that maybe you're in the wrong plane. Or sometimes there are dense adhesive periosteal fibers that you have to cut sharply to really release that lateral wall. And to understand this, you have to understand that the lateral wall of the cavernous sinus comprises of two layers. The outer layer is the dura propria, which is contiguous with the temporal lobe dura, and the inner layer is a periosteal fibrous layer that ensheaths the Gasserian ganglion as well as the cranial nerves. Generally, there are three approaches we can take to the cavernous sinus. The Hakuba technique is really peeling from front to back, starting from the superior orbital fissure. There's the Kawasi's approach to get to the posterior cavernous sinus by peeling the dura propria off of the middle fossa to expose the anterior petrous apex. And then the Dolence approach, where we open up the oculomotor trigone and cut the tentorium from the superior side. When we do the anterior clinoidectomy, we can do this extradural, which I often do. And the key here is to unroof the posterior orbit and the optic canal, and then expose the superior orbital fissure. And these two structures generally make roughly a 20 to 30 degree virtual angle for the surgeon, so you can identify where the anterior clinoid process is. And sometimes these clinoids can be quite large. They can be hyperostotic in meningioma cases, and oftentimes we will do a hybrid technique where we drill off roughly 90 to 95% of this extradurally, and then remove the remaining tip intradurally, which we can do after opening the dura and taking off the rest of the clinoid. When you expose the clinoid process, you will see at the base of it, the clinoidal segment of the carotid artery. And this is an important anatomical feature in that it is both extradural and extracavernous. And it's important to identify this because in vascular cases like paraclinoid aneurysms, this gives you that proximal control of these aneurysms, as well as the concept of a proximal control of the optic nerve. And this is important when you're dealing with large tumors that are displacing and distorting the optic nerve intradurally. And oftentimes it's hard to find where that optic nerve is. And so it's nice to have an extradural anatomy to find normal anatomy proximal to it. And so this is the view that you would get once you open the dura and get a hybrid intra and extradural exposure. You want to have this concept of early identification and early proximal control of both the carotid and the optic nerve. And this is important when you're dealing with pathologies that really distort or encase the carotid artery and distort the optic nerve. And you want to be able to find normal anatomy in order to preserve the distorted anatomy intradurally. So by the end of this, this is an example after excision of a large complex clinoidal meningioma. You could see the optic nerve is decompressed going into its optic canal and dural sheath. Here's the clinoid with the clinoidal segment and distal dural ring, and then the third nerve with fully decompressed going into the cavernous sinus to get this type of view at the end of your removal. And so the indications here are really for the clinoidectomy is if you want early identification of the ICA or optic nerve, but also early decompression of the optic nerve if the patient has visual loss. Let's take a look at some case examples. This is a spheno-cavernous clinoidal meningioma. You can see there's some extension into the petrous apex and posterior fossa, as well as some invasion of the cavernous sinus wall there. This is elevating the MCA, so I typically like to have CT angiogram studies, but you can see, look at the T2 edema. This is a sign that there's some peel invasion. And you can see there's some partial encasement of the MCA as it's elevating the MCA superiorly, but also be careful and look for the posterior communicating artery. This is the PCOM going back to P1, P2 junction. So be aware of that. And so if we do this technique from a skull-based perspective, we're peeling the dura propria, and the advantage is that we're going to be able to resect the dural origin of these tumors. So if we do this from a purely intradural perspective, you're working from inside to the periphery, but by peeling the dura propria, we're separating the extracavernous from the intracavernous, and we can also potentially resect the dural origin, which is the lateral wall of the cavernous sinus, to get a more complete removal. And by peeling these layers, again, we're able to separate the extracavernous from the intracavernous, And for most pathologies like meningiomas, we can leave the intracavernous component and save that for radiosurgery if needed. So this is the incision. We'll do the one-piece orbitopterional approach. And then here we've exposed and decompressed the orbit and the supraorbital fissure. And so we'll now cut the mini-orbital band sharply. We'll land on the temporal surface of the clinoid process and start the peeling exposure using the Hakuba technique with a heavy dissector, peeling from back to front. And then we'll go ahead and decompress the optic nerve canal and expose the optic dural sheath. And once we've decompressed the optic nerve, we can turn our attention towards drilling the anterior clinoid process. And we'll do this in an eggshell method and then remove the last remaining component. This is all done purely extradurally. And then we'll go ahead and open up the dura and expose the tumor. You can see the tumors on the temporal side of the sylvian fissure. We'll open the sylvian fissure widely, expose the MCA, and then start debulking the tumor. And then we can go pretemporal and start collapsing the tumor from the anterior temporal lobe and then freeing it from the temporal lobe. We'll now cut the dura towards the orbital apex and then connect our cut into the falciform ligament. And the falciform ligament, early division of this is important because this will release the optic nerve and untether it so that as you're removing the tumor, the optic nerve is a little bit more mobile and free of strangulation. We'll then continue our cut laterally over the ICA and we'll cut the distal dural ring of the ICA. And there's the PCOM artery proximally. And then as we dissect the lateral surface of the carotid, beware of the choroidal segment. So now we'll cut along the roof of the cavernous sinus, and here we are resecting the lateral wall of the cavernous sinus. So now what's remaining now is the intradural component of the tumor. And it's important to always make the tumor smaller so it's easier to mobilize, and to look for these small vascular feeders coming from the MCA. These are small feeders from the MCA. But beware of the choroidal artery. Don't mistake this as an MCA feeder. Look how it's coursing backwards towards the choroidal fissure. So make sure you protect the anterior choroidal artery to avoid a choroidal stroke. And then once you free the tumor off of the vascular feeders, I follow the tumor along the free edge of the tentorium here, and this serves as a useful landmark in peeling off the remainder of these tumors. And be careful of the fourth nerve as it enters the tentorial edge so that you don't injure it. So there's the posterior fossa, the SCA vessels, and then there's the third nerve entering the oculomotor canal. Here's the post-op scan. You can see a gross total removal, maybe some microscopic residual in the wall of the cavernous sinus that we left for radiotherapy. Here's another example. This was a very hypervascular sphenocavernous meningioma. You could see all of these flow voids in the tumor. And this should raise concern of where the vascular origin is. So when we did an angiogram, the vascular feeders were coming from the cavernous ICA. So unfortunately, these feeders could not be safely embolized because they were coming from intracranial circulation. So surgically, to safely treat this to avoid disastrous blood loss, you had to do the peeling and unlocking the cavernous sinus and peeling it, and then carefully devascularizing it along the lateral wall and also along the tentorium. So this allowed safe removal by using that technique. Here's another example of a large sphenocavernous clinoidal meningioma resulting in visual loss. Here, the ICA is completely encased. So how do we safely remove a tumor like this with ICA encased? You can see the clinoid is hyperostotic. a lot of mass effect midline shift. So we really want to get early identification of the proximal optic nerve and carotid artery, because the anatomy we know intradurally is going to be displaced. So we've unroofed the left optic nerve. Here's the dural sheath. Here's the clinodectomy. There's the lateral wall of the cavernous sinus. We'll open up the Sylvian fissure widely and find the distal MCA. There's the distal MCA. And luckily there's a nice arachnoid plane to peel the tumor away from the artery. So once you know where the MCA and ICA are, you can begin to safely debulk the tumor. But as we debulk the tumor, we're visualizing the ICA completely. And then I will incise the tumor directly over the ICA, so I can divide the tumor into different compartments. So now we'll have a lateral compartment and a medial compartment. And then we'll open the dura over the optic roof, and then open up the falciform ligament here to get that decompression over the optic nerve. So there's the ICA. We can now work systematically. I'll first work on the temporal side and debulk and dissect the tumor from the temporal side, excise the temporal dura because this is adherent to the lateral wall of the cavernous sinus. This is the dura propria, which is continuous with the temporal dura. And there's the inner surface, the intracavernous component, and we'll do the Dolenz cut along the roof of the cavernous sinus to release the lateral wall. And then now what remains is the cisternal component of the tumor. We'll again release CSF from the posterior fossa cisterns. We're working medial to the tentorial edge here, and then removing the tumor in a piecemeal fashion. Now we want to carefully preserve all the vascular perforators coming off of the lateral component of the ICA. This includes the PCOM perforators, and the anterocoroidal artery. And beware of the third nerve. We had a hard time finding the third nerve here because it was so displaced, but you want to be careful of the third nerve. And we'll carefully incise the adherent arachnoid, mobilizing the arachnoid from the tumor towards the neurovasculature. And this allows an extra layer of protection of the arachnoid, protecting the vascular perforators. Here we're using a 3 hands technique where we deliver the tumor to the aspirator, and we'll now work on the medial side of the tumor. Here's A1, working on the medial side. Here's the bifurcation in A1, and we're looking for the optic nerve. The optic nerve is going to be displaced medially and inferiorly. Here's the optic nerve. Look how flat it is, like a pancake. And now there's remaining tumor right around the proximal ICA. And again, using the 3 hands technique, we'll deliver the tumor to the aspirator. And now we've identified the third nerve, and there's a remaining tumor around the third nerve. You see that the third nerve is actually displaced superiorly and medially, right juxtaposed to the carotid artery. And then here's the final view. You can see, and we'll use our vascularized pericranial flap to reconstruct the dural defect because we've excised the temporal dura, the periclinoid dura, leaving a large dural defect. So here is the remaining intracavernous component where we left for IMRT radiotherapy. I want to show you some examples where using the unlocking of the cavernous sinus can help with infratemporal fossa tumors, especially tumors like this hypervascular JNA that extends intracranially and pushes the cavernous sinus upwards. You can see the relationship of the tumor near the superior orbital fissure, near the cavernous ICA. And so here we'll use a multi-corridor technique by coming in from above with our orbital zygomatic and then opening a sublabial Caldwell-Luck maxillotomy to get the lateral corridor with endoscopic endonasal. And so we'll do this simultaneously combined using a multi-portal approach. And the idea here is that we come from above first using a orbitozygomatic extradural approach. Here we are unlocking the cavernous sinus using the Hakuba technique, peeling it from front to back, preserving the inner wall of the cavernous sinus. We'll go ahead and decompress the supraorbital fissure and V2. Here is the tumor in the anteromedial triangle between V1 and V2, and we open up the periosteum. Here is the tumor, and we're peeling it and isolating it from the cavernous ICA. And we're pushing it into the infratemporal fossa. And what this allows us to do is that we've now obtained control of the cavernous ICA, so that we can now come from below with our sublabial maxillotomy and endoscopic endonasal approach to access the tumor with full confidence that the cavernous ICA is now protected and free from the tumor, so that we're not going to see that cavernous ICA last and injure it because it's still adherent to the tumor. So now we can come from below. Again, for giant tumors, it's nice to work in compartments. So we'll take out the midline compartment of the nasopharynx. Now we'll turn our attention towards the lateral infratemporal fossa component. And by having that extra additional window in the Caldwell-Luck maxillotomy, you have wide exposure, a lot of surgical freedom to move your instruments and dissect the tumor from the infratemporal fossa. Here's the tumor being lifted up from the hard palate defect where the tumor had eroded. We cauterize the last vascular feeders and then remove the remaining tumor through the Caldwell-Luck maxillotomy. There's the temporal lobe dura and V2, and there's the sphenoid sinus and the infratemporal fossa resection bed. Complete removal of the tumor. The patient had a little mild numbness in the left V2 region, which was very well tolerated. And these JNAs can be quite treacherous. This is a giant one in a young child where the vascular feeders were now coming from cavernous ICA from both sides. And when the cavernous ICA is involved, embolization is often limited, which makes the tumor very treacherous, very bloody and hypervascular. And in a child who has a lower blood volume, you have to be ready to stop and come back and fight again. And so it's important to do these in stages. This operation required 4 different stages, but ultimately we're able to achieve a safe and excellent neurological and oncological outcome. Complete removal of the tumor using our multi-portal approach, and you could see he's cured of this tumor and will have an excellent quality of life going forward. Let's talk a little bit about vascular lesions. This is the intradural clinodectomy. And for carotid ophthalmic artery aneurysms, remember that the optimal clip configuration is using a side curved clip where you then rotate your clip so that the shank is pointing towards the clinoid so that the clip blades are coursing more in access with the ICA. So here's an example of a carotid ophthalmic aneurysm. Look how the optic nerve is draped over the dome of this aneurysm. And we've done the clinodectomy, open up the optic dural sheath to decompress the nerve. And then we come across the neck of the aneurysm. And here we'll rotate our aneurysm clip anteriorly so that the clip blades are more parallel in axis with the ICA. And then here's the post-op ICG. So this is a smaller, simple aneurysm using this technique of unlocking the cavernous sinus. But it becomes more helpful when you're dealing with much larger aneurysms. Here's a superior hypophyseal aneurysm. You can see it's ventrally pointing. And Professor Sugita introduced to us many years ago the concept of using fenestrated clips to reconstruct the lumen of the ICA. And Professors Bajer and Sampson taught us the Dallas maneuver, which is the retrograde suction decompression by opening the neck and suctioning, deflating the aneurysm to allow safer reconstruction. Here I'm demonstrating a direct suction decompression where you puncture the dome of the aneurysm and deflate it as you're reconstructing the aneurysm with clips. Here we're opening the falciform ligament, decompressing the optic nerve. You could see that the optic nerve has a brown discoloration from strangulation of the aneurysm, lifting the nerve up against the falciform. We have to cut and create a distal dural ring here around the proximal ICA. And the ring, remember, it's adherent to the adventitia. There's no potential space, so you have to create the ring by cutting the dura in a 270-degree fashion around the artery. And see how this allows us to now have proximal control. We have distal control. So we have the neck prepped, but it's not exposed as a backup. But when you have this exposure, you can now put a proximal temporary clip on the clinoidal ICA, a distal clip on the distal ICA, and now the aneurysm is trapped, and we can go ahead and deflate the aneurysm using a small butterfly needle, and then aspirating it and collapsing the aneurysm. And we can now see the choroidal artery, but look how the clips keep slipping. There's a piece of calcium right in the proximal neck, and this becomes problematic because as the clips are slipping, this can potentially occlude the ICA. So you have to be aware of this. So we have to think of an alternative strategy. So I end up using a series of shorter right angle fenestrated, bolstered with vertical straight fenestrated clips. And then this calcium area I'll close off with a separate gentle curved clip. And then here's the choroidal artery. We're going to dissect the choroidal artery away from the distal neck of the aneurysm, and then protecting it and holding it away from the aneurysm with a suction. We can now come in with a angled fenestrated clip to close off that distal neck of the aneurysm. And then we'll take off our temporary clips. And then here's the final view. You could see there's still a dog ear residual on the proximal ICA. And so we can take care of that residual dog ear with a gentle curved clip to reconstruct the lumen. So here's the final reconstruction of the ICA. And then we'll go ahead and shoot an ICG. And we want to look for anterograde flow of the choroidal artery, and this is important. We want to make sure that choroidal artery is flowing, and there's a nice reconstruction of the carotid artery here. And the post-op angiogram shows excellent reconstruction of the ICA. Here's a recent case we did. This patient presented with, on an MRI, with a suprasellar mass compressing the optic chiasm with bitemporal hemianopsia. So be aware this is not a pituitary tumor. Make sure you get a vascular study showing this, again, large superior hypophyseal aneurysm. And we used this approach, unlocking the cavernous sinus, opening up the clinoid process, decompressing the optic nerve, and then reconstructing this luminally, reconstructing the lumen of the ICA. Patient also had a MCA aneurysm more distally, so we treated both of these aneurysms in one approach. And so here's the complete removal. You can see the ICA aneurysm taken care of, and the MCA aneurysm, which is here, is also occluded from circulation as well. So here's an example of a giant superior carotid ophthalmic aneurysm causing unilateral visual loss. And although one can consider flow diverters, in the presence of visual loss, my preference is to do an open approach to decompress the optic nerve. So here we've done the classic Dallas technique with some slight modifications. We'll use the orbitopterional approach as we talked about briefly. Here is opening up the superorbital fissure, cutting the meningoorbital band, and then exposing the dura propria and peeling that lateral wall. Here you can see the dense adherent fibers that were needed to be incised, and then this allows exposure of the anterior clinoid process extradurally. And we'll go ahead and decompress the optic nerve using anterior clinoidectomy here. So we'll go ahead and open up the superorbital fissure and then open up the falciform ligament, decompressing the optic nerve. And then here we are incising the distal dural ring. We'll put a little suture here to give us better exposure and also help control bleeding from the clinoidal space. So here's the ICA. We'll go ahead, trap the aneurysm by putting a clip on the common and then putting a butterfly needle on the common carotid as opposed to the internal carotid. We'll put a clip on the external, and then we can start to suction decompress. And you can see how the aneurysm's deflated. We can dissect the neck of the aneurysm and then come across with the side curved clip. Here's the ophthalmic artery being preserved, occluding the artery, and then we'll go ahead and take the needle out and then suture the needle site. And then here's the ICG. You can still see there's some residual filling, and that residual filling is because it's filling through the little gap of the clip. So we'll reinforce it with another small clip where it's trickling through the gap of the clip, and then we can now deflate the aneurysm, and the optic nerve is fully decompressed here. So here's a complete reconstruction of that aneurysm. Here's the post-op angiogram. And lastly, I'll show you this example. This is a combination of an ICA aneurysm with a basilar apex aneurysm. And we can come in from the same side and treat both aneurysms. I ran this by our endovascular team, who felt that this basilar was difficult to coil. So we'll do this through this orbitopterional approach, clinoidectomy, wide splitting of the sylvian fissure, and then you can see here is the aneurysm. It's got a fusiform type appearance. There's the third nerve. We're dissecting the arachnoid off of the third nerve, and then we'll do a temporary clip proximally and then start to reconstruct this with angled fenestrated right angle clips. Oops, sorry. So here's the first clip coming on, and then here's a second vertical clip, and then another vertical fenestrated clip to reinforce the first clip. So now that the ICA aneurysm is taken care of, we're now going to open up the carotid oculomotor triangle, opening up this arachnoid that's tethered to the third nerve. Here's a small PCOM perforator. You can divide this in some cases, but here I'm going to decide to work around it. I try not to divide arteries if I can avoid it. And I'm looking at the contralateral P1 basilar junction here. You see there's the distal P1 junction, and you can reconstruct this using the tandem clip technique. So what you do is you take a fenestrated clip and you focus on reconstructing the distal neck at the contralateral P1 and basilar junction, And once you close off this area, you want to pay attention to the distal clip blades to make sure you don't kink off the P1 takeoff. And now with the residual portion of the aneurysm, you can come in with a straight clip just behind that fenestration and then close off that last portion. And so here's the final view. And then you can see both aneurysms are nicely reconstructed. So when you're taking off the clinoid, just be careful. You can injure the optic nerve or the carotid artery. So use your clinoidectomy judiciously and tailor the clinoidectomy to your surgery. Do you necessarily need to take off the entire shark tooth? Not necessarily. In most tumor cases, you can decompress the optic nerve. In a vascular case, you probably need to take off the whole clinoid. But I just want to show you what can happen if you're not careful. And so here I'm drilling the optic strut, but for a brief moment, I don't recognize that the other surface of the drill is actually shaving down the adventitia of the ICA here. I thought this was probably one more layer of the cavernous sinus, but you can see the bleeding is not venous, it's arterial in origin, and it's coming briskly. And so a common reaction is to pack off the bleeding, but what you need to do is you need to visualize and inspect what is bleeding and what type of bleeding there is, because that's going to determine how you're going to fix it. I can see it's a small little puncture site from the drill in the clinoidal segment of the ICA, so I try to wield it together with a bipolar, and this of course is a failure. And so I remembered that you can use crushed muscle, and you have to crush the muscle so it releases clotting factors. And we'll go ahead and pack this off with crushed muscle, and I held pressure here for close to 30 to 45 minutes, and the bleeding stopped, and I was able to go ahead and remove the tumor. And you have to get an immediate post-op as well as a delayed post-op angiogram, which luckily did not have any pseudoaneurysm, and the patient ultimately made an excellent recovery. So with that, I thank you for your attention, and again, congratulations, Same, on a wonderful symposium, and thank you for inviting me.
Thanks a lot, dear Professor, for this collaborative, excellent presentation, as usual, dear friend. Is there any question from panelists? Okay, thank you. And now we will shift to the next speaker, Professor Sinali. Please start sharing your screen.
Good morning. Good morning, everybody. Thank you for the invitation. Can you hear me loud and clear?
Yes.
Okay. Can you see my screen properly?
Yes, it's not full. Oh, it's not full. There we go. It's okay.
Okay. Thank you very much for including me in this fantastic program. And thank you for giving me the possibility to talk about our experience in the management of pineal tumors in children. Here we are presenting mainly also our experience in the Herophilus Gallen line as a preoperative predictor of extent of resection in this kind of surgery, these tumors operated through the occipital interhemispheric transtentorial approach in children. This is mainly dedicated to this kind of approach. That is the only approach that we perform in pineal tumors in children. As you all know, of course, there are mainly two kind of approaches to the pineal region in pediatric population. The most widely used is the infratentorial supracerebellar approach. That is an excellent approach. It requires the sacrifice of the supracerebellar vein of the large majority of the supracerebellar veins, if not the complete sacrifice of all the supracerebellar veins. This is the main problem of this approach. it is better performed in a sitting position, and it depends mainly on the steepness of the tentorium that can limit the visibility and the easy of approach to the tumors. The fact that it is done mainly, it is better done in a sitting position, is also some kind of limitation for what concern my point of view. And the other approach that we use more frequently, if not always, is the interhemispheric occipital transtentorial approach, that is a mainly supratentorial approach that does not require any venous sacrifice, that requires the large opening of tentorium to see the pineal region, and can be performed in a very comfortable prone position, both for the child and for the surgeon, without any need for extreme positions of the head and without any need for a sitting position. The steepness of the tentorium is one of the main limitations of the infratentorial supracerebellar. When this angle is too narrow, then the limitation of view can be excessive, and the easy of access to the supracerebellar region can be dramatically limited by the excessive steepness of the tentorium. And this is also one of the limitations. That means that the supracerebellar infratentorial approach is not suitable for all patients, and a careful study of the anatomy should be performed before surgery. But in spite of the fact that this is very well known, the problem of the steepness of the tentorium is very well known, we still do not have a very clear-cut value of the steepness of the tentorium to say, yes, in this case we can do the infratentorial approach, or no, in this case we have to do the OITA, the occipital transtentorial approach. This is not clear enough yet in the literature, and this certainly requires further investigation when you still consider the supracerebellar approach as a possibility. To the point that some other authors, like the group of Jean, Sida and Jean, has proposed another kind of angle that is based on the plan of the fourth ventricle and the angle of the tentorium, saying that this kind of angle is certainly more reliable if considered to the simple steep of the tentorium. The tentorium angle, as you know, is based between the twining line and the tentorium line. Instead, this other angle is based on the anatomical limit of the floor of the fourth ventricle. In case of excessively narrow angles, of course, this could be a limitation because of the excessively low position of the internal occipital protuberance and the excessive steepness of the tentorium. When instead this angle is wider, of course, this is a point that allows the supracerebellar approach according to the authors. Unfortunately, this method has not been validated. Only their 8 patients have been studied, and of course this requires some kind of validation. So we still do not have clear-cut values to decide and to offer to the surgeon the alternative between the sheet approach, that means this supracerebellar infratentorial, and the OITA approach, that means the occipital interhemispheric transtentorial approach. So this remains still somehow not very well clear in the literature. Our policy is clear since 1999. That means that all pineal tumors are operated through the occipital interhemispheric transtentorial approach, mainly for the following reason. First of all, is that the alternative, that means the sheet approach, is better performed in a sitting position. Many authors are now talking about the lateral position, or from approach with a park bench position, but mainly most authors still prefer to perform this kind of surgery in a sitting position. And when this is performed in a sitting or semi-sitting position, anyway, this carries a 12% incidence of venous embolism, according to the very last paper, very nice paper that has been published very recently on the semi-sitting position in children. And 12% incidence of venous embolism is quite important, although this remains infraclinical. Of course, this still remains quite risky to have such a high incidence of venous embolism in this kind of position. And then there is the main reason that convinced me in the last 90s to shift from the sheet approach to the OIT approach. That means is that the sheet approach is associated with cerebellar infarct due to vein sacrifice. This is a complication that is relatively rare, hopefully below 1 or 2%, but still is not very clearly clear in the literature what is the real incidence of cerebellar infarct. Many people and many authors talk generally about cerebellar edema following the sheet approach. But in fact, this is not a cerebellar edema. This is a real cerebellar infarct that can be fatal in some cases, or can be associated with very severe postoperative neurological deficits. And certainly it is independent on the dexterity of the surgeon. It is independent of the quality and beautifulness of the surgery performed, because it is completely unpredictable. So the incidence of this complication is still unknown, but is defined as underreported by the recent the report of 9 years ago from Giacola in 2013. Mostly sporadic reports, but frequent sporadic reports, and incidence not higher than 1% in all series. That is too much for me, because it is completely unpredictable and independent on what the surgeon does and on the dexterity of the surgeon. The advantages of the occipital interhemispheric transtentorial approach that we prefer, of course, is access to the third ventricle is excellent, as well as to the superior cerebellar vermis, superior aspect of the fourth ventricle as well, and very nice exposure of the splenium of the corpus callosum. Better visualization of the third ventricle with a complete visualization of the third ventricle until the both foramen of Monroe in case of large tumors. And there are no veins crossing from the occipital lobe into the superior sagittal sinus in the surface. So the occipital lobe can be displaced very nicely without any problem, without any sacrifice of superficial cortical veins. And there is no risk of venous infarction unless the surgeon divides, of course, the internal cerebral vein. That, of course, is a clear mistake or a clear, very severe complication that fortunately in the microsurgical era is more and more difficult to observe. In our series of 30 patients operated between 2006 and 2020, mean age was 10.3 years. It was a real pediatric series. The older patient was 17 years old. 25 patients had hydrocephalus, in 19 cases treated with ETV, and in 6 cases treated with a VP shunt that was implanted elsewhere. Since 1999 in our department, of course, ETV is the gold standard management of hydrocephalus in pineal tumors, hopefully associated whenever is technically possible with a biopsy of the tumor as well, and of course with a sample of CSF to perform dosage of tumor markers. 7 of these patients had been treated with the previous chemotherapy, mostly germinomas that received a biopsy, then were treated with previous with chemo, and then they were operated on a residual tumor. And in 2 cases, referred from other departments, had already been treated also with previous radiotherapy. These are the histology of the cases. As you can see, germinoma, germ cell tumor, teratoma, pinealoblastomas, typical distribution of histologies in a pediatric series, and also some juvenile pilocytic astrocytoma, very large tumors reported in the series. We calculated the tumor, and the tumor volume was 15.1 cubic centimeters, ranging from 1 cubic centimeter, a small residual of germinoma following radiotherapy, to a giant tumor measuring up to 104.3 cubic centimeters. So extreme variability of tumor volume. To select our idea of understanding what was the predictor of troubles during surgery in obtaining complete removal, because our target in the vast majority of the cases was, of course, complete removal of the tumor, we identified this indicator. That means it's the Herophilus Galen line. We put the point on the upper part of the torcular herophily. We put another point on the lowest part of the vein of Galen, and we designed what we call the Herophilus Galen line, and we cut in this way, according with the plan that is coaxial to this line, a part of the tumor that is above this line, and the part of the tumor that is below this line. We designed this line because, of course, this is a very intuitive line of sight. This is a more intuitive line of sight that corresponds to the highest possible inclination of the line of sight of the microscope through an OITA approach. As you can see in this case, all the tumor that is hidden behind the splenium and the internal cerebral vein cannot be seen very easily through an occipital interhemispheric transcentorial approach. So the larger the area of tumor hidden above this line, the higher the possibility of incomplete removal through this approach. This is the part of the tumor lying below the plan, and this is the part of the tumor that is lying above the Herophilus Galen plan, just to give an idea of a three-dimensional view of this tumor. And this is the distribution of the Herophilus Galen line in all our series of tumor. As you can see, the tumor is listed here in growing tumor volume. So from the smallest tumor that is less than 1 cubic centimeter up to the largest tumor that is more than 100 cubic centimeter, and you can see the distribution in our series of tumor. This is the tumor volume, as I said, ranging from 1 to 104. The tumor volume above the Herophilus Galen plan was 2.7 cubic centimeters as an average. That is certainly the smallest part of the tumor was above this plan, whereas the tumor volume, the average tumor volume below the Herophilus Galen plan was 12.4 cubic centimeters. Looking at the choice of the approach, as I said, and in the decision, of course, and in order to understand what could have been the possibility to remove all the tumor, for example, like in this case, a pineoblastoma, we design our Herophilus Galen line, and we see that 100% of the tumor is located below the Herophilus Galen line. So whatever the inclination of the microscope that we use, we will always be able to control perfectly all the tumor mass from the upper pole down to the lowest pole. This is the 3D model of this tumor, and you can see here the Herophilus Galen line as tracked, and you can see that we can control very nicely both the upper pole and the lower pole, just modifying the inclination of our surgical microscope, and we can have a good control of the whole tumor volume. So this is certainly a good candidate for a complete removal through this approach. Some technical aspect of the tumor, of this approach, the preoperative preparation. Preoperative preparation, of course, is mandatory, is the control of hydrocephalus. Whatever you want to use, we are partisan of endoscopic third ventriculostomy because it is very effective. There are no foreign material implanted, but of course, if you don't want to do ETV, or you are something against ETV and you want to use an EVD or a shunt, it's okay. what is important is to control the hydrocephalus before pineal surgery. This is really mandatory because the retraction of the occipital lobe needs to be as atraumatic as possible. So you really need to have a very relaxed brain at the time of opening of the dura and at the time of occipital lobe retraction. Of course, you need standard pre-op stuff, and before positioning the patient for the surgery, we always as well implant a preoperative lumbar drainage, because even if the ETV has been performed 5 or 6 days before, still the presence of a lumbar drainage makes occipital lobe retraction and the dissection much easier, much softer, and much less traumatic if compared to the absence to the lumbar drainage. So please use the lumbar drainage before and open the lumbar drainage before dural opening. The position by definition is prone in a Mayfield, of course, or a horseshoe headrest if the patient is too young, below 3 years of age for a Mayfield. No head flexion at all. This is also very important, as very different if compared to the sheet approach, because the lack of head flexion makes venous drainage much better under every point of view. There is no problem in jugular compression, and there is no problem in torsion of the all the venous axis of the neck. So it is a very good position with a neutral position. It's just turned only 15 degrees to contralateral side of the approach in order to allow the fall of the occipital lobe. It is very important to study your anatomy, the anatomy of your torcular, because in some cases you can have, of course, asymmetry. So you have to plan your position according with the asymmetry of the torcular, and then of course you have to do your planning before the surgery. The bone flap needs to expose well the torcular and to expose well the lambda, as you can see, and I prefer the sigmoid incision because it allows to do a larger occipital flap. If you do a larger occipital flap, you allow for an easier detention of the occipital lobe and easier retractorless displacement of the occipital lobe that really falls after lumbar drainage and opening of the quadrigeminal cister. So it is very important to do all these things before surgery. As you can see, the bone flap is very well exposing both the sagittal sinus, the torcular aerophily, and the lateral sinus in order to have the best possible exposure of this. As I said, torcular and lambdoid are included in the surgical field, and this is another example of tumor. Mannitol can be, of course, also important to help the detention of the occipital lobe, and then immediately before opening the dura, open the lumbar drainage in order to facilitate your dissection. When you are doing your dissection, forget, of course, these huge retractions that are on the book. Your retractors should be placed with very, very great care, especially avoiding retractor's edge on the calcareous fissure. You have to know where your calcareous fissure is, you have to identify it, and you have to avoid to place the retractor's edge on the calcareous fissure. The initial phase of the surgery, small retraction for me is still important. We look for we dissect the interhemispheric fissure very quickly. We look for the quadrigeminal cistern. Here, for example, we are a little bit too high. We can see the you can see the free edge of the tentorium. You can see the large vein that is below a free edge of the tentorium. So we have to adjust our trajectory. And in this case, of course, adjusting our trajectory, we just go a little bit lower according with the navigator, looking for the arachnoid of the quadrigeminal cistern. Here we can see that the vein disappears and appear finally the whitish arachnoid of the quadrigeminal cister. And here now, this is very important, we can open very nicely the quadrigeminal cistern, and we can wait for at least 5 minutes, releasing CSF and allowing the occipital lobe to fall down and to open your way to the tentorium and to the pineal area. The tentorium is divided adjacent to the straight sinus. Normally, it is not so easy to perform. The initial incision is made near the junction of the straight sinus. This is what is said in the books. Of course, this is an old paper, an old video showing that with the scissors, the opening of the tentorium can be quite painful. Even after extensive coagulation, the scissors can still be associated with bleeding that can be quite annoying and long to manage. Our technique is after extensive bipolar coagulation, we open the tentorium with the contact thulium laser. The contact thulium laser is a very, very effective tool to open all the dural barriers that you have. It is the folks or it is the tentorium. In the pineal approach, of course, you need to open the tentorium, and you can see that you can manage very easily both the at the same time both the opening and the hemostasis, because if you use your contact laser with a good power, not too strong, not too weak, and you use at the proper distance, of course this takes some time to get confident with this, you still can have some bleeding, but it is a very fast way to open the tentorium. Not only to open the tentorium, you don't need to put tenting sutures, you don't need to work with a needle holder inside this small piece, and what is more important, you can tailor your opening of the tentorium according to your need at the millimeter, because of course you can just make a simple drawing of how much you need to open this tentorium, and you can enlarge your surgical window in the tentorium from a very small 1 centimeter of surgical opening to a complete opening of the tentorium, because you can see that you can manage very quickly and very easily the small bleeding that you still can have, of course, because you can still have some small bleeding, but the vaporization of the dura mater with the contact laser is extremely effective in reducing the lumen of the tentorial sinuses. And you can see here that you can create very nice surgical windows with an excellent view on the other side of the tentorium. And understanding this is very, very important, because people sometimes is limiting themselves by doing very small tentorial openings or insufficient. Can you hear me?
Yes, it's okay.
Okay, okay, sorry, I had, okay, so limiting your tentorial opening is not a good idea. Of course, you need to have the largest possible tentorial opening in order to have the best possible visibility on the other side and to control all you need to control of the tumor. Then now you have to access your venous system and control your venous system. This is your surgical trajectory. This is your torcular. You are just leading your surgical trajectory through the straight sinus that is here, and you reach this area where you have this significant complex crossing of vein. This is the vein of Gallen. You can see here the two internal cerebral vein, the large basal vein of Rosenthal, the superior Vermian vein, the precentral vein, and the group of internal occipital vein. This here you can see very nicely, the two internal cerebral vein that normally you don't see. You should not see through this approach, just in the extreme cases where you have to push your dissection so far into the third ventricle, you can see the internal cerebral vein, but normally this is not necessary. You certainly see the Rosenthal, both Rosenthal are necessary, and the superior vermian vein, and also some vein that are the first ones that you can see, and that are the first one that you have to preserve, is the group of the internal occipital veins that are here, that are frequently, unfortunately, sacrificed, but it is absolutely a great mistake to sacrifice this vein, because this can be associated, of course, with the occipital, in fact, with the residual hemianopia. You can save this internal occipital vein. You have to save all the veins that you can see, and you have to avoid absolutely any vascular sacrifice. The main reason for this approach is that you can remove even very large tumor without any venous sacrifice. You have to save every single vein, and saving every single vein, you can avoid hemianopia, you can avoid occipital lobe infarction, and of course can avoid every other kind of complication. So the first veins you have to deal with are the complex of the occipital veins and the right Rosenthal. After opening of the tentorium, this is the bunch of vein that you still start to identify. This is the white stuff is the tumor. In this case, it was a teratoma, and you can see that this group of veins is somehow limiting your vision. You have to identify the right basal vein of Rosenthal that is much higher and much larger, and these ones instead is the right complex of the internal occipital veins. You can manage this vein very well, as you can see here. You can absolutely avoid any sacrifice of this vein, and you can continue your dissection without any problem. Then, of course, after completing your dissection of the tumor of the upper pole and of the lateral poles, of the lateral pole of your side, on the right side, if you are approaching to the right side, then you have to deal with the tectal plate and find the third ventricle. The lower pole, of course, is relatively difficult to find if the tumor is very large. This could require significant tumor debulking, but after significant tumor debulking, you can push upward your tumor and dissect your tumor from the tectal plate until you find the posterior third ventricle. Sometimes, of course, after identification of the third ventricle, you continue the debulking of the tumor, or in this case of the teratoma, until you find the third ventricle cavity in the depth of your tumor, and of course at this phase you know that you are very well advanced in your tumor control. Fortunately, in this case the teratoma was not bleeding very much, so it was a very easy case to manage because of the very low bleeding. And what is also very favorable in teratomas is the excellent plan of dissection that you can find between the outer capsule of the tumor and the veins of the pineal region. Then we have to deal with the superior vermian vein. After you find the third ventricle, the superior vermian vein can be very large and can be mistaken for the left Rosenthal. In fact, it's a big vein that can be identified here. You can and can be very attached to the upper pole of the tumor. It should be preserved as much as possible. It is very rare that it should be sacrificed. In my experience of 30 pineal tumors through the OITA approach, only one case required sacrifice of the superior vermian vein. And you can see here the right Rosenthal, the internal occipital veins. Then Gallen. Of course, the upper pole, after you have freed the lower pole, you have entered into the third ventricle, you have significantly debulked the tumor, and you can just deal with the upper part. The upper part, of course, is the more complex, is the more difficult, because the Gallen vein is very large, and of course is the part of the tumor that can be hidden. But as you can see here, especially in cases of teratoma or in cases of tumors that have been treated with chemotherapy, you can dissect very effectively the upper pole of the tumor from the galen. In this case, it is protected by this cottonoid that has been implanted on the vein of Galen, and you can deal very nicely with that. Continuing with this is another case where we show that you can push your dissection in more complex cases also above the vein of Galen. Here you recognize that there is the splenium. This is the edge of the splenium of the corpus callosum, and in these cases the tumor was going so upward that it was passing the limit of the vein of Galen, and it was going below the splenium. But it is possible to work, as you can see, between the splenium and the vein of Galen. Here you can see also another lucky case because of the very good dissection plan that we have. Of course, you can make an alternance of, as usual, of debulking and dissection, and here again we find the limits of the ependyma of the third ventricle, and we have freed completely the upper part of the tumor above Galen. Then we go back below the Galen, as you can see, and we dissect the vein of Galen with a sharp dissection, and we, as you can see, it's relatively easy to do, but especially it is you have a very nice view. You have a very nice surgical view. You can control very nicely the structures, even if they are hidden. Even if they are hidden below the vein of Galen, you can control these structures. You can displace gently the structures, and you can continue the removal of the tumor. Here you can see both with dissection and removal, and this is final view of the splenium, of the vein of Galen, and of the third ventricle, completely free of the upper part of the tumor. Then we go back to the first previous case, managing the left basal vein of Rosenthal. Here you understand how important is the good opening of the tentorium. Here you can see that you are controlling the left basal vein of Rosenthal that is very far away in your surgical view, only because of the very large opening of the tentorium that you have before. It can look as extremely complex to dissect this vein, but you can see that through this approach, you have a very nice view of the left Rosenthal. You can dissect the left Rosenthal very effectively with a sharp dissection, and small bleedings can be managed very quickly and very effectively. And even if there are, as you can see, quite a strong adhesion between the left Rosenthal and the capsule of the tumor, you can still remove very nicely these adhesions progressively, gently, and always with an excellent view. Here you understand you are at the limit of your Herophilus Galen line, and see how important it is to have to know that you can control until the upper pole of the tumor, thanks to your preoperative planning, thanks to the fact that you have positioned your Herophilus Galen line above the upper pole of the tumor, and you know that you can push your removal very high. Then, of course, the last part is the dissection of the contralateral thalamus. Dissection of the contralateral thalamus is, I must say, the easiest part, because the major veins have been completely dissected, have been free from the tumor infiltration and adhesions. Of course, the only limit and the only difficulty of this depends on you. If you have done a sufficient opening in the tentorium, then this part is relatively easy. If your tentorial opening is not sufficient, then of course you can have trouble, and you can limit your removal at this point. You can see again the dissection of the left thalamus. You see that she progress with this, and millimeter by millimeter you can find your dissection plan and remove progressively the tumor that requires to be removed. Very, very small bleeding, and this is the end of the surgery. And this is the end of the tumor and the removal of the tumor. This is a good vision of the and this is the final view of the tumor, the tentorial opening, the folks, the right internal occipital vein, the right basal vein of Rosenthal, the splenium, the straight sinus. You see that the occipital lobe is completely fallen, but there is absolutely no need for a retraction. This is the adhesio interthalamica with a perfect view of the third ventricle, and there is no problem about this, and you cannot see down to the left foramen humeral. In our 30 cases, as results, the gross total removal was achieved at 73% at first surgery, and we went up to 88% of gross total removal after second surgery that was performed in 4 cases. So even if the first OITA does not work, you can still rely on the same approach at a distance of 1 month or 2 months or 3 months, or following a session of chemotherapy to further reduce the tumor, because with the adaptation and the loss of the largest part of the tumor volume, of course, you have the upper part of the tumor that falls down and becomes apparent through the OPERA approach. In our experience, a tumor volume above 2 cubic centimeters above the Hierophilus-Galen line is predictive of incomplete removal at first surgery. And this was very important to us, that this Hierophilus-Galen line in our hands is a good predictor, is something that can be said to the parents, saying that probably if a single approach is not sufficient, the patient can be reoperated in case, or in the more extreme cases, as we have recently published in the Journal of Neurosurgery, if the tumor is located excessively above the Hierophilus-Galen line, then of course we prefer another approach, that means the transcallosal, transchoroidal approach from above, in order to, because this becomes a pioneer tumor, yes, but with a predominant extension inside the third ventricle. These are some cases of pioneer region tumor operated through the occipital interhemispheric transtentorial approach. You see that there is no sacrifice of the superior vermian vein. You see that there is no problem at the level of the occipital lobe. All our postoperative MRIs were reviewed, and in no cases there were any kind of occipital ischemia or any case of occipital infarct. Only 1 case out of 30 had definitive hemianopia following surgery. So it's quite good results under the clinical point of view. So as take-home message, certainly for this kind of approach, train CSF before occipital lobe retraction. This is very important. This can make a normal standard surgery, the difference between a normal standard surgery and very complex and complicated and unclean surgery. Drain CSF, treat hydrocephalus, put the lumbar external drainage, and allow your occipital lobe to be extremely soft and easy to dissect. Favor any kind of brain relaxation, even with the mannitol, perform a large opening of the tentorium, and of course, keep the veins wet, because change frequently your cottonoids. Don't leave your cottonoids to dry on the veins. Use the cottonoids as rarely as possible, because the veins prefer to stay either with a last generation cottonoid that keep them wet without getting dry, or is better in the air with frequent irrigation of the surgical field. And in our series, tumor volume above 2 centimeters cubic above the Hierophilus-Galen line is predictive of incomplete removal at first OITA approach. And some of these steps have been already published on Journal of Neurosurgery and in Techniques in Neurosurgery, a Springer video. And thank you very much for your attention.
Thanks a lot, dear Professor, for this excellent presentation. Is there any question from panelists? Thank you. See you again. Okay, next speaker, Professor Atul Goel. Thanks, dear friend, for accepting our invitation, and thanks again for giving us this
I can hear.
lecture. This lecture, although you are traveling just now. Thank you.
Thank you, dear Samay. You can hear me, Samay?
Yes.
Yes, it's okay.
Loud and clear?
Yeah, yeah.
So I am very happy to give this presentation, which is actually my lifetime work on this subject of skull base and cavernous sinus. And many of you know that I have spent more than 35 years on cavernous sinus and skull base. And it will be a pleasure to give you my current concepts and my historical concepts. And I must tell you, all the concepts which I'm going to discuss are my personal and my own, and they are not literature review or things like that. Skull-based tumors are complex, skull-based tumors are difficult, but what we have to understand is the dura. And if we understand dura, we understand skull-based tumors, and that is very, very essential and critical. Anatomy has to be learned and understood. There is no question about that. These are my two books. Just can you give me 1 minute? I have to close the window because I'm sitting on a beach. And there is too much noise of water. So now I hope you can hear me more clearly. Is that correct, John?
Yes,
Okay.
the beaches of Rio.
So these are my books. This was book published in 1996, which was reprinted 3 times. And still, I think it is quite relevant in the field of complex skull-based surgery. And before, we have to be philosophical, we have to be understanding, we have to understand the tumor, we have to understand the patient, we have to understand the needs of the patient, what patient wants and what kind of surgery should be done. We cannot be mechanical, we have to be, we have to be for the patient. And we have to understand the entire subject in a philosophical manner. So there are several philosophical papers of mine which I discussed in my earlier presentation about what cavernous sinus is, what is the role of cavernous sinus, what is the role of cavernous sinus in vision, in eye movements, in maintaining temperature of the brain and body, regulation of the function of pituitary gland, regulation of a number of activities which have been discussed by me. So this is the cavernous sinus. The entire venous drainage of the eyeball is into the cavernous sinus. I have discussed in the past. The eyeball, which is an entirely hydrodynamic system, water in front of eye, water in the lens, water behind the lens, fat behind the eye, are all a compact cavity. The entire venous drainage is into the cavernous sinus. And understanding how cavernous sinus affects the hydrodynamics of the eyeball is a very beautiful and untouched chapter in the history of neurosciences. So cavernous sinus, in my estimation, of course, I will not give all the details because these are all published, and I wish you go through the literature to find out how the eyeball cavernous sinus affects the function of retina, how it affects the function of the lens, and how it affects the function of eye movements. These are very critical things. Any pressure disruption in the eyeball and any disruption in the hydrodynamics of the eyeball can affect the retina, which is the most noble sense organ, as was discussed earlier. So we had labeled cavernous sinus like this is the circle of Willis. This intercavernous sinus connection and cavernous sinuses, we had related it to venous circle of relief of the brain. You press the eye, and how the pressures are dissipated into the cavernous sinuses is a very important thing that we have to realize. And when cavernous sinus thrombosis, even with presence of normal cranial nerve 6th, 3rd, and 4th, the cavernous sinus function may, eye movements may be lost, vision may be lost. So cavernous sinus affection, how it disturbs the eye function, is a very important thing that we can learn and understand. We have to understand. So it has great role in eye movements, role in vision. And these slides, of many of these slides, I have been talking about these slides and how the eye movements of deer are different from that of lion. I have discussed on several occasions, and why eye movements affect the size of the cavernous sinus. The cavernous sinus of a deer is much bigger than the cavernous sinus of a lion, and the eye movements difference between the two animals determines the size of the cavernous sinus. Eye of cavernous sinus of a fish is much larger than human cavernous sinus. There is some fat in the cavernous sinus of a fish. Cavernous sinus is responsible for eye movements and also responsible for swimming in a fish. Like you know about Romberg sign, when you close the eye, there is ataxia. Similarly, when you close the eye, when you puncture the eye of a fish, the fish cannot swim, and that relates how important the function of cavernous sinus is to the fish. So eye movements and various other beauties of the eye are related to cavernous sinus. Cavernous sinus is associated very closely to the sphenoid sinus and to the pituitary gland, and function of both these structures are directly affected by the cavernous sinus. Cavernous sinus has a big role in, John, just see what is happening here. So the sphenoid sinus and paranasal sinuses are like air conditioners of the body. The temperature in the nasal sinuses may be different, but as the nasal air passes through the nose into the trachea, the temperature becomes normal because of the high vascularity of the nasal mucosa. When you drink hot water or cold water, the temperature in the esophagus is normal because the heavy vascularity of the oral mucosa changes the temperature. So this is close, this air conditioner of the nasal and nasopharyngeal mucosa affects the temperature of the cavernous sinus. It relates the temperature to the pituitary gland. It relates the temperature to what is coming in the carotid artery and ultimately affects the temperature of the brain. So there are many issues which cannot be discussed at length here because Alam al-Dimag, this is from Arabic literature. I'm not sure if Sameh has read this or heard this. This mentions that meninges are the mother of brain. Like dura is durable. The dura covers the entire brain and in a absolutely incomplete compact fashion. But when the cranial nerves comes out of the brain and come out into the optic nerve, trigeminal nerve, other nerves, they take a sleeve of dura along. So that concept I'm going to discuss, that dura, when the cranial nerves come out of the brain, they do not come out through a hole in the dura. They take a sleeve of dura along with it. So this concept I'm going to discuss. And this concept has been the basis of my papers over several years about the surgery of cavernous sinus and how the arterial displacement impact the surgery of cavernous sinus is an important lesson. So this is the cavernous sinus and carotid artery is squeezed. Carotid artery is not squeezed, so these two tumors are different. Carotid artery is displaced. Carotid artery is encased, so these two tumors are different. So this paper of mine published 23 years ago was a very important in the historical perspective of cavernous sinus surgery. So I have been involved in complex skull-based surgery for several years, more than 35 years. This was one case I did in 1993, one of my prize case, which I like to show always. You see this tumor, which is quite a tumor. In 1993, I operated and resected this tumor. And over the years, I have realized that we have to learn the art of breaking the tumor. We have to learn the art of demolishing the tumor. We have to learn the art of removing the tumor without extensive coagulation. So 1995, I removed this tumor. This tumor I removed in 1995. Small bit of tumor was left behind. No radiation was given at that time. Even now, I don't like to give any kind of radiation to any meningioma unless I'm not able to resect. So my strategy for meningiomas like this is resect it. And if there is some residue, wait. And if that residue recurs, again resect it. But if you are not able to resect, or if your knife is not able to reach the tumor, then you think about giving radiation. Before that, don't try to learn the art of removing the tumors. Learn the art of neurosurgery. Not, we are neurosurgeons. We have to see how best we can do neurosurgery, and the best thing that we can do in neurosurgery is to remove the tumor. So this is another tumor which I showed earlier also, tumor in the retrobulbar region. In 1997, these tumors were obviously difficult to do, or maybe some of these tumors may not be even possible to remove 25 years ago. So this is one tumor, this is another tumor. This hemangiopericytoma, this was schwannoma. Both, this was removed first, this was removed second, and this is total removal. This was very vascular tumor, you see, after several years. And even now, this I had removed 25 years ago. Even today, this patient is quite well and without any deficit. For the first time in the literature, we described intracavernous sinus tumor extradural approach. Of course, we know the study of Vinko Dolenz as how he dealt with intracavernous aneurysms and things like that. But this paper of mine was for intracavernous sinus tumors, and extradural approach was the most beautiful approach for such tumors. So understanding the dura mater, dura mother, the layers of the dura and how they encase the cranial nerves, how the lateral wall of cavernous sinus keeps the trigeminal nerve, the third nerve, and the fourth nerve, and the sixth nerve within its confines is a very important thing that we have to understand. So this is the most vascular tumor of the body, of the brain, and the most benign tumor, cavernous hemangioma of cavernous sinus. This is the only tumor which is entirely within the confines of cavernous sinus. So this tumor, when it grows, it displaces the lateral wall of the dura of cavernous sinus along with the cranial nerve fifth, sixth, third, and fourth, and goes into the intercavernous sinus like this. So it goes anteriorly towards the orbit, goes towards the Meckel's cave, posteriorly goes towards the intercavernous sinus here. So this is a very confined tumor into the cavernous sinus. It encases the internal carotid artery. So it encases the artery but displaces all the cranial nerves around it. Even the sixth nerve is displaced by the tumor, not encased by the tumor. Even when the tumor becomes huge and large, it remains within the confines of cavernous sinus. You see, the dura is intact. It goes towards the Meckel cave. It goes towards the intercavernous sinus, does not go into the sella, goes towards the orbit, encases the internal carotid artery, displaces the sixth nerve here, displaces the third, fourth, and fifth nerve on the dome of the tumor. It is angiographically occult. If you can handle the bleeding, if you know how to control bleeding in a heavily vascular tumor, you can give absolutely new life to the patient. The technique of doing this tumor is, one is that you have to have extradural exposure, which we described for the first time for these tumors. Come extradural, the brain is not tight because this is a chronic and long-standing tumor. Open the lateral wall, open the displaced cranial nerves, and work within the cranial nerves, work within the triangles of the cranial nerves, and you then resect the tumor. So let me show you this case. This is the case of intracavernous cavernous hemangioma. Difficult case as it is, very heavily vascular case. And I hope I can show you the, you see here, I have opened the extradurally and I am splitting the gasserine ganglion, and then identifying a very heavily vascular tumor working within the fibers of the fifth cranial nerve. And then more importantly is to displace the sixth nerve inferiorly early in the operation and work towards the dome of the tumor under the dura. Respect the dura because the tumor respects the dura. And whilst if you are within the confines of the dura, the fifth nerve, the third and fourth nerve are on the dome and they will not be affected by your surgery. When you remove the tumor, the carotid artery comes under control. The tumor is bleeding quite furiously. This is almost an unedited version of the tape. And you see in how quickly this tumor can be removed, provided you respect the dura, provided you are knowing where the sixth cranial nerve is displaced, provided you know how to control the bleeding in this situation. And if you are lost, you are lost. Basically, you have to know how this tumor has to be debulked. You have to know how every tumor has to be debulked. So that art of understanding and then having an attack on the tumor with keeping that in perspective. You see, this is the artery of inferior lateral trunk of the cavernous sinus. You coagulate that and how the bleeding in the region stops, and then you can do quite a controlled resection. So meningeal arteries supply this tumor basically from the inferior lateral trunk. The bleeding now comes from the cavernous sinus, and you see how I'm holding the suction in my right hand to control the bleeding, suck the blood, and to dissect and to resect. So you can see that this tumor has been resected in exactly 5 minutes of surgery and bleeding has been appropriately handled. So once you remove the tumor, the venous bleeding of the cavernous sinus can become quite profuse. Then you have to pack the whole thing with gel foam on Surgicel, and the bleeding will stop. In this kind of dissection, what you have done is you have not, because you have worked within the confines of the cavernous sinus dura, you have been able to avoid exposure of the cranial nerve. The sixth cranial nerve is displaced on the inferior dome of the tumor. That is a new thing that I have identified, and I will like to show you. This is the post-operative image showing tumor resection. This is another patient who came with the issue of sixth nerve weakness and disturbed third nerve weakness as well. And this is the cavernous hemangioma. Let me briefly show you the video of this. Now this is, first you have to get the middle meningeal artery coagulated when you are doing extradural exposure. Then I'm doing extradural. You see how I'm peeling the dura off from the fifth cranial nerve, identifying the foramen rotundum, foramen ovale, and the supraorbital fissure, working within bleeding. There is no need, if you go on coagulating and coagulating, I don't think you can ever finish this kind of vascular surgery. What you have to do is you have to understand the dura of each cranial nerve. You see here now I have reached the extradurally, I have exposed the whole cavernous sinus. The divisions of the fifth cranial nerve are still encased with the dura. And then I will try to open the dura between the cranial nerves. You just see this operation. The tumor is of red color, and maybe now you see here is the V1 division. This is the V2 division. I am working between V. First, I tried to work in the Parkinson's triangle, but I don't think I got enough space in working in this area. Then I moved my direction of surgery. So I am working actually in the Parkinson triangle. First thing that I will like to do is I will like to identify and save the sixth nerve. You see it is bleeding quite furiously. And you will see how that is the sixth nerve on the inferior dome of the tumor. That is very important to realize, that sixth nerve identification and saving early in the operation. And then you remove the tumor, and this is the carotid artery. Sixth nerve is here, which is displaced, and this is at the end of the operation. Now you see, this is preoperative. This patient not only has eye movement disturbance, but also has severe headache. And this smile which has come, these eyeballs have returned back to normal functioning. This is another tumor, huge tumor with a internal carotid artery aneurysm. Same configuration, lateral dural wall displaced, goes towards the intercavernous sinus, towards the Meckel cave, towards the orbit. I removed the tumor and I clipped the aneurysm. And this was the first case. This was flow-related aneurysm. So this is another tumor which is of similar configuration. Recently, I published my series with 48 cases of cavernous hemangiomas of cavernous sinus, which is the largest published series in the world. Now I rapidly go on giant pituitary tumors, which is also a very fascinating subject and a subject which is very common in our life of neurosurgeon. And there are several articles of mine. These tumors can become big, these tumors can become huge and massive, and these tumors can become dangerous, but they are benign. And if you are able to remove these tumors, you give new life and new vision to these tumors. So we said about 25 years ago that the diaphragm cell is elevated by the tumor. So this concept that the diaphragm, the dura of the diaphragm is elevated and not transgressed has completely revolutionized pituitary tumor surgery. So my grade 1 pituitary tumor is when the tumor elevates the dome of the diaphragm and it does not go into the cavernous sinus, that is grade 1. You see the dura is elevated. This concept was not there 25 years ago. The concept that existed was this supracellular part of the tumor is subarachnoid in location. And if this is subarachnoid, then it will have very serious relationship with the arteries of circle of Willis and the perforators. So if there is dura, then if there is dura here, the whole thing is under the, between the dura, you can remove this tumor quite safely. When there is a nubbin like this is also within the dura. If there is a nubbin like this is also a dural nubbin. So we have to understand that if you have to remove this tumor from the nose or from the skull, this dura is going to protect you and make your operation simple. So the understanding of the dura is absolutely critical. And if you don't want to understand this dural anatomy, you will never be able to remove this tumor. Grade 2 tumor is that when the tumor is going into the cavernous sinus, lateral wall is displaced by the tumor. So this tumor encases the carotid artery, which is a very wonderful character of pituitary tumor. Elevates the diaphragm, displaces the dura. Elevates the diaphragm, displaces the dura. Intracavernous extension is common in pituitary tumor. What makes tumor goes in cavernous sinus is a different subject. Elevates the diaphragm, elevates the lateral wall, encases the carotid artery. So it is completely confined into the dura. So you encases the carotid artery, elevates the dura dome of the cavernous sinus. So this is another thing that we describe for the first time in the literature, that this tumor is also under the dura. This tumor is elevating the roof of cavernous sinus. It is not going in the brain. It is not subarachnoid in location. So there is dura here, there is dura here. This concept has completely revolutionized pituitary tumor surgery. You see, you can clearly see how the dura of the dome of the cavernous sinus is elevated. Dura of the diaphragm is elevated. Dura of the dome of cavernous sinus, dura of the diaphragm, dura of cavernous sinus. So it is very, very important to understand the anatomy of the dura. It is very rare that the tumor transgresses the dura and encases the artery of circle of Willis. And when it does this, these tumors are more aggressive in nature. So this is my classification. Grade 1, when it does not involve the cavernous sinus, it goes and remains under the dura. Even when the tumor is going beyond the corpus callosum, you see it is under the dura. This concept, you can imagine that all these surgeries were done transcranial 25 years ago, but now these tumors can be removed just by opening the anterior wall of cavern of the sella and then demolish the tumor, and you can remove these tumors. Grade 2 is when these tumors encase the cavernous sinus carotid artery and enter into cavernous sinus. Grade 3 is when the roof of cavernous sinus is elevated, the diaphragm is here. This is grade 3. And when the tumor goes beyond the diaphragm in the subarachnoid space, encases the artery, this is grade 4. So this classification, I think, my feeling is, and whether you agree or not, has completely changed surgery for pituitary tumors, particularly this concept of dura and concept of diaphragm. So these tumors, which were very difficult to remove several years ago, can be removed just removing the anterior wall of the sella. Learn the art of breaking the tumor, learn the art of demolishing the tumor, learn the art of removing the tumor amongst bleeding, learn the art of removing the tumor without coagulation, and you can remove these tumors in 15 minutes. More important is learn the anatomy of dura. So there is no need to remove plenum spinalis or tuberculum celli, just anterior wall, demolish the tumor, and the whole diaphragm will come into your picture. So as I have shown earlier on several occasions, this very favorite slide of mine, that the uterus, which is the strongest muscle of the body, has the power to push the baby out. There is no need for transabdominal surgery. This is the strongest muscle of the body. Similarly, the dura is a very strong anatomical structure. You remove the anterior wall and deliver the tumor. Debulk the tumor, debulk the tumor. These are soft tumors. These are breakable tumors. These are suckable tumors. Very rarely they are firm tumors, but even if they are firm, you can remove the tumor if you know that the diaphragm is going to protect you, if you know that you will never encounter arteries of circle of Willis unless you violate the dura, and you can do a beautiful resection. I did this resection in 20 years ago, this tumor resection. This tumor also quite a straightforward tumor. I will say this tumor should not take more than 15 or 20 minutes to be removed. Just open the anterior wall, demolish the tumor, debulk the tumor, and you will have the entire thing in your view, entire dura in your view. This subfrontal extension was a very classical indication for transcranial approach, but not necessary. Just remove the anterior wall of the sella, debulk, debulk, demolish, debulk, and the whole thing will come in your picture in a very quick time. Sometimes these tumors go into this direction, maybe an indication for transcranial approach, but this remove the anterior wall, get into the tumor, and you can have a very fantastic dissection. You can imagine this tumor I removed in 2001, and this was quite a huge tumor, but these, no matter how huge they become, how big they become, but they respect the dura. And that is very important for us to understand. Remove anterior wall, debulk the tumor, and in 20 years ago, I removed this tumor, and this patient is still alive. However, there is no further investigation, and he's well, and his vision is intact and improved. This tumor also I removed 22 years ago by just removing the anterior wall of the sella, and debulk the tumor, learn the art of breaking the tumor, and you will see the dura will help you bringing the tumor down. Some Valsalva maneuvering can be done, and this tumor can be removed completely. More important is, if you are able to remove this completely, the patient will improve dramatically in the vision and dramatically in his life. Tumor in the cavernous sinus, how they have to be removed is a different chapter, but understanding the dural anatomy can give you information as to how to remove this tumor. You can remove the tumor, even the dome of the tumor, which is elevating the roof of the cavernous sinus, dome of diaphragm celli, you can remove by understanding that these tumors are soft, these tumors are breakable, these tumors are defined. If you go on coagulating in this tumor, you will damage certainly the cranial nerves and also may be the carotid artery without removing the tumor. Tumor which goes beyond the diaphragm is a different chapter. We can discuss it at length at a later stage. Another beautiful dural respecting tumor is trigeminal neuronoma. And this paper of mine was, I think, a very fantastic paper. Trigeminal neuronoma arises from the Meckel's cave, like acoustic tumor arise from internal aortic meatus. In the middle fossa, they remain interdural. In the posterior fossa, we had described that they become subarachnoid. But now we have said recently that many of these posterior fossa tumor also are interdural. So work within the dura, and you can have a very beautiful resection. So these tumors are of three types, either only in the middle fossa or middle fossa and posterior fossa, or they may go extracranial. but extracranial and middle fossa are always interdural. Posterior fossa are on several occasions interdural and in some occasions subarachnoid in situation. So if you know how to debulk the tumor for the first time, we described that you can improve the trigeminal function as a series in this article in 2003. So open the dura, work within the dura, identify the trigeminal nerve early in the field, learn the art of breaking the tumor without coagulating and coagulating at strategic points, respect the dura, and you can remove these tumors. So in 2003, we presented 203 cases. In 73 cases, now we have more than 300 cases, which is certainly the largest series in the world. In 1995, on the basis of dural anatomy, we suggested that you don't even need to do craniotomy, have an infratemporal fossa exposure. I don't do this nowadays. Open the Meckel's cave, widen the foramen ovale, and you can do without craniotomy. So removing a skull-based tumor, removing a tumor in the cavernous sinus without craniotomy was described for the first time in this article in 1995. So you see, this is on the basis of clinical information and on the basis of radiological information, you can identify that this is trigeminal neurinoma, work within the dura without opening the skull, widening the Meckel's cave, and you can have a beautiful resection. This also in my same paper, tumor going in the posterior fossa, in the middle fossa, by doing just widening of the Meckel's cave without doing any kind of craniotomy. Of course, now this is also without craniotomy, I remove this tumor, understanding that this is within the dura and within the confines of dura without going beyond, and the cranial nerves are displaced on the dome. Very frequently, these tumors are located in the posterior cranial fossa, and then I do subtemporal exposure, then intradural exposure. We have to preserve the superior petrosal sinus or ligate the petrosal sinus and then work in both the compartments. So we have several years of experience of these kind of tumors. Early in my experience, I used to do two-stage exposure. Like this tumor, first I removed the middle fossa component and then the posterior fossa component in 1991. In 1992, I first removed the posterior fossa and then the middle fossa. This is the tumor removed. But then as my experience went on increasing, understanding of dura went on increasing, I used to do such kind of middle fossa extension where I removed the roof of the zygoma, root of the zygoma, roof of the condyle, roof of the external ear canal, partial mastectomy to remove this dumbbell-shaped tumor. But nowadays, I don't do this extensive exposure. I do just splitting of the temporalis muscle and do a smallish craniotomy, basal craniotomy over the Meckel's cave, and then do extradural or intradural exposure to remove this tumor. For large dumbbell-shaped tumor, I do intradural exposure. For smaller dumbbells, I do it with extradural exposure. So these dumbbells can be removed beautifully, and these are the most beautiful chapters of skull-based surgery, where you can remove these benign tumors and give beautiful life to these tumors. Over the years, as I have mentioned, that I have done more than 300 cases. This tumor, you see, there is a nubbin here, but this nubbin is also interdural, like pituitary tumor I showed. Work within the tumor, work within the dura, demolish the tumor. These are soft tumors. These are breakable tumors. These are bone eroding tumors. You see, anticlinoid is eroded, petrous bone is eroded. Work within the dura, identify the things in a perspective and save the fifth cranial nerve. When the tumor goes extracranial, it is covered by dura. This is also a beautiful fact, and you can, I did reverse transcranial operation, reverse skull-based operation. So you see this extension along V1, extension along V2, extension along V3. Do a small basal craniotomy, open the dura. These tumors will remain within the dura. Break the tumor, break the tumor. Don't violate the dura, and you can have a beautiful tumor resection. Even when there is an apoplectic or a large recurrence of trigeminal neurinomas, even then they are within the dural confines. That anatomy is very important to understand. Now I want to show you third nerve neurinoma. Third nerve neurinomas arise within the oculomotor system. They elevate the dura and remain within the dura. Can you imagine this tumor can be just open the dura where the third nerve is not likely to be there, and then learn the art of breaking the tumor without doing much manipulation, have a very basal exposure, and preserve the dura and the region of the third cranial nerve. You see here this tumor. This is my paper where we had described that third nerve oculomotor system. This tumor arises and elevates the dura, and this tumor remains within the dura. You see this tumor, if you realize that this is within the dura, you can have preserved eye function. If you remove the so-called capsule, which is the dura, you will never be able to preserve the third nerve function. And you have to know exactly how the third nerve courses and how you can protect the fibers of the third nerve. You see here very clearly it is seen how the dura of the third dura is elevated around the dome of the third nerve. This is the sixth nerve schwannoma, which are relatively rare, and they encase the internal carotid artery due to its proximity. But I have now realized that these tumors have also considerable interdural location. Similarly, seventh cranial nerve, you can imagine this tumor, which can be considered to be a high-profile skull-based tumor, and you will need very extensive exposures and all those things. But if I tell you that this tumor arises in the region of geniculate ganglion, and then it elevates the dural dome in the posterior fossa and in the middle fossa. You come from lateral, make a transverse incision, break into the tumor, avoid the region of seventh nerve, and there is a beautiful chance of saving the seventh nerve function and doing these tumors quickly in a very rapid fashion without doing any major petrosectomy and things like that. Similarly, I said that the lower cranial nerves arise in the region of the jugular bulb, and when they become large, they remain interdural in a majority of situations. When there is a dumbbell shape and when there is tumor has multi-compartmental extension, more often than not, the intracranial component is also within the dura. They make a lateral petrosectomy, expose the region of the tumor, make a transverse incision, go inside the tumor, remain within the confines of the tumor. And for the very first time in the literature, in this article of mine, we said that you can improve the function of the lower cranial nerve. So that is a beauty. But many a time in such tumors which are multi-compartmental, even the posterior fossa is almost always within the dura. However, if the tumor arises, it is mainly located in the posterior fossa, it may not be interdural. Then, of course, you have to do dissection to save the nerves, which are very important and critical. If you damage the lower cranial nerves, you have damaged the patient. Now I want to show you C2 neurinomas, which are outside the canal, behind the atlantoaxial joint. When they become large, they dilate the C2 ganglion. And we remove for these kind of tumors for the first time without laminectomy, like we did trigeminal neurinoma without craniotomy, we did these tumors without laminectomy. So these tumors, earlier in my experience, we thought that like trigeminal neurinoma, we thought that these are intradural or subarachnoid in situation. But now I realize that all the three components of C2 neurinomas are within the dura. Believe me or not, my dear friends, if you realize and if you understand that these three components of the tumor are within the dura, you take a lateral incision in the lateral after opening the midline exposure, work within the dura, these tumors can be removed in absolutely quick time. And I must tell you, of course, time is not a factor, but many of these tumors I remove within 15 or 20 minutes. The whole of this tumor in particular, certainly can be removed in 15 minutes by opening the lateral wall, demolish the tumor, vertebral artery will be away from you, and the ganglion, the nerve fibers of the ganglion will be on the dome of the tumor, and you can actually try to save the dome, but there is no need to save the second cranial nerve, which are having very little function. So earlier in 2008, I thought these three compartments, this part is intradural, but in 2018, I published my new series with 50 cases. And I mentioned that all three are interdural in location. Quickly to show you cases, you see this is interdural, make a lateral wall incision, break into the tumor, like you do for trigeminal neurinoma. You can remove the C2 neurinoma very easily and very quickly. Now to show you rapidly chordomas, what, my dear friends, I am showing you my own work over the years, over the last 35 years, as to how I have developed my neurosurgery, how I have developed my skull-based surgery on the basis of understanding of the dura. Chordomas are very peculiar tumors, strange tumors. They demolish the bone, but displace the soft tissue. They displace the carotid artery anteriorly, they displace the cavernous sinus superiorly. You come from, and they are extradural. Now recently we have identified that the sixth nerve is also displaced on the superior dome of the tumor. That is another beautiful thing that we have recently described. Now I described you see this tumor chondrosarcoma displaces the internal carotid artery anteriorly, demolishes the bone, and also displaces the sixth nerve on the posterior aspect of the tumor like that. So that is why, because of the stretch, the sixth nerve is involved more commonly. So chordoma and chondrosarcomas have very characteristic relationship to internal carotid artery and to the cavernous sinus nerves. So understanding this anatomy, we had described in 1995 a very beautiful approach, and still it is very relevant. Middle fossa, subgastrian ganglion, and transgastrian ganglion approach to cavernous sinus chordomas. So these tumors, they destroy the bone, displace the carotid artery. And this is a very important diagnostic feature. And if you know that this is a chordoma, you can do a very beautiful surgical resection. So this is a chordoma, and on the basis, I just want to show you how beautifully from a lateral perspective you can get anatomy. Of course, you can do from nose, and of course you can use endoscopes and things like that. But lateral approach, you see, is also carotid artery, the fifth cranial nerves, you can see, and how the tumor is being resected. Recently, I described supracerebellar approach to Clivus chordoma. You see this tumor, you can remove from this direction, you can do from lateral direction, but I removed it from supracerebellar because I now realize that the sixth nerve is located here on the posterior dome of the tumor, and then it traverses along the third and fourth cranial nerve. So you come from here, make a smallish dural incision. These tumors are soft tumors. Identify the sixth nerve early in the operation, then demolish the tumor, and you can remove from a posterior perspective the entire tumor. So this is another chordoma which I remove from a posterior perspective completely. The advantage of supracerebellar approach is tumors which are predominantly in the posterior cranial fossa, you can see the bulk of the tumor early in the operation. You can see sixth nerve early in the operation and then preserve the sixth nerve. I'm not saying we preserve the sixth nerve in this massive case, but there is a possibility of preserving these tumors best when you're doing posterior lateral supracerebellar approach. I'm not saying do this approach in all the cases, but it is a possibility. Just to say a few sentences about nasopharyngeal angiofibromas, they are extracranial and subcavernous sinus in location, and you can develop a beautiful plane of dissection in that plane. Nasopharyngeal angiofibromas are tumors which can be removed in a very blunt plane. They are extracranial and extradural, and this plane of dissection can be beautifully identified. We described in 1994 transcranial operation for these tumors, but now, of course, I will not recommend. You can do with a smallish mid-facial degloving operation. There are some tumors like epidermoids, dermoids, fungal infection, aspergillomas. So in my life of these tumors, tuberculoma, cavernous sinus meningioma is a huge chapter. I know Samay will be getting restless, John will be getting restless, but I will talk in my next lecture on cavernous sinus meningiomas as to why cavernous sinus meningiomas are different and what is the philosophical issues when you are having a cavernous sinus meningioma at hand. In any case, I thank my dear Samay to give me this opportunity to give my concepts. And these are personal concepts which I have developed over several years of neurosurgery. I have lived in cavernous sinus. I have loved cavernous sinus. I have resected cavernous sinus tumors, and I have tried to preserve dura, which I consider dura mater or dura mother, and which is a very important thing that you have to do when you are resecting skull-based tumors. So thank you very much, my dear friends.
Thanks a lot, dear friend, for this excellent presentation. Is there any question from panelists?
No, I'd just like to say thank you, Atul. You went to Bogota, you had a camp, and now you're in Rio, and now on your afternoon off, you're giving a presentation. Thanks a lot.
Thank you, John. This is you will be surprised, John, when I went to Bogota. People from Ecuador, from Peru, from Guatemala, from all these countries knew me personally. They knew me, and they, you will be surprised that I was photographed with young people more than 200 times during this Bogota meeting. And, this was because of the webinars I have been presenting, because of your forum that you have made and developed. I think this has gone into the depth of the world, and it has given me a big platform to deliver my message throughout the world. So thank you, John. Thank you, Sameh, for this opportunity.
Thank you.
Thank you. And now we will shift to the next speaker. So we're going to Haya. Please start sharing your screen. Thank you. Please unmute yourself.
Okay. Can you hear me and can you see my presentation?
Yes, you're going to make it hi, Roberto. You're going to make it larger presentation mode.
Hello, everybody. First of all, I want to say I have nothing to say about the presentation, Professor Atul. It was amazing presentation and amazing experience from Professor. Congratulations for him. I'm going to talk about our experience using intraoperative MRI. In the last 20 years, we was operating with intraoperative MRI in Buenos Aires. I'm going to show this. Okay. Thank you, Professor Hassan, for inviting me. Thank you very much for this opportunity to stay here in this important meeting. Thank you very much. I'm from Buenos Aires, Argentina, in South America. This is my country here, close to Brazil, Uruguay, Chile, and this is Buenos Aires in South America. My first question is it the real glioma treatment results, or these values are based on incomplete surgical resection? Of course, we are leave aside the high-grade gliomas, but I'm going to talk mainly about low-grade gliomas and what I have will be the treatment of these tumors and the concept of the main goals of the surgery in low-grade gliomas. What does the bibliography tell us? For example, Professor Raymond Sawaya from Anderson Cancer Center in the United States, he reviewed the bibliography, and over the past decade, in some series of glioma surgery, the number of gross total resection has been limited to a mere 6.2, 12% of the total. This means that 90% were partial resection of these tumors. And the most of the patients with incomplete low-grade glioma removals die within the first 5, 6, 7 years because recurrence or malignant transformation of the tumor. And it is an important, very important date. The first neurosurgeon in the world who operated using intraoperative MRI was Professor Peter Black in Boston, Brigham and Women's Hospital in the United States. The second country was Germany, then Finland, Canada, and the 5th country in the world where we could use intraoperative MRI was Argentina in our apartment in Buenos Aires. And between July 2000 and December 2021, more than 500 patients with gliomas were operated using intraoperative MRI, and plus one or more of navigation, brain mapping, airway patient surgery, and other tools. We have in our department intraoperative MRI and these other very useful tools for making total resection in low-grade glioma surgery. But this is the main concept. In low-grade glioma surgery, we think that we have to do complete removal of the tumor to try to cure the patient. Of course, with minimal or no permanent neurological dysfunction, neurological deficit. This is our operating room. In these days, we are changing our magnet, our MRI, for a new system. But this is our first operating room with this magnet, 0.23 Tesla. This is the other side of the operating room. And here you can see the team, my team working during the surgery. How do we do this? How is a surgery with intraoperative MRI? Here you can see a tumor, typical high-grade glioma in occipital lobe on the right. We put the patient in surgical position and we do the surgery in normal condition. We do the craniotomy. Here you can see the magnet is very close, near to the surgical table. Here, we are working here. This is the operating room. And we remove the tumor, taking into account anatomical and morphological repairs, and we go on with the resection of the tumor. But at some moment during the surgery, when the things look at the same but are not the same, at this point, we don't know if we are leaving tumor in the bottom of the cavity or not. At this moment, we put some marks and we do intraoperative MRI images. We can check the surgical step with intraoperative MRI. Then we go on with the surgery. If we see there is something else of tumor to be removed, we go on with the surgery. And here you can see the tumor here before and after removing with the marks on the bottom of the cavity and the patient in very good condition. I'm going to show you some surgical cases. For example, this was one of our first patients operated on July 2001. It was extraventricular neurocytoma in a 9-year-old boy. This is the patient with no tumor, 7 years postoperative, and you can see here, 21 years postoperative. This is that boy with his family here, and this is my question. A good surgery could be the cure at least in some number of patients. This patient was operated on 2006. This oligodendroglioma, we use intraoperative MRI, we use electrocortical stimulation, and here you can see the patient. This is his last MRI, and this is the patient. Nowadays he is in very good condition with the tumor completely removed and the patient with normal life. This case is about a multicentric oligodendroglioma in 30 years old patient. He had two tumors, one in the right temporal lobe and the other in left parietal lobe, very close to motor area here. We decided to remove, in the first time, the temporal lobe, then the parietal lobe, using electrocortical stimulation to detect the motor area. And here is the tumor. And this is the patient. You can see 7 years postoperative with his first son. This is the patient 10 years postoperative, 12 years postoperative with two tumors and without sequela and without tumor. And here with his nice family. Infiltrating low-grade glioma, left frontal lobe tumor. We expose the area. This is the tumor. Here in the intraoperative control, left a piece of tumor remnant. Here we decide to remove it, complete resection. And this is the patient with completely normal life and working several years. I think is 12 years postoperative. Tumors located in midline, astrocytoma pilocytic in the midline. In this case, we can use neuronavigation plus intraoperative MRI. You can't operate away this patient, this tumor, but yes, you can operate it with intraoperative MRI. This is the MRI after resection, after removing the tumor. With no tumor here, the patient in very good condition, immediately postoperative. Another important point is that the tumor has not neurological function. When you do functional MRI, you can see the functional areas around the tumor, but not into the tumor. We decided to remove this tumor very close to the Broca area, only with intraoperative MRI, not away patient, with intraoperative MRI. We decided to remove it, the surgical surface, you can see the tumor here. And after removing it, complete resection, this is the patient. You can see 10 years after surgery, completely normal. A patient with tumor in pars opercularis, pars triangularis, pars orbitalis. This tumor was in pars opercularis, Broca area. This is intraoperative MRI. Here you can see the head is open, and this is the area of removing, when we remove the tumor. Here you can see this is the resection of pars opercularis completely in the intraoperative MRI, and the patient completely normal because the tumor have not function. It is very important neurophysiological monitoring. It is important to have a good team and plus the technology. This tumor, this was a high-grade glioma. It was located in very close to motor area, and here we use electrocortical stimulation, evoke potential to localize the tumor. This is the central sulcus, and this is the area of the tumor here. Comparing with MRI, we put some marks and confirm the location of the tumor, and we remove it. It is intraoperative MRI with complete resection of the tumor. This is the area of the tumor. After removing it, and the patient very good condition, he was operated 2013, and this patient is completely free of tumor and completely normal life nowadays. In insular tumors, it's very useful to have the possibility to operate with intraoperative MRI. We have more than 70 cases of insular tumors operated with intraoperative MRI. Here you can see the classical, the typical craniotomy. We open the Sivan fissure, export the tumor, removing it. We can use subcortical stimulation to detect the cortical spinal tract, and this is the final view of the surgical bed. And here you can see the patient a few days and several months after surgery, and here with complete resection of the tumor in the insular area. This patient was a baby, 3 years old, with insular tumor too. You can't operate away this patient, 3 years old, but yes, you can operate using intraoperative MRI. Here you can see one of the first control with this remnant of tumor. Here we remove partially the tumor, but we have here this remnant of tumor. And here the last control, intraoperative control, the head is open here with this resection, and the patient a few days after surgery completely normal. And this is the patient several years ago, several years after the surgery with complete resection, no tumor, the patient plenty healthy. Watch and wait is not an option in low-grade glioma. It's not an option. You can see this tumor, September 2005, and this tumor here, November 2006, and here April 2007. The sooner the better. We have to operate this tumor early. The sooner the better for the evolution of the patient. We operated, and here you can see 3 years postoperative, the patient with slight hemiparesia here. 22 years old, a young woman with this huge tumor. We can remove it using intraoperative MRI. This is the patient 5 years postoperative, completely normal. Neuronavigation, surgical programming is very important, taking into account the white fibers. In this tumor, located deep inside the brain, a small tumor, but deep inside the brain, we study the fibers with tractography, and we selected the entry zone to attack the tumor using intraoperative MRI, neuronavigation. This is the entry zone we selected. Here we are starting the surgery. During the surgery with neuronavigation. And here you can see it was a xanthoastrocytoma pleomorphico. Here we are removing the tumor. Here the same. This is the final aspect after removing it. Here. And this is the patient with a mark on the bottom of the surgical bed. This is the patient completely normal and complete resection of this tumor. Some words about away patient surgery and intraoperative MRI. We can use both together, no problem. You can operate a patient awake using intraoperative MRI, but surgery with patient awake is an excellent tool, but it cannot be considered the gold standard in the surgery of glioma, how some neurosurgeons say, because many patients cannot be operated awake. It is a good tool, very good tool to preserve neurological function, but it does not allow us to know if we remove the tumor completely. It's very good to preserve neurological function, but you can see in 64% of the cases, there were tumor remnants using a awake patient technique. But you can change it using intraoperative. Intraoperative confirmation of residual tumor during awake surgery led to further tumor resection. With awake patient surgery, in many cases, there were tumor remnants. And you cannot operate awake more than 50% of the patient who has a brain tumor. This is the list. You can't operate awake infants, children, teenagers, patients with a lot of excess weight. This list is very important. In our experience, you can see low-grade glioma operated. She had operated in 2007. This huge tumor here. This is the patient, awake, evocative potential. The tumor was located in this area. We remove the tumor. You can see here complete resection in the MRI, the brainstem completely free. Another case with a tumor in Wernicke area, a man 23 years old, low-grade glioma. You can use awake surgical technique and intraoperative MRI, no problem. In conclusion, I think this is not the real result of all treatments of low-grade glioma. This is not the final evolution of glioma treatment. The last example, 2 years old baby girl. She was operated in Europe for a neurosurgeon with using neuronavigation, but this MRI was 6 months MRI 6 months after that first surgery with this tumor remnant, important and very difficult tumor remnant here. This is the tumor 6 months after surgery. This is the baby. This is the baby in surgical position, 10 days post-operative, 1 month, during the winter holidays with her family. This is the patient, 3 years post-operative, 6 years post-operative, MRI 7 years post-operative with no tumor. This is February 2017. With here you can see complete resection of the tumor. The patient is a teenager, 14 years old. This is the patient in Disneyland with complete resection. This is one of her last MRI. And this is the difference. Partial resection. Again, complete resection. Here you can see 13 years patient with her mother, complete resection, and patient could be cured, completely cured of this important low-grade glioma. And this is very important. This is, if we make a subtotal resection in 10 years' time, we would be losing nearly 50% of our operated patients. And it is a very important difference. Gross total resection, the most of the patient will be alive 10 years after surgery, but with subtotal resection, 50% will be alive at 10 years. It is a very important difference. In our series, we achieved gross total resection in 81.7% of the cases and subtotal resection in 11.3%. In this zone are patients who was operated previously in another apartment 2, 3, 4 times. But we think this number could be higher if we don't consider this patient who arrived to our apartment with previous surgeries. The main goal, I repeat, in low-grade glioma surgery would be complete removal of the tumor to try to cure these patients. Of course, preventing neurological dysfunction and with minimal or no permanent neurological deficit or dysfunction in the function, neurological function. Okay, thank you for your attention. If you sometime visit my country, this is Iguazu Falls, very nice natural falls in the north of my country. Thank you very much for your attention. Thank you, Professor Samir. Thank you very much, everybody.
Thanks a lot, dear friend, for this excellent, nice presentation. Is there any question from panelists? Thank you, sir. And now we will shift to next speaker, my brother, Dr. Hisham Basyouni. Please start sharing your screen.
I would like to, but I think Professor Herrera has to unshare his screen.
Okay.
Okay.
So I hope you can see me.
Yes.
So thank you very much, Dr. Sameh, for your kind invitation, Dr. John. And yeah, congratulations for the sixth anniversary, and also congratulations. I just saw that Dr. Sameh had birthday also some days ago. So my wishes for continued success in every regard. So my topic is the versatility of the microsurgical endoscopic assisted transcallosal approach. And of course, as in all the approach topics, we have to begin with the anatomy and anatomical basis of this transcallosal approach, and used most often the wonderful images from Rotman's anatomy. So you can see here the first step in the interhemispheric approach, which is usually centered in the anterior transcallosal approach around the coronal suture. Usually standard is 2/3 in front and 1/3 behind. And you have to take care about these bridging beams. And when you enter the interhemispheric cleft, you have on your medial side the falx cerebri, and on the lateral side, in this sagittal view, you can see it. You have the superior frontal gyrus, and you have the cingulate gyrus. The inferior sagittal sinus, it can be prominent, it can be almost non-visible, and then you reach the corpus callosum, and above the corpus callosum you have got the pericallosal arteries, or specifically in this approach the A4 part of the anterior cerebral arteries. So then you enter the lateral ventricle, and the connection between the CSF connection between the lateral ventricle and the third ventricle is the foramen Monroy on both sides. And then you have a view on the floor of the third ventricle dorsally you can see the aqueduct, then the midbrain, then the corpora mammillaria, and in front of the corpora mammillaria, as you know, we are performing the third ventricular tumor. So a close-up after performing the callosotomy, you can see the foramen Monroy, which is usually in the dilated ventricles, except one example I'm going to show you, a colloid cyst, but usually which is also dilated. And it is bounded medially and in front by the important fornix, the body of fornix and the column of fornix, and laterally also by the very important structure, which is the anterior thalamus. So here you can see the venous structures, which are important. Most important is the thalamostriate vein, which lies in the sulcus between the thalamus and the nucleus caudatus, the caudate nucleus. And you've got the superior choroidal vein, which is going with the choroid plexus, and the anterior septal veins, and the latter two you can section in order to enlarge the foramen of Monroy. In this image, you can see the approach, the callosotomy, which can be in between the pericallosal arteries or which can be beside, and this depends on the local anatomy. So there is no rule to this, but the local anatomy makes for you the decision how to enter the lateral ventricle. So to give you one example, this is a patient, 59-year-old man, with progressive memory and sensory disturbances on the right side. And you can see this tumor, which is restricted to the anterior horn. And you can see also in the MRI, and you have to analyze these carefully preoperatively, the internal cerebral vein, and also here the venous ankle, and on the other side it's better viewed, but you can see it also on this side, the thalamostriate vein. So this is the sagittal view, and here you've got the internal cerebral vein and the venous ankle and the thalamostriate vein, important structures which you have to save. And this is the tumor. This is the coronal view preoperatively. Now in this case, these are the pericallosal arteries, the corpus callosum, and in this patient I went in between both pericallosal arteries, and after opening the corpus callosum, this grayish and quite rubbery tumor was visible. It turned out to be a subependymoma histologically, and this is after resection. You can see the foramen Monroy after resection of the tumor. This is the postoperative or preoperative and postoperative images after removing of the tumor. Also in the sagittal view, yes, you can see the callosotomy in front, and also in the coronal view, and you can see also the callosotomy. And this is the patient on day 5 after surgery, had no neurological deficits or any complaints. So the preoperative symptoms had regressed. So for entering the third ventricle, you can have 3 routes. 3 routes from the superior or the transcallosal approach. There are other routes from posterior, of course, and from anterior through the lamina terminalis, but we're talking about the transcallosal approach. So you can have the interfornicial approach in between the fornices. This is not a natural cleft, but you have to create it. The other approach most commonly used is going through a natural cleft, going through the tenia fornicis, between the choroid plexus and between the fornix. And the third route is the so-called subchoroidal. Actually, it's also a transchoroidal approach, but it's called specifically a subchoroidal approach. And it's going through the tenia choroidea in between the choroid plexus and on the thalamic side. So giving you an example, for the interphoneal approach, this is the 34-year-old man with recurrent midbrain bleeding due to a cavernoma. And he was preoperative immobilized and had a bilateral ptosis. And the aqueduct here was completely occluded. He had consecutive occlusive hydrocephalus, which was treated with a ventricular drainage preoperatively. It came as an emergency case. This is the endoscopy after removal. This is an older video I used. The retractor, I'm not using it anymore. And you see here the interphoneal approach. This is one fornix, this is the other. And it had to be created, this approach had to be created. And you see here the foramen Monroy, you see here the thalamostriate vein, the plexus choroideus, the anterior septal vein. And when entering the third ventricle, you can see here the thalamus, the adhesio interthalamica, or massa intermedia, also called, the internal cerebral veins on both sides. And this is the resection area in the midbrain of the cavernoma and the hematoma. And you can see here the corpora mammillaria. I also performed in this patient third ventriculostomy, but this endoscopy was before performing the third ventriculostomy. You can see the chiasm. So this is before and after surgery. 1 year after surgery is now the aqueduct is patent, which was not the case before. There is also, in addition, a third ventriculostomy just to get sure about the patency and the CSF circulation. So this patient did not need any CSF drainage or shunting. There was the patient before surgery. He had a bilateral oculomotor palsy, which remained and persisted after surgery, but now he was mobile, independent, and came to the follow-up alone without assistance. The oculomotor palsy was corrected by the ophthalmologist afterwards. So this is a neurosurgical classique. It's colloidal cyst of the third ventricle with a typical location here. And this is a benign disease, as you of course know that it may be potentially fatal because of the occlusive hydrocephalus. So it should be taken seriously and also treated adequately. And there's some risk in following up these patients because in this patient the colloid cyst was known for some years, but he, despite of the follow-up, he came as an emergency patient, and you can see why. This is the occlusion of the high occlusive type of hydrocephalus with thinning of the corpus callosum, or the small third ventricle and small fourth ventricle, which is typical in these patients. And this is the colloid cyst here, also in a typical location in the anterior superior part of the third ventricle. So this is the positioning, and I prefer a sagittal incision. You can do other incisions, but I like this slightly paramedian. This is the cortex. This is the falcine side. You can see here, this is the callosomarginal arteries, and you have to not to confuse the cingulate gyrus with the corpus callosum, because they may be very adherent, but there's a difference in coloration, as you can see here. This is the corpus callosum, and this is the cingulate gyrus, very bright, the corpus callosum. In this patient, I went in between the pericallosal arteries, performing the callosotomy in between. This is the callosotomy. And with CSF egress in these patients with hydrocephalus, you gain more space, so retractor is not needed, required. And you can see here the closure of the foramen monroe. In this patient, due to the chronic pressure, the septum pellucidum was fenestrated, so you had a very good overview on both sides. So this is the left lateral ventricle. You see the complete occlusion of the foramen monroe here. You see the thalamostriate vein, the anterior septal vein, probably the anterior caudate vein, the plexus choroideus, and this is the remnant of the septum pellucidum. On the right side, you see also a complete occlusion, and you see this bulging underneath, which is the colloid cyst. So in this patient, I performed cochoroidal approach. That's to say on the forniceal side. This is the anterior septal vein, which can be cut in order to enlarge the foramen of monroe. And you can see this typical cyst. You can internal decompress the cyst, just not to reduce the pressure. You see these are the vascularization of the capsule of the cyst, which has to be cut selectively. Of course, on the lateral side, you've got the thalamus. And here is, usually there's an adherence to both plexus choroideus on both sides, which has not to, you have not to disrupt it, but coagulate it selectively and cut it, and then get the cyst out completely. That's very important to get it out completely. Of course, you can do this also purely endoscopic. I prefer to do it microsurgical and endoscopic assisted. You can see now the open foramen monroe on the left side, the plexus choroideus, thalamostriate vein, anterior septal vein, and on the right side also nice opening. And this is the incision of the corpus callosum, which is usually 1.5 centimeters in length. So this is the preoperative and this is the postoperative MRI in this patient after removal of the colloid cyst. And you can see here in the sagittal view the callosotomy and the removal also the coronal section. This is the patient 12 days after surgery, normal, and shortly afterwards he had also returned to his previous work as an IT specialist. As you can see here now, the incision, this was at the day of stitch removal. So another example, quite different. This was also a young lady, 21 years old, suffering from headache, short memory deficit, papillary edema, and decreased physical mental performance. She said she feels as being under a cover, and the cause was an aqueduct stenosis, which you can see here in the distal aqueduct, with consecutive dilatation of the lateral and third ventricle. And you can see in the axial view this dilatation of the aqueduct. You can, by the way, you can see here the oculomotor nerves on both sides. And you can see also as a widening of the optic sheath on both sides, and she had papillary edema clinically, also ballooning of the intracellular contents. So in this patient, I also performed a transchoroidal approach, and you can see in this case prominent inferior sagittal sinus, which is not always seen nicely as in this. Neuronavigation is, I use it in all these approaches, it's great help. But of course, if it fails, the neuronavigation can also continue with the anatomical landmarks. So this is after entering the lateral ventricle, the choroid plexus, The choroid plexus I'm usually coagulating it in order to have a better overview of the clefts to perform the transchoroidal approach. And this is also sectioning of the anterior septal vein, and then you enter the third ventricle. In this patient, I first performed third ventriculostomy. You can see it here. These are the corpora mammillaria behind, and you can see here this third ventriculostomy. And then going posteriorly, you can see here the posterior commissure and the aqueduct and this web or closure of the aqueduct. You can see it nicely here, and this is the cause of the hydrocephalus in this patient. And then I'm dilating this area, of course, very carefully in order to protect the oculomotor and trochlear nucleus, which are lying in close proximity. So this is after opening, and this is the endoscopy. This is showing you the third ventriculostomy. Usually in the hydrocephalic patient, the corpora mammillaria are not so nicely visible, but because of the chronic compression. And this is here the basilar artery, both posterior cerebral arteries. You can see the chiasm in front. And now going posteriorly, you can see the internal cerebral vein and the main tributary, which is the thalamostriate vein. And you can see posteriorly here the opened aqueduct and the posterior commissure. And also this was performed it was a bit larger than 1.5 centimeters. So these are the CSF studies, MRI CSF studies after surgery. You can see here the patency of the third ventriculostomy, and you can see here also posteriorly the patency of the aqueduct. This is a longer sequence. You can see here the aqueduct nicely opened. And this is the patient 5 days after surgery. And this is the preoperative MRI, and this is the follow-up after 2 years. The patency of the aqueduct and also the patency of the third ventriculostomy, and you can see here the callosum. So my last case to show is thalamic cavernoma. And I'm showing you this case because this I'm using in this the subchoroidal approach. So this is the 62-year-old man with a familiar cavernomatosis. He, as a granddad, had it, his son had it, and the daughter of the son had it. The thalamic cavernoma was growing. There were multiple cavernomas, but the one in the thalamus was growing and had new symptoms. Headache is quite unspecific, but he had increasing short memory deficit and hemihypostasia. So discussed it with him, and he wanted to the removal of this thalamic cavernoma. And you can see that the cavernoma is abutting on the interpeduncular space. You can see here. And in this patient, I performed fiber tracking preoperatively, and you can see that the pyramidal tracts are just lateral to the cavernoma, so you have to be very careful. And that's why I also used intraoperative neuromonitoring, which I'm not routinely using, but in most of the cases, and this is of course a special one, you have to use intraoperative neuromonitoring and also use the stimulation suction by Rabe. So this is to show the subchoroidal avenue, and this here you see a twig of the pericallosal artery going to the cingulate gyrus, So in this case, it is also safer to perform a callosotomy in between both pericallosal arteries. You see here the bright white corpus callosum, neuronavigation. And in this patient, I used FLAIR neuronavigation in order to see the cavernoma better. And in this, of course, you have to go through a full thickness corpus callosum because it is not dilated. And he is performing a fenestration of the septum pellucidum so that it does not, by bulging, occlude your pathway, surgical pathway. You can see here the foramen Monroy. So that's the medial side. This is the fornix. I'm going laterally to the choroid plexus thalamic side, and you can see here the cavernoma in the third ventricle, in the lateral wall in the thalamus. You can see the typical aspect. Of course, this is a critical area. You have to be very careful. Cavernomas are also very different. There are cavernomas which you can nicely remove by going around and removal en bloc. This was not the case here. It had a lot of nests in the parenchyma. So here, for example, is one such an example of a cavernoma nest. And of course, you try to remove these lesions completely. This is the fenestration in the interpeduncular fossa. This is neuronavigation. You can see it here, that we're in the interpeduncular fossa. And this new endoscopy was very useful in this patient because you can see here small nests, which I could not see through the microscope. Here you can see cavernoma nests, which have to be removed. And this is a stimulation suction, as I said before. And now the cavernoma, there are no visible nests anymore, so the cavernoma is completely removed. And this is the cortex after removal. So this is the MRI follow-up at 8 months. This is the cavernoma, or this is pre and post-operatively. And also in the sagittal view, removal of the cavernoma. You can see here faintly the callosotomy, and this is the coronal view after removal. And these are the pyramidal tracts. This is an early postoperative fiber tracking. You can see they are intact. But the patient had a slight weakness of his leg on the right side, which regressed afterwards, became normal. But there was some deficit, and this is the control at 6 months. And also the hemihypostasia has regressed, and he had, after this follow-up, no new neurological deficits. So I would like to conclude that the transcallosal approach, if properly planned and performed, is a safe, effective, and I think very elegant route to lesions of the lateral and third ventricle. Of course, all the structures have to be protected, but especially the bridging veins, going with the sequence of preparation, the cingulate gyrus, which has not to be confused with the corpus callosum if they are adherent. The pericallosal arteries and its branches, the thalamus rate and internal cerebral veins, fornix, of course, thalamus, and the structures of the floor of the third ventricle. Of course, each step depends on the individual and local anatomy you see. and of course on the side and size of the lesion, and so there should be no dogmatism in the preparations. So thank you very much for your attention.
Thanks a lot, dear Professor, for this great, excellent presentation. Is there any question from panelists? Okay, thank you, sir. And now we will shift to next speaker, Professor Samandoaz. Please start sharing your screen.
Okay, so thank you very much for the invitation to talk to you today to this excellent educational event. My practice is based at the National Hospital for Neurology and Neurosurgery, Arcuate Square, which was established as the first institution specializing in brain pathology some 150 years ago. Up to this point, patients with neurological disease were housed in asylums for mentally unfit. And as you can see, the facade at the bottom is the same as it was some 150 years ago. It's in a beautiful, quiet square in the heart of central London, and it's surrounded by university buildings dedicated to research on neurological disease. My practice is mainly based on tumor surgery, and some of the pillars of my practice include evidence-based surgery. And I believe that a lot of research, particularly in the form of trials, are required to establish surgical techniques and also the role of extent of resection in a number of tumors, including gliomas. A number of my research is based on standardizing mapping techniques for awake brain surgery. And as we have seen in a number of studies from my group and other groups, there is a significant inter-observer variability with regards to understanding and interpretation of intraoperative tests. In other words, we don't quite agree as to what we should be testing and how they should be tested, and more work needs to be done there. With regards to the anatomy of the nervous system, I think still there is a lot of controversy with regards to the origin, termination, and function of various white matter tracts. We should do perhaps more efforts to try to parcellate the cerebral cortex and the different maps so far, but none of these maps is currently validated. In addition, the role of functional imaging needs to be investigated further. And although tremendous progress have been made, still we need to delineate further, similar to the anatomical difficulties, the origin and termination of the white matter tracts depicted by DTI. With regards to surgical techniques, it is important to try and preserve not only the function, but also the vessels around these important areas, particularly to avoid surgical morbidity in the form of ischemic stroke. And last but not least, part of my efforts is to develop personalized patient models. And as a result, we have created a number of teams, particularly at Queen Square, where we involve cognitive neuroscientists, functional imaging specialists, neuropsychologists, speech and language therapists, neurologists, try to understand better each patient individually and propose personalized mapping paradigms. However, today I'll be talking to you about fourth ventricular and brainstem tumors. And particularly, I would like to emphasize the importance of triggered MEPs rather than free-running MEPs. And I will show you an example from 2 or 3 cases. These are some of the cases we've done recently. This is from a patient in his teens, late teens, with a very large tumor going from the posterior third ventricle and pineal to the midbrain pons and down to the orbix with a pre-op and post-op scan. And also second patient with a tumor extending to the midbrain and thalamus. You can see there again pre and post-op scan. And I would just like to share some of my experience on how to best handle these tumors, because they appear to be quite challenging. This is from a paper in Press, will be published, I think, next month in Operative Neurosurgery, where it shows the complications in surgery around the fourth ventricle. And you can see the multiple cranial nerve pulses have been reported, particularly for the lower cranial nerves, 9, 10, 12, 7, 4, 6. And of course, that depends on the exact anatomical location of the tumor. Also, patients have a lot of noise and vomiting, hearing problems, dysphasia, and of course, the very few, fortunately, very few catastrophic complications, such as difficulty to breathe, difficulty to wake up, or severe weakness. So some of the principles of the monitoring, which I would like to focus today, includes free-running and triggered EMGs. With regards to the triggered EMG, which is the active monitoring, not just having a background run of ACPs or MEPs that people do very often, even in spine surgery, it's important to place a number of electrodes, particularly for the midbrain and pons. We place double lumen electrodes in the eye muscles. We go for the trochlear nerve, which is perhaps the most difficult to place electrodes, because the trochlear is very thin and also it's quite up and laterally, so it's quite difficult to hit. The oculomotor and also the abducens. These are the needles I like to place myself. I just push the eyeball laterally or medially according to where you want to go, and is mainly visual and tactile insertion of concentric electrodes. I found the double lumen thin needle electrodes from Minomeds particularly useful. I also place the needles in the soft palate, and for the cranial nerve 10, we place sensors on the endotracheal tube. The rest of the needles are placed by our neurophysiological team. For electrocorticography, we use corkscrew needle electrodes, and we're using the standard montage C3, CZ. With regards to transcranial MEPs, we use somatosensory evoked potentials, cortico-bulbar evoked potentials, and as I said, free running and triggers EMGs. For the cortico-bulbar MEPs, we like to use single 90 millisecond stimulus after a short train of stimuli. We apply short train of stimuli rather than single stimuli because the single one can elicit just peripheral responses. And this is because it can bypass the cortico-bulbar tract. Finally, with regards to intraoperative monitoring, we use for triggered EMGs, we use a concentric electrode to stimulate the same cranial nerve nuclei, and we have action potentials from the muscles they supply. For simulation settings, we use both high frequency and low frequency. For the low frequency, we normally go for 150 Hertz. For the high frequency, 1500 Hertz. For the pulse duration, this ranges between 0.2 to 2 milliamps. But when we start to stimulate the floor of the fourth ventricle, we typically start 0.5 and we very rarely exceed the 1.5 milliamps. It should be noted that this is not similar to the supratentorial stimulation, where when we test, for example, for motor testing, we can go up to 15 or 20 milliamps sometimes as an initial stimulation setting for the high frequency stimulation. So that's a little bit of theory. So let's go to surgery. And this is an example from a lady in her late 60s who presented with unsteadiness. And the scan showed this lesion, and you can see that there's this honeycomb appearance. And if you look closely, you can observe that it gives the impression that it goes into the medulla and the upper pons. Doesn't look like there's a clear plane. So I typically perform endoscopic Thalamic Callosum as a first step, and then a week later I perform the surgery. This is some of the monitoring we employ. And you can see that although we have multiple electrodes and multiple recordings, the overall surgical field is quite minimalistic and clutter-free. So all you can see here is the bipolar stimulation, this blue and white cable, and that's just bipolar and monopolar diathermy. So we try to keep everything as clean as possible. Although we do use navigation, as you saw the star earlier, this is an operation where navigation is pretty much useless. It's really impossible to see other extent of resection or exact position with a navigation, because here we're just talking about millimeters. So although I have to place the navigation system like we do for every surgery, I very rarely use it. It provides no assistance whatsoever. I normally like to perform a craniectomy, although craniotomy is perfectly reasonable. So the patient is placed down, I ligate the occipital sinus. The occipital sinus could vary from either a very small amount of blood within it to very, very severe, significant blood flow. Recently, I think 2 weeks ago, we had a young boy who had all his venous drainage through the occipital sinus. The transverse sinuses were hypoplastic. And our radiologist said to us that if we go through the midline and ligate the occipital sinus, he's going to end up with a massive venous stroke. So he had to go paramedian. But my point is that it's best to ligate the sinus, because sometimes the hemorrhage from the occipital sinus could be very, very severe. So this is a typical exposure, and it's very important to identify 4 key landmarks. The first one is the obex, and that applies for all posterior fossa tumor surgery, either fourth ventricle or brainstem. The picas, you can see here, the right pica on the sides, have to be identified, and usually there are multiple small perforators that go to the tumor or the surrounding brain. These perforators have to be identified, coagulated, and incised. The reason is that if they're just avulsed, they can cause thrombosis of the pica or can cause some small hemorrhages. So I always tend to diathermize those. So as you start this particular case, I like to assess the tumor first. In reality, you have to play with your tumor a little bit to see how it behaves. Very rarely these tumors are hemorrhagic, but they can be very firmly attached. So for this particular tumor, as I lift it up with a rotary microdissector, it looks like there's a nice place at the beginning. So at that stage, you feel like it's going to be an easy case. It's just going to be lifted up and separated. Bear in mind that all pressure I apply for all stages of resections are on the side of the tumor rather than on the sides of the upper cervical cord or medulla. So this is the stage of the operation where you just need to see which attachments are where, rather than try to jump in and debulk the tumor. So time spent to understand the tumor is time well spent. And sure enough, after we lift the tumor, we realize that it just fuses with the medulla. And we just try to identify if there's any more planes. And again, notice how I lift the tumor up, so the pressure I place on the medulla and the presumed location of the fourth ventricle is very, very little. So at this stage, I shift my attention at the superior parts because we need to start debulking the tumor. It's quite hard. I don't try this stage to develop the plane between the floor of the fourth ventricle and the tumor, because the bulk is so big that it will be impossible. I like to do what's called a tilovelar approach. The tilovelar membrane is a double pier membrane that very nicely pack the vermis with the cerebellar tonsils. Once you release these two membranes bilaterally, the cerebellum is in reality, the bottom of the cerebellum is in reality unboxed and released very nicely. I don't like to go through the vermis because even if you go through the inferior vermis, I find it quite destructive by principle lesion. The limb ataxia patients have often resolves with lower vermis approaches. For the upper vermis division, which we need to avoid as much as we can, patients develop truncal ataxia, which is quite more persistent. But I believe it's useful to try and avoid both limb and truncal ataxia by using a tilovelar approach rather than transvermian approach. Then once some of the tumor is removed, I employ ultrasonic aspirator. We're now a little bit deeper towards the floor of the fourth, but not as close as to develop an interface and start mapping. So before it starts to map, we need to remove more tumor. It's important to have a mental image of the floor of the fourth. And it's important to remember that it starts from superficial level when you go from the orbix, then it goes right down to the middle of the rhomboid fossa, and then goes right up. So if the surgeon doesn't have this mental image in his or her mind and just go right down to follow the tumor, it's likely to end up within the floor of the fourth. So we identify the first landmark. I mentioned I have 4 anatomical landmarks in my head. The first is the orbix that we saw. The second is the right foramen of Luschka that you can see here. So the patient's face is down. This is right foramen of Luschka. We saw the orbix a little bit there. In these tumor cases, you don't often see choroid plexus through the foramen of Luschka. And then we need to move towards the left-hand side and identify the left foramen of Luschka, which is just at the bottom of the screen. You can see some of the floor of the fourth has been exposed. So this is now the left foramen of Luschka, right foramen of Luschka. I'm starting on the left-hand side of the patient. So this rhomboid shape is slightly tilted by way of positioning. And now I have identified 3 of my 4 landmarks. Now you can see some of the floor of the fourth started to become visible. And all this area is still tumor. So at this stage, my dissection is purely anatomical. I have not used any triggered EMG, although in the background we have been the free running EMGs providing feedback, both the corticobulbar and the corticospinal ones. Oftentimes the neurophysiologist will give us a warning whether there is a irritation of one of the nerves. And now where is the stage where I perform a triggered EMG. So this is active stimulation. This is not just passive free running. I'm using these concentric electrodes, and although it looks like it's a monopolar stimulation, in reality this is bipolar. So one circle stimulates and the outer circle records of our stimulation settings. To be able to do stimulation settings, you have to have a clear idea, or at least an approximate idea, of what you're actually stimulating. So right and left, and you need to know if you're close to the facial nerve or the 6th nerve. For example, I do say to my physiologist, now I'm likely to be on the right 6 or on the right 7 and look for responses. We're now reaching the 4th landmark. We're reaching at the aqueduct, and this is the top of the rhomboid fossa. And this is, as I said, how you understand why using neuronavigation is completely pointless in these situations, because we are dealing with millimeters and very sensitive areas of the brain, and navigation is very, very unlikely to provide any useful information. An additional point I would like to make is that although I do routinely third ventriculostomies, more recently I realized that the blood that sometimes goes through the aqueduct can be easily aspirated by using a suction. So more and more often now, we just put the suction into the aqueduct at the end of the surgery, and this can aspirate all the blood remnants and small clots that have escaped during surgery. And I found this very, very simple and very efficient. So now that we have resected the vast majority of tumor, you can see a little bit better the anatomy. And as I said, these are the four landmarks, the four anatomical landmarks: the obex inferiorly, aqueduct superiorly, and the two foramina ophlusca laterally. Now, this is the median sulcus, this is the stria medullaris, and you have the facial colliculus and the genu of the sixth cranial nerve. As you have noticed, these are landmarks which are mentally imagined. This is very, very different than a cavernoma surgery where all this area is completely shiny and clean, and you can see the stria medullaris, and you can see the protuberance of the facial colliculus, and you can see sometimes even the vagal and hypoglossal trigones. For tumor surgery, you have to forget all this. You're not going to see anything. Everything is infiltrated, distorted, and invaded. So that's why the image of anatomy and the image of mapping, triggered mapping, targeted mapping, is very important. The reason that this is important is that every time you stimulate, you do it by cycles. So you stimulate, you resect a layer, you stimulate, you resect a layer. If during stimulation you have very high responses, then you have to stop there. That means you might have gone too far, and you might need to move to a different area and then come back after 5 or 10 minutes. So in one hand, you use the stimulation, the stimulator. In the other hand, you use either suction or ultrasonic aspirator. And we have found this technique very, very sensitive. As you know, the fourth ventricle and the dorsal midbrain or pons or medulla are very unforgiving, particularly the medulla. And the many reports of patients not being able to wake up or being extubated, even by rattling it, by putting a little bit of pressure, can cause a lot of problems. This is examples of the nucleus ambiguus and the vagal and hypoglossal trigones. As a mnemonic, bear in mind that the vagus is going to be more medially and inferiorly. So touching this area, I would say to my physiologist, this is likely now to be the vagal nerve on the right, or the hypoglossal on the left. And as you can see, as long as we get normal responses, particularly with the triggered EMGs, we continue to resect the lesion. The ultrasonic aspirator oftentimes can cause artificial responses. And this is how it looks like in the end. And again, all these are the nuclei that are superimposed mentally. This is from a paper that will be available next month from some of our work. And then this is the final inspection. And this is a tumor where was infiltrating the floor of the fourth and we were able to remove completely with no neurological deficits. And this is a typical paradigm of how we approach these tumors. And this is the post-op MRI scan that shows that there has been complete resection. And I'm just going to spend a few more minutes describing another case. This is a patient I showed at the beginning of the presentation, a patient in his late teens. And that's a second patient who I believe was 16 with similar tumors. We did both of these cases in a sitting position. The previous one you saw was a prone position. This one, both of these were done in the sitting position, the supracerebellar infratentorial approach. And this is the case I mentioned to you that there was a very significant big occipital sinus, so he could not go through midline, so he went paramedian. And for this particular case, we're pretty much at the end of the surgery. It took about 8.5 hours. And as we remove the tumor, there were some small remnants we would like to test. And this is some beautiful anatomy. So this is the point where the tumor has been removed, almost. We're looking at the pineal region. We're looking at the splenium of the corpus callosum, the thalami on either side. This is superior colliculus, inferior colliculus. This is the posterior part of the third ventricle, and this is the tila choroidea. And it should be emphasized that the tila choroidea actually seals off the back of the third ventricle. Some large tumors can infiltrate the third ventricle, and when you remove the tumor, you go right through the third ventricle. But normally this will be sealed off. And this is one of these cases. So this is tila choroidea. The line, the midline is on this location, is oblique because you're looking laterally. And for this particular case, we placed electrodes, needle electrodes into the 3, 4, and 6 cranial nerves bilaterally. And we're just stimulating to see whether these are intact. And now stimulating the superior colliculus on the left, and we went up to 10 to 12 milliamps. And we were able to get responses on both sides, which was very reassuring. Our experience showed that with low settings, we could not get the response. And you can understand this better if you look at a cross-section of anatomy of the brainstem. So if you go for the cranial nerve nucleus of 6 or 7, that are entirely immediately underneath the ependyma, they're literally 1 or 2 millimeters below. But if you look at the cranial nerve 3, 4, and 6, and the midbrain and upper pons, they're approximately 1 to 1.5 centimeters deeper than the ependyma. Hence, the need to use higher stimulation settings. So at the end of this, we were able to very clearly demonstrate that we were getting good responses. And the patient, I think we did this case 2.5 weeks ago, and the patient did extremely well. There were no neurological deficits after resection of a very extensive tumor. And this was one of the rare panoramic views of the dorsal brainstem and splenium, thalamus, thalami, etc. So I think I'll better stop here. I would like to thank my team, a big team of people helping some of these complex operations, anesthetists, speech and language therapists, neurophysiologists, and my research team. And if you want to get in touch, this is my email, g.samanduras@nhs.net. So thank you again for the invitation.
Thanks a lot, dear Professor, for this excellent presentation. Is there any question from panelists? Thank you, sir, for this amazing.
Thank you very much.
If there is any question, please type it in the chat box. And now we will shift to next speaker, Professor Sanjeeva. Please start sharing your screen. Thanks, our dear friend.
Samir, thank you very much. And thank you as always for this kind invitation. I'm always very impressed with the excellent speakers, excellent lineup. I look forward to catching up with some of the videos I missed later on the recording. And thank you for this invitation. Always a pleasure to speak here. I really enjoyed George's talk just now that I just caught. So I'm a skull-based surgeon at Oxford, and I want to talk about an approach that I think is very helpful, very useful approach that involves sort of understanding the temporal bone and using that to access tumors deep within the skull base, in this so-called transpetrous, transcentorial approach, where you're drilling through the petrous bone and cutting through the tentorium. I use this approach a lot. I heavily favor it. I like it mainly for anything that's anterolateral to the brainstem, so definitely for petroclival meningiomas. Certainly for large petroclival meningiomas, I favor this approach. It can be used for chordomas, chondrosarcomas. I have used it for epidermoids. Not really for schwannomas, but it's something you can bear in mind. And you can, of course, tailor versions of this for certain aneurysms or cavernomas, although my practice is heavily based on tumors. And these are some cases you could consider it for. I've used it for some of these cases. Certainly this picture here, the bottom and the middle, this I get a lot of redo cases. So this had previously been operated on. And this is a petroclival meningioma, and you can see the cysts forming within the brainstem. The plane is going to be very poor on the brainstem. And so certainly a case like this, I would favor it.
Excuse me, we're not seeing your PowerPoint.
Oh dear, have I been talking all this time without sharing my screen?
No, that's okay. Okay.
That was very silly.
No, that's okay.
I apologize.
No, that's okay.
Thank you, George. Thank you very much. So I won't go through it again, but yeah, I'm based at Oxford, and these are the indications I just talked about. And these are some tumors that I would use it. Thank you very much, John. It would have been a very boring talk without the slides. So these are some of the indications I would use it for. So bottom picture here, difficult petroclival tumor, PL invasion on the brainstem is going to be very challenging. And I think the access you get with this approach is very useful. The top two pictures are from the same patient. This is something you could do via retrosigmoid. Certainly, a lot of people would. The sort of lateral petrous. Retrosigmoid is excellent for it, but these sort of approaches are also useful if you don't favor the retrosigmoid. Bottom left actually is a hypervascular vestibular schwannoma that I resected via retrosigmoid approach, but again, obviously some people will consider translabyrinthine approach and adding the cutting of the centurium will open windows up for you. But that I did via retrosig. And this one at the top here, you could certainly go endoscopic as a chordoma involving both cavernous sinuses coming onto the brain stem, both carotids and basilar are all involved. Endoscopic is an approach, but if you wanted a lateral approach or a combination, that's also a potential. But skull-base surgeons, we're very, very focused on approaches. But I think, as I'll talk a little bit here, I think tumor biology is the most important thing. And for some of these malignant chordomas, for example, despite very aggressive resections, sadly, you can end up in a lot of trouble with them. And as I'll talk again about how these tumors can involve the PIA, the vascularity, that sort of thing, I think you have to understand that sometimes, particularly in very tough tumors, I think sometimes no matter what your approach, it can be very, very challenging. You can't always get as complete a resection as you would like. But approach selection is the queen. I think, it's key. And for me, I really favor, particularly for petroclival meningiomas, these aggressive approaches to tackle these tumors. And then the things like arachnoidal dissection, all that, which we heavily favor in skull-base surgery, there further down the line. And you have to understand, no matter how good you are at these sort of technical maneuvers, in the long term, it's really tumor biology that really matters, number one. And then, getting the right approach that allow you to go and use these maneuvers. Okay, so that's my sort of view on tumor surgery anywhere. Here we're going to talk about going through the petrous bone. So before I get into, what I think are some of the considerations preoperatively, I just want to really explain what this approach is so you have an understanding when I'm talking about the preoperative considerations. So this approach involves doing a middle fossa craniotomy, a retrosigmoid craniotomy, and then some version of a pre-sigmoid drilling. Usually I combine that with an anterior petrosectomy and cutting the tentorium. Okay, so it's to do this what I call a transgenderal transpetrous approach, you must do these 5 steps. All 5 steps are key to giving you that exposure. And the pre-sigmoid approach varies depending on the pathology. If they have good hearing, then as we're showing in this picture here, so just to orientate you, we're on the left-hand side. This is middle fossa that I'm pointing to there. At the bottom of the picture, you can see the sigmoid sinus and the retrosigmoid area behind it. And obviously this is the labyrinth, the ossicles there. And here, as the labyrinth is intact, this is a roton picture. This is a retro, so you've drilled the retrofacial air cells. This is a retrolabyrinthine approach. If you take the labyrinth and they lose hearing, that's translabyrinthine. As I'll show, if you want to access the ascending carotid, then you drill out the cochlea, transotic approach. And so these are the various pre-sigmoid bits you can do. The retrosigmoid craniotomy is key. The middle fossa craniotomy is key. I find the anterior retrosectomy key. I'll talk about that in a minute. And then cutting the tentorium to really pull the sigmoid backwards, I think is very important. So this is the approach that I'm discussing, and now I'm going to talk about some of the considerations in that approach, and I'll show some videos on that. And these are all sort of technical steps within it, which as I said, this is the princess that I was, the analogy I used earlier. And these steps are important as part of that. So the retromastoid drilling is really important because it allows you to cut the suprapetrosal sinus, and you can put a stitch in that and really pull the sigmoid sinus backwards. That's an important step to open up that window. Drilling around the jugular bulb, above the jugular bulb, actually medial to the jugular bulb, is really important because this big disadvantage of this approach is your view down towards the lower cranial nerves. It's not as good as a retrosigmoid approach. And then I think, usually a lot of these tumors are coming quite high. So the petrosectomy and opening Meckel's cave is very important. It's cutting the tentorium. And of course, we cannot then forget, once we're in there, our standard skull-based technique, we're always doing an arachnoidal dissection. Okay, so what do I think are the main advantages of this approach? I think that the big thing here from cutting the tentorium is you get this hugely expanded corridor around the 5th cranial nerve. Okay, so around the trigeminal nerve, you get massively expanded corridor. You get this very nice superior angle working downwards, almost sort of parallel to the brainstem. And that is really the big plus point of this. And as I'll show in the video, really big, really nice working angles on either side of the trigeminal nerve. Like any pre-sigmoid approach compared to retrosig, you're coming further forward, so you pick up the cranial nerves early. These cases are still difficult. You can see here, this tumor is medial to 5, it's medial to 7 and 8. You're still not going to have to work between cranial nerves. There's no getting around that in anterolateral lesions on the brain stem. The basilar is usually out of your way till the very end. It's a nice landmark that, once you sort of see most of the basilar, you've got it all out. And it avoids, particularly in the dominant hemisphere, any issues with Sylvan fissure splitting. Sylvan fissure splitting, of course, is an extremely important skill. But, for various reasons, you may not favor that, particularly in long operations. So it avoids all of that. But again, it's a matter of personal preference. Now, these big operations I usually do with my ENT colleagues who are excellent in the sort of drilling of the posterior petrosectomy. A very good ENT team here at Oxford, so we're very lucky. But these are sort of things that we go through with our neuroradiologists when we're doing this. So full vascular and MR imaging obviously is key. And like any meningioma operation, it's the venous anatomy you really want to understand. Arterial anatomy, of course, is important. But where do people run into trouble? And that's taking veins and things they shouldn't do in meningiomas. Obviously, on the dominant side, you will see the vein of Labe, and you want to protect that during this approach. There has to be some understanding of the dominant sinuses and the venous outflow there, because they're going to be exposed for long periods of time during this operation. There's a risk of injury to them during the approach, and how you protect them during the operation. The jugular bulbs, and particularly a high jugular bulb, is going to affect your view. And I talked about how the drilling can help with that, but sometimes anatomically it can be a real problem. Obviously, you have to understand all the draining veins, the normal structures, and how you protect them. CT is extremely helpful. I've already discussed how hearing plays a role. If you have a very pneumatized petrous bone, then of course the drilling is quicker and it's easier. If there's tumor and bony invasion, I'll show one scan of that. then you'll remove a lot of tumor on your way in, and protecting critical structures like the sinuses, the facial nerve, I think are important in this procedure. Now, for most tumors, particularly tuberculin, meningiomas, things like that, my expectation is I'm going to make patients better. So the vision is going to be better. Careful technique in removing the tumor, opening the optic canals, whether you do that open or endoscopically, you're expecting the vision to improve, particularly if you get to them quickly. But this is the one location, these petroclimas things, where I think this is not true. So I do not expect patients to be better after the operation. What I tell them is that they're going to be the same. I'm going to prevent them from getting worse, but they're going to be the same. I'm not going to say that they matter. So here, the preoperative clinical condition really matters. Like this is the same scan I showed axial earlier, same patient, where the cyst is in the brainstem and it's PL invasion. This is not good. This is, you compare that to a chondrosarcoma here on the right, mainly an extradural tumor. Here you're going to get a very good outcome. The patient on the right, you're going to get good resection. Patient on the left, as I said, tumor biology is king. So this, I think the preoperative counseling in these patients is really important. I think it predicts their postoperative outcomes, what you see on the scans. And here I'm very, very clear with them, unlike other locations in the brain, that I am not expecting to make them better. I think understanding that about this location is really important, how you counsel patients preoperatively. And then there are things that some things I don't think matter as much. I don't think the size matters. I do think the other things matter, but size, for example, I don't think matters. I think if you have a soft tumor that's very large, you can make rapid progress. That's why the chordomas, chondrosarcomas are nice to do, and you can take a lot of tumor out well compared to a tough meningioma invading the brain. So the plane definitely matters. Poor plane, or I'll show a video of a recurrent epidermal, although we got a very good resection. It's tough. Redo surgery is difficult. Poor plane is challenging. Size in itself doesn't matter. Tumor consistency definitely matters here. I think you can get tough tumors out, but it is a very different operation to soft tumors in this location. Again, this is very different to, let's say, the anterior fossa and middle fossa, where actually that tumor consistency, modern ultrasonic aspirators doesn't matter. Here it does matter. You're working at depth between cranial nerves, right on the brainstem. That tumor consistency really can change how you feel during the operation, how long it takes, and how tired you get and things. So here, I think it does matter. I don't think it matters in other locations, but here it does. Vascularity is always a factor. We do a lot of vascular tumors. It's not a problem, but again, dealing with that consistent vascularity in this location is challenging, but with a good understanding preoperatively can be managed. This bottom picture here is a very extremely vascular tumor that was removed in this location. Of course, it's not the only way to do it. There are some other surgeons like myself a favorite, but lots of people will do it different ways. Okay, so I'm suggesting this combined supra-infratentorial essentially is what I'm suggesting. But equally, for a lot of these tumors, you'll see very good surgeons go retrosigmoid and take a lot of these tumors out. They do it very nicely. For the smaller ones, some people will just do a pure Kawase. For me, as long as it's at the level above the IAM, that's fine. Anything lower, I think it's very difficult. A lot of people favor OZs, charionals, pretemporal approaches, splitting with fissure, lots of different ways, cutting the tentorium from above to get low. For me, I think there is a limit to how low you can get. Some people do very aggressive drilling at the petrous apex and go quite low. I personally don't favor that. I like this posterior petrous approach. A lot of tumors, particularly they start to get below the level of the IAM. And of course, for these soft tumors like chordomas, chondrosarcomas, nowadays going endoscopically is a very reasonable way to do it. And that's certainly one option. So this is a slide I use for the residents, just when I'm trying to explain how I think about the various approaches. So again, a rotund picture looking from the back. The brainstem's been removed. We just got the blood vessels and the cranial nerves. So retrosigmoid, it's the workhorse approach, it's the king, or queen, I should say, of approaches. And you see, from the tentorium all the way to foramen magnum very easily. So definitely a real workhorse approach. We'll be doing at least one retrosigmoid every week. Excellent approach. Kawase, probably use it the least out of all of these. but nice for small tumors. A lot of the small tumors here get SRS. We're not doing a lot of small tumors, but nice for small tumors at the petrous apex. Far lateral, of course, different pathologies for him, magnum really, but extremely helpful. And then there's this approach, but actually, I've got to pull this box back a little bit. It's hard to see this low with the transdentural. This box should be slightly higher. What you get is a beautiful view going up, but the one weakness of this approach is you start to look lower down, it is not as good. But it does take you beautifully round compared to a retrosigmoid, beautifully round the petrous bone to give you a much better view, much more anterior view of the pathology and the cranial nerves. Okay, so let's get into it a little bit more, starting with the anterior petrosectomy. I put this slide in, I mean, this is more really when I talk about the cavernous sinus, but you have to understand not just the horizontal carotid, but actually the whole, the ascending and horizontal carotid, but actually the whole carotid anatomy, the paraclavial carotid, and what happens in the cavernous sinus. Because without understanding the cavernous sinus, you can't really do, in my view, a petrosectomy and anterior petrosectomy, because one of the first steps is splitting around V3 to get some space, for me anyway. I think everyone understands, this Cavazio anterior petrosectomy well. You understand its approach from the middle fossa into the posterior fossa. The key landmarks are here. It's V3, the trigeminal nerve, and it's the third branch there. The carotid and GSPN, the IAM. Probably, if you've come to the IAM, you've gone a bit too far. Of course, the cochlea. It's important to understand and protect, in my view. And you're drilling in between. And then you can open the suprapetrosal sinus and the middle fossa and posterior fossa dura to get you into this, into the CP angle. But I think the other thing that's really important to sort of understand here is dealing with bleeding from the sinuses. I think that's important, but also how low you can get. And I understand there are some technically excellent surgeons out there who go much lower than I am, but for me, I don't favor that. I would then combine it with a posterior petrosectomy. And of course, nowadays you can, in individual patients, you can model this anatomy. There's pictures on the right for a particular patient. You can build 3D models. We used to build physical models. Now, of course, we do it all virtually, and really plan the anatomy very, very clearly before you go in there. So this is a relatively straightforward tumor. Just as an example, this is just a pure, extradural petrosectomy. It's a very, very straightforward case. This is a chondrosarcoma within the cavernous sinus and going back into the petrous apex. And of course, the thing to remember when you look at this bottom left picture that I'm pointing to is you have to remember the other two pictures that show all these other pictures here. The picture on the left without scans is a lateral view. The bottom one on the far right is an anterior view. And you have to understand these tumors completely wrap around the carotid, which is fine. These are soft tumors, they're actually very straightforward to do, but only if you understand the anatomy. If you don't understand the anatomy, then the whole thing becomes very challenging. But you must understand how it wraps around the carotid, how you're going to work on either sides of the carotid, where you're going to drill. Just in the interest of time, I won't show the whole video, but this is obviously we're on the right-hand side, we're down in the middle fossa. The first thing you'll get to is middle meningeal, which you're going to take. So we're working down, we're getting to middle meningeal. There's usually some bleeding from it. I've coagulated, I'm skipping forward in the video, I've coagulated middle meningeal. I'm cutting through middle meningeal, and then we're going to separate at V3 just to get a bit of space in the petrous apex. I'll skip forward here. We're opening into the cavernous, just opening into the cavernous sinus there, and exposing the bone of the petrous apex. These tumors would have done a bit of the work for you, so you can get a. I'll skip forward. You can get an idea. I'm just going into the tumor. Obviously, more bone needs to be drilled away. There's not enough of a view, but this is the sort of soft tumor there, and you can see the sort of pieces of it coming out. And because you're extradural, actually the whole thing is very straightforward. Not that going intradural is that much more difficult, but it is nice to be extradural. So tumor coming out, all this tumor coming out, we're going to expose the horizontal carotid in a minute. All this bone has to come. So you can see it's very, very easy to sort of gently dissect tumor out. We're working just behind V3 here, the petrous apex. Yep, so all of this bone. No, you know, obviously you protect the hearing, you protect the cochlea and the IAM. And I'm going to skip forward. Yeah, so that's a nice view of the carotid here. Okay, so V3 carotid, P2 apex, you got posterior fossa dura. You know, you can expose middle fossa dura. Tumor on either side of the carotid has all been removed, and you get a very nice resection on either side of the horizontal carotid. Very straightforward to do. Just take away as much bone as I need to take away. I'll just show you the postoperative scan, so you can see you can remove the entire tumor. Yeah, the whole thing is you get a macroscopic resection of the whole thing. Very straightforward to do just by understanding that anatomy. Okay, so then what we really want to talk about is the lateral features and how you combine those two approaches. So this anatomy is really important to understand, and I'm very lucky because I have excellent ENT surgeons that I work with who do a lot of this drilling, either retro lab, trans lab, transotic. There are, of course, neurosurgeons who do that themselves as well. So you can do it either way. But the anatomy to really understand is this pre-sigmoid anatomy. Okay, so transverse on the left-hand side, transverse sinus here, labe coming in, sigmoid coming down to jugular bulb. You can see how coming forward takes you dramatically in front of the cerebellum. You see the Dandy's veins going up to the tentorium. Tentorium has been incised, and you get this amazing view. You can see fourth nerve coming to the tentorium, SCA. You get this amazing view above and below. But to do that, you have to understand the labyrinth, and really importantly, you have to understand the descending facial nerve going down the stylomastoid foramen here. Okay, and that's the anatomy you really have to understand in this approach. When you can take the labyrinth, when you would come retro labyrinth, but it's about opening up this space in front of the sigmoid. As neurosurgeons, we're very, very familiar with the retro sigmoid approach, of course, our workhorse approach. But you can see how this pre-sigmoid approach, beautifully shown in this Roton picture, brings you much further forward in the view of the cranial nerves you get from that. This is just an operative picture about that picture I took from one of the skull-based books showing retrosig. What I favor is translab or retrolab approaches. Transcochlear, nobody uses now. Although we do drill the cochlea, we call it transotic. Transcochlear strictly is about how the facial nerve is transposed, and obviously that gives you facial palsy. We consider that unacceptable now. Right, so you're going to watch a video of this approach. I'll just talk you through the anatomy before we get to the video. Left side again, middle fossa here, sigmoid sinus. This is the pre-sigmoid area we're talking about. Retrosigmoid here. This is the descending facial nerve going to stylomastoid foramen. You've got the three parts, semicircular canals of the labyrinth here. Retrofacial air cells in blue. You'll always take the retrofacial air cells, external ear canals there. Retrofacial air cells will always go. That's the sort of retrolab bit. Okay, can go, I think in this case we go translabyrinthine, and I think we even drill transotic here. Before we get onto the video, I'll just show another case that, once you get used to these approaches, actually tumors that sometimes may look complex and become very, very straightforward. So this is not where we're going deep inside. It's a very lateral tumor, but it's an easy tumor to get wrong because you can see there's a lot of tumor. This is a recurrent meningioma, it operated somewhere else quite a while ago, then came to us. And you can see the descending facial, this tumor is involving the descending facial nerve and heading towards the facial nerve there. Soft tissue components, this tumor within the sinuses. This is a case that's, although it's straightforward, it's easy to get wrong. So really understanding this petrous anatomy is useful not just for anterolateral to the brainstem, but even for more straightforward lateral cases like this. And here again, complete resection. We opened into the sinus, or I opened into the sinuses and removed all of the tumor. This is the fat packing afterwards. We skeletonized the descending facial nerve, my ENT team. Again, we're very, very good. Right down into the condyle, right where the vertebral artery, all of that tumor removed. Hearing's intact, facial nerves intact, and even tumor within the sinuses all removed. So this is more straightforward, but it's the same anatomy. All right, this is the position. This is the incision I favor going all the way around. Lateral position, I like to rotate the table depending on how it goes. Okay, so this is the anatomy we talked about earlier. Just a reminder again, this is descending facial that's been skeletonized. And once you've drilled in the video, you'll see that's the labyrinth there, middle fossa with fourth nerve coming to tent, sigmoid sinus, pre-sigmoid dura. We're going to cut the superior petrosal sinus and the tentorium as part of the approach. Okay. And the big advantage of that is an intraoperative video, is the trigeminal nerve. I just put this picture here just to show the massive view you get above 5. You're saying below 5, but you can go really high in these tumors. This picture is really important because it shows the big corridor you get between these big yellow nerve. Here's the trigeminal nerve. You can open into Meckel's cave. You got 7, 8, and 6 there. But what the other important thing it highlights is your view at 9, 10 and lower down is poor. Okay, and it's the retrosigmoid bit that really gives you that view, not this approach. That's important to understand. All right. So this is the video I've been talking about. Okay, so we looked at this picture a few times now. I think you understand the anatomy. This is a descending facial here. This is a slightly more complicated case where we wanted to get to tumor at the ascending carotid. So that brief bit there was the transaortic part. Now we're back into the labyrinth. And we're going to drill through the labyrinth there. Okay, I'll just pause this briefly here. Some of you who do translabyrinthine approaches will understand this anatomy. You got the IAM here. Okay, middle fossa floor, facial nerve going up there, turning, coming around. And then the second genital coming downwards here for descending facial to a stylomastoid foramen. Pre-sigmoid dura, retrofacial and labyrinth all gone. Middle fossa, sigmoid, retrosigmoid. That's important to understand. We're now going to, and transaortic drilling. Sorry about the change in color. Used a different scope for the anterior putresectomy. I've already talked about that. So I'm going to skip that. That's the anterior putresectomy. Okay, so now we're opening the dura. Okay, so we're going to open posterior fossa dura. We're going to open middle fossa dura. And then the important thing there is we're going to start cutting the tentorium and really pulling the tentorium posteriorly. A lot of people use clips and things for the superior petrosal sinus. I actually find coagulating it fine, but you can use a stitch. You can coagulate like I did. I find the coagulation helpful because you actually need to remove quite a bit of the tentorium. Sometimes you have to cut quite a bit of the tentorium, physically cut a large part of the tentorium out to really give you that window. Okay, so I'm cutting the tentorium. We've got cerebellum here, superior cerebellar artery, trigeminal nerve. I'm cutting the tentorium and I'm going to come pretty anterior around the brain stem here. I think in the interest of time, I'm just going to skip forward. That's just the final cuts in the tentorium. Okay, lovely view. This is trigeminal nerve here. You can see this massive corridor on either side of the trigeminal nerve. We're very far forward, and this is, of course, the arachnoidal dissection. You can see the nice planes in this tumor. That's tumor there. That's brainstem there, and you just don't get this view with the retrosigmoid. Look at how high I'm looking, how much above the trigeminal nerve I'm looking. Now I'm looking below it. Huge corridor, beautiful corridor, nice planes. Tumors just being peeled off. It's just internal. Obviously, debulking is really important. That's trigeminal nerve there, and the tumor just being worked off the brainstem. Standard sort of arachnoidal dissection technique. I'll skip forward just to show the really, really good view you get looking higher up. So tumor coming out, massive corridors again. We're now above 5 again. Really large corridors for removing tumor. Not so good lower down. That's 9, 10 there. As you can see, your view is not as good going down. Going to skip forward. Yeah, so going above 5 now. And just to show you, obviously, tumor's pretty much all gone there. Fourth nerve. I'm just going to go forward. Yeah, that's it. So you can see up to PCA and basal vein. So you can look really high up with this. I've got to the third ventricle or lateral to the third ventricle. So fantastic corridors above and below. I won't show the video here, but this is just a recurrent epidermoid. So again, I've been operated previously. You see all of the vessels are involved. Vessels going to the thalamus were all involved. And particularly in a redo, I actually find this extended approach is quite helpful. I just want to point that you can see the extensive bony drilling we did. But I just want to show this scan is the immediate postoperative scan. And you see, he got right up to the third ventricle with this approach. Okay, well, I think I'm really come to the end of my time. I just also want to say that sometimes if you wanted, you could do this purely endoscopy, but you can combine this with the endoscopic approach. I like doing that for some tumors. It's just a nice example where you get really good resections, combining lateral and endoscopic approaches. So in summary, I think, it's something to have in your armamentarium. Very, very useful for some of these anterolateral tumors.
Excuse me, Sanjeeva, we have lots of time. Take your time.
Oh, okay.
Take your time.
Oh, okay. Sorry.
This is good. This is good.
Oh, sorry. Well, I've already I've given the game away with some of these videos, but
no, that's okay. We got lots of time.
No, well, don't worry. I've gone for half an hour, so I'll take questions then on this. And thank you for this invitation. You're very welcome to come see what we do at Oxford. There's some interesting operations, but also the city, as you can see, is very, very beautiful. So you're always welcome to come and visit us. Sorry, I was timing myself, and I'm at half an hour. So
okay.
Are there any questions by any of that?
Thank you, brother, for this excellent presentation. Is there any question?
See here. You see any, Sam?
No, it was clear enough.
Well, no, thank you again. I always enjoy coming. It's very nice to see you, Samir, and you, John. So thank you for this very kind invitation.
Thank you for coming.
Thank you. And now we will shift to next speaker, Professor Carlos Castello. Please start sharing your screen.
Hi, it's a pleasure for me. I am grateful for the invitation. And I'm going to introduce by myself. I am Dr. Carlos Castillo from Mexico. I am professor of the Hospital 1 de Octubre and chairman of the Clínica de Neurotraumatología, and I am from the Colegio Nacional de Neurocirugía in Mexico. So the question for many neurosurgeons, including Mexico, is some gliomas are unresectable. So, and we are going to talk about the advantage of using neuronavigation and single port for total resection of the gliomas. Okay, the concept about inoperable gliomas can be considered paradox, because many of the tumors traditionally deemed to be inoperable can, in fact, be safely resected. So the inoperable brain tumor concept is in relation with the concept of eloquent brain areas. And eloquent brain areas are defined as essential areas for carrying out basic neurological function. But if it is injured, result in significant neurological deficit can be. However, this idea is not quite congruent with current concept in neuroanatomy and functional networks in the brain at this time. So this is an example. Only we are going to back in areas no eloquent. And after all this concept, there are at the time one concept called connectome. What is connectome? Who's called connectome? So connectome is an entire set of the connection of the brain. Refers to the large-scale connection between section of the cortex and possibly the subcortical structures. So after all these concepts, allowed transition to more free concept of maximal safe resection. For example, in this case, in glioma bifrontal in the corpus callosum is traditionally considered non resectable, unresectable. So, but now with if you combine microanatomy and all this kind of concept of minimally invasive parafascicular surgery correlate with functional MRI, you can go to do the resection of this kind of gliomas. So what is the best way to go this resection of this kind of gliomas? Is combine image techniques as functional MRI, combined with microanatomy, neuronavigation, neuroendoport, and transoperative neurophysiological brain monitoring. So what is the advantage in use, for example, neuroendoport in the surgery? So you can do a smaller incision in the skin, you can do a smaller craniotomy, a smaller incision in the dura, and introduced by a small corticotomy and intersurgical slowly and gentle into the brain until you reach the lesion, guided by stereotactic or neuronavigation systems. After the tumor is resected, we remove the neuroendoport and brain tissue returns to the original position. There are many kinds of neuroendoport, but all this is the same function. And we can go for the pathways, you know, about the large fibers. And if we combine neuronavigation in my guided surgery, allows to navigate through the brain in order to create a preparative plan for the surgery, allows to do a smaller craniotomy, and allows to localize the borders or limits of the tumor and correlate the surgical anatomy with the image of the navigation. So all neurosurgeons know how the neuronavigator, an indication for this is deep brain lesions, posterior fossa lesions, interventricular lesions. And this is all the pathways, example of all pathways you can go through the brain to get some lesions. So for us in Mexico, the question is how easy it is to do in Mexico, because in many places of the world, you can do for the resources. But in Mexico, there are a few medical centers with all these technologies. Maybe 30% of the surgeons have access to all this technology in Mexico. And the rest don't have, sometimes MIDAS, for example. If the people don't have medical insurance, it's too difficult to get this technology in every medical center in Mexico. So, but fortunately, we have this technology in some centers like the clinical, the neurotraumatología and the Hospital 1 de Octubre, and we can do this case, this kind of case. The next case describes how we combine this technology in clinical neurotraumatology in Mexico City. So the first case is a 60 years old, right-handed woman who presents headaches, nausea, vomiting, paraparesis, and frontal disorders. The MRI shows glioma that spread along the white matter tracts of the corpus callosum to both hemispheres, butterfly glioma. This is the MRI that shows how the glioma surrounded bilateral bifrontal spread and cross over the corpus callosum. So for this patient, the option for treatment of this is one, biopsy, maybe for stereotactic, maybe for neuronavigation. The second option is craniotomy for unilateral transcortical or interhemispheric approach. The third option is endoscopic assisted transcortical or interhemispheric approach, and biportal approach assisted by endoneuroport with two small craniotomy. We use the last option, biportal approach assisted by endoneuroport. So what is the rationale for procedures? Use neuronavigation, use neurophysiology monitorization with cortical stimulation and motor evoke potentials. Use a neuroendoport for the resection, ultrasonic aspirator, and surgical microscope. The objective of this procedure is histopathological diagnosis, maximize extension of the safe resection, and improve survival. So we see the benefits and the risk. Obviously, risk is paraparesis, motor deficit of the patient after surgery. The position for this patient was supine position with neutral head. We did bicoronal incision. This is the patient. After the flap, we go to do the two small craniotomy frontal, localized with neuronavigation, the better way to access the tumor, realize a small corticotomy and introduce the neural report guided by neuronavigator, and at the same time use the microscope to see the deep tissues to distinguish tumor from healthy brain. This is a patient with two small craniotomy, open the dura, and at the beginning of the procedure, you need to put the pointer to see what is the best way and go by a small corticotomy. This is the example. We go into the intersurgical approach, confirm the trajectory by axial, coronal, and sagittal view. You see how we guided the image to get the tumor. This is all this technology we use, how the pointer is in this moment into the tumor. After we introduce the neural port into the tumor, so you can begin to use the ultrasonic aspirator. So you see by microscope how the tumor is into the endoport. After you see the borders of the tumor, and constantly verifying with neurophysiological stimulation, following resection and hemostasis. And the surgical step is brain shift correction and continue the procedure to the margins of the tumor, followed by resection and hemostasis. You see the borders, and this video is during procedure. You see the pointer, how we can define the borders. It's allow with the microanatomy knowledge, you can do the resection. And all the time you need to see the borders. No? So after there is this is a postoperative CT scan. And for me, there are an important phenomenon, I call it endoport phenomenon. When you put the endoport into the tumor or through the tumor and begin the resection, the pressure from the tumor mass delivers the rest of the tumor into the neuroendoport. So many people don't want to use neuroendoport, but actually when you put the neuroendoport, you can see how the tumor is coming into the neuroendoport. It's an important phenomenon. And you can do the whole resection without damage the rest of the brain. So this is all the presentation. Thanks for the invitation, and I'm grateful for this. Thanks very much. Thanks very much.
Thanks a lot, Professor Angel, for this excellent presentation. Is there any question from panelists?
Okay.
Okay, thank you, sir.
Thank you, Dr. Mori. Thank you.
Thank you. And now we will shift to next speaker, Professor Pascal Jabbour. Please, John, start playing his lecture.
Okay, I'm sorry, Sam, do I have it? Sam, do you have it or I have it?
Yep. You have it. I sent it, the link.
Oh, okay.
Okay.
I don't have it handy. I don't have it, Sam.
Okay. Unfortunately,
Can you tell me the link, or where's the link at?
Okay, I will send it to you again.
Okay, you send it, what's up?
Unfortunately, Professor Pascal have emergency travel today. That's why he can join us.
Everyone understands that.
But we can miss his lecture.
Okay. No, I never saw this before. Okay. Okay, let's start. Here we go. Oh, let me make sure I got the sound, Sam. Hold on. Sometimes I forget. Yep, I forgot. Okay, here we go.
Hello, my name is Pascal Jabour from Thomas Jefferson University Hospital in Philadelphia. I'm a neurosurgeon, dually trained in open and endovascular techniques. Thank you for the invitation to talk about clipping recurring brain aneurysms. Those are my disclosures. This is Thomas Jefferson in Philadelphia. This is the medical school, and this is our subspecialty hospital, a unique model of a subspecialty hospital. This is where we do all our vascular work, open and endovascular. Philadelphia is also the birthplace of the Philly cheesesteak. Those are the two competing restaurants. Each time I do an endarterectomy while removing the plaque, I kind of remember the cheese in the Philly cheesesteak from Philadelphia. We are also the city of Rocky. Those are the Rocky steps. Let's talk about some definitions first. What's a hybrid when we say I'm a hybrid neurosurgeon? Hybrid is an offspring of two plants or animals of different species or varieties, such a mule, right? A mule is a hybrid. It's the crossing of a donkey and a horse. One time I was doing a debate and they made fun of me. They said, you're a hybrid while mules are hybrid. Well, mules are known to be more patient, hardy, and long-lived than horses, and they are described as less obstinate and more intelligent than donkeys. So this hybrid mule got the best of both worlds from his mom and dad. What about the BMW i8? That's a hybrid car. It's better than a totally electric car, and it's better than an emission car. So it has the best of both worlds. So I think we should stop thinking that way, and we should all be fine with all what you see on the slide. If everyone is okay with everything you see on the slide, I think I would have, sent the right message from my lecture. There are different ways treating the disease. All those are complementary ways. They are not competitive. They don't compete. It's just choosing the best technique for the patient. And I think we should stop advertising for the tool and start advertising for the disease. We have the tools necessary to treat any disease. There are always questions to ask. One of them is, am I able to beat the natural history of the disease? And this, we can apply it on any disease. It can be applied on aneurysms. It can be applied on anything else. So very important to know our complication risk of any procedure and the natural history before offering a treatment. Not because I have the tool and the tool is available, I need to offer it every single time. Evolution in life is going to happen regardless if we like it or not. Homer evoluted, his body evoluted, his brain didn't, but it evoluted. And same thing with aneurysms treatment. How to choose the right tool. And sometimes it's easy and we don't have to think about it. Like this patient that presented with an acute subdural hematoma, she was found unresponsive with a blown pupil. In this case, I didn't have time to even go do an angiogram, just the CTA showing this oblong PCOM aneurysm. And then this patient went to the operating room right away for an aneurysm clipping and a decompression. And this is after the cranioplasty 3 months later. Another case of a big hemorrhage from a ruptured aneurysm. In this case, it was an MCA aneurysm. Again, I didn't have any dilemma in my mind what technique to use. This patient needed a decompression, a quick decompression, and the clip of the aneurysm. Here's the MCA aneurysm being clipped, the aneurysm being opened, temporary clip removed, another clip at the neck, and here's the intra-op angiogram showing a complete occlusion. Another case of a large PCOM rupture. Again, I didn't have to even think what tool to choose. It was obvious this patient needed to go right away to the OR, evacuate the subdural hematoma, do a decompression, and secure the aneurysm. And this is what I did in this case. That's a temporary clip on the ICA, and this is the permanent clip on the PCOM aneurysm. This is the intra-op angiogram showing the complete occlusion. This is the lateral view, and this is a unsubtracted view. And again, there's no dogma in there, right? I mean, this the other way around can be right also. By showing those cases, I'm just trying to show you that it can go both ways. This is a case of an interparenchymal hemorrhage. The patient was awake, wasn't herniating. In this case, we had time to take the patient, do an angiogram, and here it is. It was a narrow neck. I was able to coil the aneurysm, and then I brought the patient back up for a decompression because I knew that in 2 or 3 days they're going to have some edema, and I'm going to have to take the patient emergently. And then this is a long-term follow-up showing a complete occlusion of the aneurysm, and this is a cranioplasty later on. And then this is a paper from our institution showing that this is a feasible option. So innovation in open surgery is also happening. It's not only in endovascular. This is the exoscope that we're using more and more. And this is the voice recognition robotic arm of the exoscope. As you see, I'm clipping an aneurysm. I'm talking to the exoscope. To access. Pointer, point. Completed. 60. I'm asking the exoscope to zoom, and it's zooming with voice recognition. And whenever we think about clipping recurring aneurysms, we should think and look on each case what devices were used in endovascular to know how to plan it. You know, when you go to clip an aneurysm, you need to have access to the parent vessel. What if you know there is a stent in the parent vessel? This is a nice paper by Rocco Armonda and his team, where they looked at can a self-expanding aneurysm stent be clipped? And this is very important in case you have a stent in the parent vessel. And then they looked at it, and what they found is like old-fashioned stents used for stent-assisted coiling like Enterprise and Neuroform can be clipped, and they can take their shape, but a flow diverter like a pipeline cannot be clipped because once it's clipped, it's damaged. This is important to know. Showing how you usually see the coils in the subarachnoid space. And the coils would erode the dome. And this is the neck. It's very important to make sure before that there's enough room to place a clip. And this we showed that in our paper of clipping previously coiled aneurysms, because if you're at a point where you don't have enough space to place a clip, you should argue the indication that this patient needs any treatment or a clip if the recurrence is just a tiny neck. This is another pericallosal aneurysm recurrence. You see here the interhemispheric approach. You see the coils that they are always seen in the subarachnoid space, and then dissecting the neck here, and then placing a clip at the neck, making sure there is room for a clip. This is the ICG intra-op showing complete occlusion. And this is the intra-op angiogram showing 100% occlusion. This is a ruptured ACOM aneurysm, coiled with a good result, then came back with interstitial filling. And here it is. You see it's an there's an atheroma on the neck of the aneurysm. You see the coils. And then here's the aneurysm clipped. You see the intra-op angiogram showing 100% occlusion. And mainly in ACOM aneurysms, we looked at our series of ACOM aneurysms that were coiled and recurred. And this was just published online in Neurosurgery. The conclusion was, when we looked at our series, that clipping is the best option for retreatment in recurring ACOM aneurysms treated with coils. The study consisted of 463 patients that were coiled, and part of them recurred. And when we looked back at all the treatment modalities we used, either recoiling the ACOM or clipping it or stent-assisted coiling, the more durable treatment, the less complication was with clipping. That's why more and more we are more aggressive. Once an ACOM aneurysm previously treated endovascularly recurs, at that time the best way to go is to just go and clip it. Of course, if the patient is a good candidate for clipping. And those are the cases. We published this paper about clipping previously coiled aneurysm in 111 patients. And this paper, something important, we found that the risk is low, but the risk increases whenever you start pulling coils and opening the aneurysms. And you've all seen all those heroic movies of opening the aneurysm, removing the coils, pulling the coils to be able to fit a clip. We do not recommend doing this unless you really need to do it, right? I mean, it's at this point, if you have, as I said, a recurrence that's not big enough at the neck to fit a clip, well, maybe you should just watch this patient, because as soon as you move into start removing those coils, this is when your risk of intra-op stroke will increase. And this is what we showed in our paper. So it is safe if you have enough room to clip it. This is a 57-year-old female with a headache and with this PCOM aneurysm, ugly looking. We decided to treat this aneurysm with a web device. You see the stasis of contrast, which is a predictor of a good occlusion at 6 months. So this is the stasis of contrast. And then at 6 months follow-up, the patient recurred. We decided to go ahead and clip the aneurysm. And this was one of the first, if not the first, web clipping, web recurrence clipping. We didn't know what to expect. So it turned out to be, by now we have clipped many web recurrences, turned out to be that it is feasible to clip a previously webbed aneurysm that recurred. It's not as bad as coils, so the web is crushable. You're able to go with the clip and crush your web, and nearly you don't need to go and open the dome and remove the web. So this is the case. This is showing the after the web, this is showing the recurrence, and this is showing the intra-op angiogram after clipping the aneurysm. Another case of a PCOM aneurysm treated with web. This is the immediate stasis of contrast. Then this is the 6 months follow-up angiogram showing an here there's an even worse recurrence. At that time we decided to go ahead and clip it. You see here, this is the recurrence. You see the web, and then same thing. We went in with a straight clip and clipped the recurrence with no problem. The edge of the web is crushed and there's no issue and no impingement of the parent vessel. That's the intra-op angiogram showing the complete occlusion. This is a case where we wanted to do stent-assisted coiling, a fusiform dysplastic MCA aneurysm. Turned out that the stent went and then bulged in the aneurysm. We couldn't coil, we couldn't do anything. Tried to retrieve it, we couldn't. At this point, we went in and actually removed the stent. As you see here, we're pulling the stent. sorry. And then we close the arteriotomy, and that's the stent out. It's very important to not to make of a bypass a lost art. Again, rarely, less and less, not rarely, but less and less, we're doing bypass for aneurysms, because now we have a lot of endovascular techniques. But whenever it's needed, it should be done. Again, for Moya we're still doing it, but for aneurysms less and less. So especially in places where we are training residents and in academic programs, it's very important to keep the art alive, and it's our responsibility, dually trained neurosurgeons, to keep this alive. Use all the varieties of the clip. That's very important. You see this dysplastic MCA aneurysm where I used all those clips to be able to clip it. This aneurysm had calcification and atheroma on it. So as you see here, I had to stack all those aneurysms to avoid clipping. A straight clip would have occluded the MCA. You see the atheroma plaque here. So using all clip varieties is important. And this is here, I'm finishing all this construct to reconstruct. And as you see, those are the clips. This is exactly the construct I did when looking here. And this is the intra-op angiogram showing a complete occlusion and normal filling of both M2s before and after. Always keep an STA dissected in case you're gonna need a bypass, in case you shut down one of the M2s. Again, keep calm and clip. This is a case of a PCOM aneurysm. As soon as I clip the aneurysm, it ruptured. It's very important to, keep calm, has a full suction ready. In this case, I needed to go a little bit deeper. Always keep in mind adenosine in case you need to have a cardiac arrest for 20 seconds or so to be able to figure out what's clipping. In this case, all I needed to do is go deeper with the clip, and then it took care of it, but important to keep calm and know where the full suction is to be able to get it right away and use it. And here it is. I went a little bit deeper and then clipped the aneurysm. So some people would say if you're dual in trait, you cannot do both. You cannot be a good clipper. You cannot do a good endovascular job. Well, I say no, it's mainly how many clips you do. And here in our shop, we're still very busy clipping, and we still clip more than 100 to 150 aneurysms a year. So we published this paper on unruptured cerebral aneurysm clipping. We looked at the Medicare database of aneurysms clipped by only open neurosurgeons and aneurysms clipped by dually trained neurosurgeons. And we looked at the outcome. There was no difference in the 1-year mortality, no difference in the 30-day readmission, no difference in discharge to rehab or in the length of stay. Same thing, we have the same publication about endovascular treatment on aneurysms when the other side tell us that dually trained neurosurgeons cannot treat both. A lot of technological advances are happening. This is one of them, which is the contour device, which is like a funnel that you place at the neck of the aneurysm. I am the national PI in the US with my co-national PI, Dimitrios Lopez. This is one of the cases we've done. Very interesting device to treat previously cold aneurysms and recurrences. This case was I was going to clip it, but then looking back, it's going to be tough to dissect this M2. They're going to be big amount of coils here, and then I was able to treat it with the contour device. And this is the status of contrast. That's the contour device. Again, as I said, no dogma here, despite the fact that this patient was on my schedule to get clipped after this recurrence, but then we had this device and then decided to go less invasive and do it. It's a two-way street. I showed you how clipping can save endovascular recurrences, but also endovascular can save some clipping sometimes. Not only a two-way street, sometimes it's as complex as a roundabout. As you know, in Europe, there are so many roundabouts, and my wife always makes fun of me that I don't know whose priority is in a roundabout because it's very complex. So this is a 50-year-old female with an acute third nerve palsy. She had this ugly aneurysm with a fetal PCA. I decided to clip it. And then it has atheroma on it. And every single time I would clip this aneurysm, would do the intra-op angiogram, either the aneurysm is gone, but there's no PCA anymore, no PCOM, or I would readjust my clip and then there is some filling of the aneurysm, but the PCA is filling. So in this case, I decided to stop and not keep on going in and out. As you know, sometimes if you break a piece of atheroma, that's it, your vessel is shut down. And I thought to myself that, you know what, I turned this big neck aneurysm into a narrow neck aneurysm, and it's perfectly fine for me to go in and then just coil this small part without putting the patient at risk of manipulating multiple aneurysms, and also less risk than doing a bypass. So this is what I did. I called the aneurysm, and here it is. I have a 3-year follow-up angiogram on it with the part that's clipped, part that's coiled. This is a perfect, in my opinion, a perfect result. There's some neck here, but this is the takeoff of the fetal PCA. So at 3 years, it looks great. I did a service to the patient. I wasn't aggressive intraoperatively and caused any problem. And I used my both techniques to be able to treat the patient the right way. This is an ACOM aneurysm, dysplastic ACOM aneurysm with calcification. Every single time I would go and have a complete occlusion intraoperatively with the clip, it would shut down the contralateral A2. And then I had to stop with this result and with this with this dog ear or partial occlusion. Well, I took it, and what I did, I placed a stent and coiled the rest. And here it is. This is how it looked like with I transformed an aneurysm from a wide neck to a narrow neck. And then this is a 5-year follow-up angiogram, complete occlusion with a stent and coil and the clip. For this aneurysm. 63-year-old, subarachnoid grade 3. This is a patient that long time ago was treated with a clip. The patient had a 9/7 ACOM aneurysm that ruptured, that was clipped. This was done way before I started practicing. And then a 5-year follow-up angiogram was done on the 9/7 ACOM aneurysm. That was the 5-year follow-up angiogram, showed the complete occlusion. And then 15 years post-clipping, the patient comes to me with a CTA showing a big recurrence. You see here, that's the recurrence. In this case, I mean, this patient had a history of subarachnoid hemorrhage, had a history of a clipping. I'm gonna go in, dissect all that. It has a high risk with a previously clipped aneurysm. In this case, I decided to go with a flow diversion and place a flow diversion to treat the aneurysm. In my opinion, this was the lowest risk option. So as you see here, I went and placed the flow diversion all the way here. And then here's the stasis of contrast in the aneurysm after flow diversion placement. That's the stasis of contrast. And then 6 months follow-up angiogram showing complete occlusion of the aneurysm. I think it's time for neurosurgery to learn from the airline industry by, you know, doing double and triple checking and doing more and more simulation to treat aneurysms. This is one of the examples of simulation for pre-sigmoid approach that we make our resident practice on it, where they go and drill. They have a beep sound if they hit the facial nerve, if they hit the sigmoid sinus. And those are simulators training our residents for endovascular technique. Regardless of the technique you use, it's a match between you and the technique and the device and the procedure. And it's exactly like Match.com. It's like relationships. You get to know each other, you and your date, and you and your technique, and you and your device. You get to anticipate the reaction to your action. You get to learn to avoid embarrassing situations. You get to know how much to ask and what to expect, and avoid pushing to a nervous breakdown. Try to follow the rules, you know, like this guy is breaking every single rule, right? And then try to learn from our own mistakes. That's very important. Have the insight. If we learn from our mistakes, we avoid having problems in the future. Like this sheep here went in and same mistake, jumped back in the in there. So this is all what I wanted to tell you. Thank you very much for the invitation, and hope to see you soon in person.
Thanks a lot for this excellent presentation. And now we will shift to final last speaker, Professor Neil Zinanon. Please start sharing your screen.
Good afternoon. Thanks for this kind invitation. It's a great pleasure to be here and share some knowledge about hip endymoma. How many times do you need to operate these patients? And some words about classification and management. Focus on pediatric ependymoma. This tumor is considered a rare tumor, but we need to remember that less than 2/3 of them will still alive after 10 years. And if we see about age, 80% of them are below 8 years of age and correspond more or less 5 to 10% of childhood brain tumors. And the question about relapse is involved half of these patients. And if we compare adult ependymoma and pediatric ependymoma, childhood have a worse prognosis on the same pathology. And about the location, adults and pediatrics ependymoma, we see infratentorial in children, more than half of them, and adults is more than 60% on the spinal cord location. And on histological point of view, we may consider 4 subtypes preferentially. But we have now molecular biology showing that we may have more than 9 subsets. But if we consider only pediatric, we have YAP1 and RILA in the supratentorial and A and B in infratentorial location. For those that are intraspinal, like we see here, they correspond more or less as 60% of all intradural spinal tumor. And on MRI or CT scan, supratentorial ependymoma can be small tumors or giant tumors, but usually they have some regular shape, but not necessarily. When we go to the grade 4 tumor, the anaplastic one, they are usually more irregular, and also the contrast enhancement is not regular one. On the posterior fossa, to differentiate between medulloblastoma, astrocytoma, and teratoid rhabdoid tumor, we usually can have a lateral invasive tumor, like we saw on this MRI, posterior fossa tumor invading the lateral image. And about the survival rates, if we see here on the 60s and 70s, it was less than 20% 5-year survival rate with only surgery. Now, with a gross total resection and multidisciplinary team, we increase this survival a lot. If we consider 5 years survival rate, after complete resection, we can achieve 80%. And considering that pediatric patients a little bit less than adult patients, talking about ependymoma. But this survival curve, progression-free survival, it's very important to see if we don't leave in place residual tumor with residual tumor, we have a very best survival rate with no residual tumor in place. Try to be the most gross or total resection without harm the patients and try to improve the survival. How we can define the quality of our resection based on Merchant paper? Gross total resection is neurosurgical judgment macroscopically, but also no evidence of residual tumor on MRI. Near total resection is if we left in place less than 5 millimeters residual tumor in the greatest dimension, and subtotal resection, all the other cases. The standard therapy today is near total resection or gross total resection, followed by radiotherapy, except for very young children. Some papers below 3 years and other papers below 5 years. But if we are talking about efficacy, we need to see that if we delay radiotherapy, we have less prognosis, like we see here. If our radiotherapy starts less than 15 days, we can have 86% of 5-year survival rate, and more than 15 days, the decrease less than 50% survival rate at 5 years. And about chemotherapy, we have very heterogeneous answers. We can have the range between 20% and 8% response for different protocols. We have North American protocols, Europe protocols. There is some difference between them, but our standard protocol try to achieve is try to see if you achieve total resection, but if there is a residual tumor there, and if it's possible, go back and try to resect the tumor before radiotherapy. And just 2 cases. The first one is a 13-year-old boy with a 15 days history, strabism and diplopia, bilateral papilledema, before surgery and after surgery. In intraoperative feeling, it was total resection for us, our impression. But on the MRI postoperative, we saw here a very small residual tumor. We discussed with our oncologist and we tried 2 cycles of chemotherapy. It was ependymoma grade 2, but it doesn't move. And we decided to reoperate and try to eliminate this residual tumor without harm the patient. With intraoperative guidance, with neuronavigation, it was possible to goes back in the posterior fossa and reach the residual tumor to take out. The pre-op operation and post-op reoperation MRI. The first operation before it was here, the second in the middle with this residual tumor, and at the end without tumor on the back. Our question for these patients is still this image in the CP angle. It was there, this residual since the beginning, or it's a new lesion? And if we consider more than 5 years follow-up now, the residual lesion is still there, still stable, and the patient is absolutely normal, just ending his university studies. The second patient is ependymoblastoma anaplastic 1, 3-year-old boy, 2 previous operation, and VP shunt also, normal neurological examination after chemotherapy, and radiotherapy also at 33 years old. And became now with this question: we have this invasion on the brainstem. We know previously that it wasn't primarily brainstem tumor, it was posterior fossa 1. And the question was, try to go there or only palliative care. The boy was fantastic, absolutely normal neurological examination after the 2 surgery. And after a multidisciplinary discussion team, we decided just to go in and try to empty. It was radiotherapy. We see here the anatomy very difficult to separate the structure. And our decision, it wasn't took away all this tumor, but it was only give some place for some more time for this anaplastic tumor. And it was possible with a small and careful open this residual tumor that invades the brainstem. And we just decided to empty piece by piece. And at the end, it was possible to have some place there. And with the ultrasound aspirator, we can empty a little bit more. And we give some more months without arm these patients additionally. And complications need to be in our mind is related to location, infection, meningitis, CSF fistula, seizures. We need to have in mind when we decide to operate this child. But try to answer the topic question. How many times do you need to operate? Keep in mind Hippocrates' principle, do not arm. We need to preserve quality of life. Ependymoma is, the outcome is related to surgical procedure, and we operate how many times the patients need to receive for us. And my gratitude to my mentor, Professor Schutz, and thanks a lot for your kind attention and your time.
Thanks a lot, Professor Zenon, for this excellent presentation that we have enjoyed it a lot. Thanks also because you have given us this lecture after a long day of work.
Yes, thank you.
Is there any question from panelists?
Congratulations for your organization.
Thank you, sir. Thank you. It was a great celebration benefiting our reputation of Academy, which we have built up for 6 years. And we have reached the end of this day, and we will see you tomorrow, the same time as today.
Sam, could you go over the schedule tomorrow? Could you go over what we're doing tomorrow, please? Can you do it? You want me to do it? You want me to do it?
You can do it.
Yeah. Okay. Let me get the. Just give me a second. Let me get it up here. Yeah, we have a full schedule tomorrow. A lot of talks. Let me just share the screen, Sam. Just give me a second here. Okay.
There are some modifications also. I will make it and upload it on our groups.
Okay, Sam, could you go over that, please?
Yes, we will start at we will start at 1 p.m. KO, and it will extend till 11 p.m. clock.
Okay, if you want to see the schedule, you can go to the first page of Neurosurgical TV. The schedule is on there. So you don't have to go through the same thing, the whole thing, Sam. It's been a long day.
Okay. One more notification about our ambassador If you are interested in, please send your CV on this email. Okay, thank you, John.
Okay, we'll see everyone tomorrow. See you, Ahmad. See everybody. Thank you, Nelson. Thank you.
Bye-bye. Thank you.
Thank you.
Thank you, Nancy.
Thank you.
Goodbye. شكرا دكتور. ميرسي.
That was a long day, Sam.
Yeah, we had a lot of changes and emergencies.
Yeah. Well, it's good having those extra.
We handle it.
Yeah, it's good to have Pascal. You know, I didn't want to do it, but it's good to have it. You know, probably at every conference, it's good to have something like that around so you can use it. You know?
I was caring to be alive, but to attend live, but unfortunately he is in long trip to America. That's why he couldn't join us.
But you know, Sam.
We will get him back again. We will not finish it with him.
But you know, Sam, I was interviewing people in Bogota live. We were, they were in breaks.
Bogota also make a lot of changes for our schedule. But thanks to God, it was a great celebration that we all are proud of. And I think tomorrow will be more interesting.
Okay, we'll see. But you know, after watching the webinar in Bogota, it wasn't full. I don't think many conferences will be full. But I really think that people will go back to conferences. They'll like it a little bit, but then they'll come to the realization was, you know what? I could have done this at home from my desktop. I didn't need to come to Bogota. It's a beautiful trip and everything, but you know, I really think there'll be a backlash against in-person conferences. I really think people will say, hey, we don't really need to go here.
I think it was more beneficial if it was hybrid. Unfortunately, the committee didn't approve that. Okay.
Yeah, definitely, for sure. I think they're going to have to. Bogota didn't have. I was surprised. They didn't live stream it. They could have easily done it with just a webcam and a laptop, but I guess they just wanted to do pure in person. But I don't think they're going to be as popular as before going to conferences. But we'll see.
All of us as human, we need to meet each other in person. It's a nature.
I don't know. I don't know if you need the in-person contact so much. I just want to stay home and spend the money.
For me, I need to meet everyone in person. But unfortunately, not all of us can accommodate this all that cost. That's why we will consider in our progress to be hybrid, to be available to everyone.
Well, I'm going to make a bet with Omar. I'm going to make a bet, Omar, that in-person conferences will not be the same. I think they're going to be changed, and not as many people are going to go. Now that they've seen what they can do, once they see the value, I think the educational value that they get. I don't know. I could be wrong, but we'll see. We'll see. But I'm going to make a bet, Omar. How much should I bet?
Very, very nice webinar. Thank you, Dr. John and Dr. سامح. Very nice. شكرا دكتور سامح كثير لك وتحية لمصر الحبيبة.
شكرا جزيلا دكتور عمر.
You guys speak Arabic, right?
قعدت 11 ساعة ده.
Is anybody else on the floor that wants to say hello?
Okay.
There's a bunch of people still in, or not a bunch.
Can I go, Dr. Sam?
Yeah, Omar, thank you for coming.
I have something.
I'm just going to hang around. If anybody wants to chat. Anybody want to meet Sam?
Thank you. Assalamu alaikum.
Alaikum assalam.
Does anybody want to meet Sam?
Dr. Zainab.
Yes, sir.
And son.
It was really wonderful and great being here. It's just that it has been a long day, but then it really worth it.
I think tomorrow will be more longer.
Zainab, is your camera working or it's not working?
I think it is working. I can try.
Yeah, try it. Try it.
Okay.
Yeah, is Hisham, are you still there? Anybody else still there? We're off the air. Oh no.
Yes, I'm